Hi everyone, very good evening to all of you. Yes, everyone. Yes, good evening, good evening. I can see the chats here. Yes, good evening everyone, good evening. और हमेशा की तरह थोड़ा सा लेट हो, okay. As usual, okay. Yes, I'm good. चलो ठीक है, I can see your chats here. Yes, all of you बताओ कैसी तैयारी चल रही सबकी? हेलो सर, केम छो? भालो बात छे एकदम चलता है. अच्छा है, very good. ये बताओ, so far see, yes, so now we are going to start with the rapid revision of psychiatry. So now you tell me, have you revised psychiatry completely? एक बार पूरा revise किया, all of you? एक बार, at least for one time. Like in the different colleges, I have completed psychiatry in detail, right? So now we are going to have only rapid revision. The most important topics we are going to revise, we are going to learn. And from, see, especially those topics, I will be emphasizing where like so many questions are being framed, right? Yes, चलो ठीक है, कोई बात नहीं. डॉक्टर सैयद आसिफ सर, आप क्रिकेट पे कमेंट्री करो. अच्छा, आपको हर्षा भोगले दिख रहा हूं मैं, हैं? अच्छा है, करेंगे, भाभी करेंगे. आजमी एकांत में किया था. ऑलराइट, ठीक है, चलो फाइन. सो लेट्स स्टार्ट. सी हियर, फर्स्ट ऑफ ऑल आई एम गोइंग टू शो यू ऑल द चैप्टर्स. सी हियर, नाउ फर्स्ट ऑफ ऑल यू टेल मी how many questions you are expecting from psychiatry. How many questions you expect in upcoming FMG exam? See here, these are all the chapters which I am showing you. How many questions do you expect? As per blueprint, you will say, sir, 5 marks. As per blueprint, you will say 5 questions only. But remember here, these days there is a changing pattern now. Last time, see, exam was very difficult. Right now, last time exam was very difficult. Do you know how many questions they have asked? Last time they have asked, in psychiatry, they have asked 13 questions. 13 questions. So now you will ask how. So first of all, let's understand which chapters are most important, where you are going to invest your time, right? Okay, fine. This time, INI-CET, they have asked 7 questions. See, NEET PG, 8 questions. Last time, FMG question, 13. Before that, 9 questions. So, on an average, I expect minimum up to 10 questions in psychiatry. Let's understand how. First of all, these are psychiatric topics. From here, I expect 6 to 7 questions. From here, I expect 6 to 7 questions. 6 to 7 questions, these are going to be the direct questions. How to diagnose schizophrenia, how to diagnose depression, mania, mood disorders, substance abuse, right? Now, see, like the pediatric psychiatric disorder, after sleeping disorder, eating disorder, anorexia nervosa, bulimia nervosa. These are actually direct questions, all right? But the most important thing which most of the students are leaving, remember here, most of the students are not emphasizing, that is actually what? Psychopharmacology. Psychopharmacology. See here, from here, I expect 5 questions. I am telling you, 5 questions from psychopharmacology, antidepressant drugs, mood stabilizer drugs, antipsychotic drugs, treatment of schizophrenia, treatment of mania, treatment of sleeping disorder, treatment of eating disorder, side effects of antipsychotic drugs, side effect of antidepressant drugs. So psychopharma, I'm telling you, extremely important. Please revise it well. I will be covering all the new medicines which have recently approved right now. So psychopharmacology, I'm telling you, 5 questions minimum. Last time in MCR, last time in FMG, they have asked 13 questions. Out of 13 questions, 7 questions were related to psychiatry, direct psychiatry, and 6 questions were related to psychopharma questions, right now? So yes, So we have to emphasize on psychopharmacology more this time. So first of all, now you see here how many questions we can expect from different, right now, from different chapters. First of all, most important chapter is general psychiatry. Most important chapter is always general psychiatry, where we are going to learn about mental status examination, basic definitions. Do you expect that? See, suppose if they are going to ask you 6 questions in psychiatry, means 100% only psychiatry question. 1 question will be one-liner. 5 questions will be big. You have to decode the language. So see, from general psychiatry, we are going to learn about delusion, hallucinations, right? Delusion, hallucination, mental status examination, all in neurotransmitters, dopamine, serotonin. So from first chapter, general psychiatry, you can expect 2 questions for sure. 2 questions for sure. See, schizophrenia 1 or 2. Substance abuse, minimum 2 to 3 questions. Minimum 2 to 3 questions substance abuse. And in substance abuse, most important is alcohol. And can you tell me what is the most important topic? Yes, what is the most important topic in substance abuse? डॉक्टर शिवरम, ये साइकोफार्मा कराऊंगा, बहुत अच्छे से मैं कराऊंगा, राइट? यस, डॉक्टर ज़ैनब, डॉक्टर पुष्पेंद्र, ऑल ऑफ यू. यस, वेरी गुड. आई एम ग्लैड टू सी ऑल ऑफ यू. यस, I can recall some of your names. Okay, different college. Yes, Dr. Mizanur Rahman. Yes, Dr. Raman Saini, Dr. Lokesh, Dr. Amit. Yes, Dr. Divya Reddy. Yes, Dr. Vijesh. Yes, very good. All of you. Yes. In substance abuse, most important topic is alcohol. In the alcohol, what is the most important topic? Can you tell me? Any kind of delirium? Are you able to recall? Can you answer me? Which one? Which delirium? बोलो, आंसर करो. Delirium tremens. Most important. Second most important, Wernicke's encephalopathy. Remember here. Fine. After that, mood disorders. If you see the question of last time MCI question, no, from mood disorders means what? Depression and bipolar disorder. Last time FMG, only from depression they have asked 3 questions. So on an average, from mood disorder, we can expect minimum 1 to 2 questions. Yes, after that, neurotic disorders like anxiety, phobia, panic disorder, PTSD, OCD, 1 question pakka from here, 1 question from here, and somatoform disorder like somatization, hypochondriasis, factitious illness. So in total, 1 to 2 questions from here. See, sexual disorders will be covered in psychiatry also, forensic also. Do not leave paraphilia. From sexual disorder, minimum 2 questions. Minimum 2 questions you can expect. I'm not saying 100%. No one can say. Expect, because sexual disorder will be covered in psychiatry also and forensic also. Paraphilia, sadism, masochism, lust, murder, right? See, I have taught you everything in detail. So see here. Sexual disorders, see, in psychiatry, these days, so like in the upcoming exam, I can expect 1 question related to the management, related to the medicine, new drug. Okay. Eating disorder, anorexia nervosa, bulimia nervosa, very important. Child psychiatry, autism and ADHD. Psychoanalysis, last time 1 question. Sleep disorder, narcolepsy and all. Personality disorders, I expect 1. Remember here. And organic mental disorder will be covered in neuromedicine also, right? No, like delirium, dementia, amnesia, Alzheimer's, Parkinson's and all. So see here, now when you see all these chapters, now you can have more clarity where to spend more time. Again, I'm telling you, psychopharma, no one is going to leave. Psychopharmacology. Even when you are revising pharmacology, CNS drugs, please revise it well. All right, chalo, let's start. Yes, very good. Dr. Kaushar Alam, you are asking, sir, please tell about psychosexual stages of development. Obviously, I'm going to cover this topic in psychoanalysis chapter. Okay? Now, let's start the session. Fine. So we are going to start with rapid revision of entire psychiatry, complete psychiatry. Okay? Less question, more revision, more topics. All right? Chalo, fine. First of all, general psychiatry. See here, Overall, we know the basic things here, that the basic point what we have learned, that most important neurotransmitter related to psychiatry is what? Dopamine, serotonin, norepinephrine, acetylcholine. Fine. Now you tell me, see, basic thing, whatever we have learned here, that increased level of serotonin, norepinephrine, and dopamine in a limbic system will cause what? It will cause what? Psychotic symptoms, or person will become hyper. And in the same manner, decreased level of these neurotransmitters will cause what? Decreased level will be causing what? Depression. So can you tell me some of the functions of dopamine? This will be covered in your physiology. Please remember here, physiology, don't expect direct question. Physiology will be integrated with neurophysiology, psychiatry, medicine, everywhere physiology will be there. So can you tell me some of the important functions of the dopamine? See, we are going to have revision here. Can you answer me? All of you, please write down in chat box. What are the functions of dopamine? Dopamine का functions बोलो. Dopamine क्या काम करता है? What dopamine does? I've explained you in detail, right? Can you answer me, all of you? Remember here, whenever you abuse any substance, bhang, ganja, hashish, cocaine, whatever you want, right? No. After that, you are getting kick, no? Kick because of what? Because of dopamine. So first of all, dopamine is responsible for kick. Dopamine is responsible for kick. After that, you are enjoying, no? Right? After that, you are enjoying after abusing bhang, ganja, right? Cannabis, I'm talking about, right? So see here, dopamine is responsible for reward, for pleasure, and even for addiction, right? No, even for addiction. Remember here, serotonin is responsible for, please remember, serotonin is responsible for good food, good mood, and good sleep. That's why it is called as what? Happy hormone. Now if I have a patient, 21-year-old female, she is saying what? Sir, I do not feel good. I'm not eating well. I'm not sleeping well. For last 1 month, I'm having some negative thoughts also. So can you tell me the diagnosis? Now I have taught you this much that you can easily answer. Yes, this is a case of what? Depression. This is a case of depression. So do you think in the depression there is what? Lack of food, lack of mood, lack of sleep, and some other symptoms, right? Okay, fine. So do you think in the depression there is a deficiency of serotonin, right? Deficiency of serotonin. So do you think to treat depression I should be giving a medicine which is going to increase the level of serotonin? Do you think I should be giving SSRI? Yes, selective serotonin reuptake inhibitor. Easy to understand. Whenever I'm going to give SSRI, this is going to increase the level of serotonin. Very good. Now, without seeing the notes, please write down in chat box minimum of 5 SSRI drugs. All of you, please write down. सर अमित आनंद का शादी हो रहा है, विश हिम गुड फॉर द न्यू लाइफ. वेरी गुड, बहुत बहुत मुबारक हो आपको, है ना. लेकिन अभी फोकस करेंगे हम लोग FMG. ओके, चलो ठीक है, शादी मुबारक हो, बेस्ट विशेस, wherever you stay happy. I think Dr. Amit, right? चलो great. Okay, fine. चलो all of you, please write down at least 5 SSRI. 5 SSRI. लिखो. Yes, very good. See here. Yes, first of all, most important is what? Fluoxetine. See here, I will be writing some drugs. Please keep on writing. I hope all of you have received the notes also, right? PDF is shared, right now? PDF is already shared. Keep on using. Please write down, okay? Fluoxetine. The PDF is already shared in the Telegram group. Link is shared in the chat box here. I can see here. Yes, very good. Fluoxetine, escitalopram, sertraline, dapaxetine, and paroxetine. minimum 4 to 5 drugs of every class you should be able to recall. Okay, examiners can write the name of fluoxetine, escitalopram, depoxetine, right? No, paroxetine. Okay, fine. So now, if I can increase the level of serotonin, I can treat depression. Remember here, these days, SSRI, this is the drug of choice for depression. Drug of choice for depression. Okay, very good. Okay, chalo, fine. Now, serotonin, you can understand in the easiest language, I can say that serotonin is what? Serotonin is what? Happy hormone, right now? Dr. Shri Niket Kumar, very good, very good. Okay, chalo, fine. All right. Now you tell me, see here. Now, what about norepinephrine? What about norepinephrine? Norepinephrine, this is responsible for alertness, for arousal. Alertness and arousal. My question is that if I have a patient of depression, I have started my patient on SSRI, and even after that, if there is no improvement, see here, norepinephrine is responsible for what? Alertness and arousal, no? Alertness and arousal. So you would have seen depression patient also, no, every time. No, like this, no, every time like this. No alertness, no arousal. So do you think apart from serotonin, I should also be increasing the level of norepinephrine? Yes or no? Answer bolo. Yes, right now. So now if my patient is not improving, now apart from serotonin, I should also be targeting for what? Norepinephrine also. So now do you think I can start my patient on SNRI? Yes, serotonin, norepinephrine, reuptake inhibitor. This will increase the level of both. So can you tell me at least a few examples of SNRI? Please write down in chat box. I can check here. Please write down in chat box, all of you. Very good, Dr. Kanu said, Dr. Momina, very good. Okay, fine. Please write down. Dr. Shubham Verma, can you please share PDF instead of PPT? I think PDF is already shared in the Telegram group. Please check there, right now? Yes, okay. So 2 SNRI like venlafaxine. Remember here, like venlafaxine and desvenlafaxine. Venlafaxine and desvenlafaxine. Venlafaxine and desvenlafaxine, these are 2 SNRI. 2 SNRI. The question is that why I'm teaching all these drugs? Remember here, these days, mostly they are asking the questions related to the management of psychiatric patients. Okay, no, so we should know all this. My question is that when will you take a decision that you are supposed to start the patient on SNRI? Direct question. When will you take a decision that you should start your patient on SNRI? Please write down in chat box. Remember here, whenever you see that patient is having what? Lack of drive, right? Lack of motivation, lack of energy, Right now, if a depressed patient is saying what? I don't want to do anything in my life. There is no motivation and all, right now. So remember, when there is a lack of energy, lack of drive, lack of motivation, then please choose SNRI. Increase serotonin also, norepinephrine also. I hope all these points are clear to all of you. Now, last one here is what? Acetylcholine. Last one is what? Acetylcholine here. Acetylcholine. So can you answer me? What is the function of acetylcholine, all of you? Function of acetylcholine. Whenever you smoke a cigarette during the break, during class break, when you smoke cigarette, after, see here, when a faculty will be taking class for 2 hours, after that you are very much, silent, lack of energy, lack of attention, lack of concentration. During the break, when you smoke a cigarette, what is your condition then? After that, you are having good attention, good concentration, good judgment power, good mathematical ability, right? A good mathematical ability, very easy to understand. So what does it mean? What is there in the cigarette? What is there in the cigarette? What cigarette is going to stimulate? Can you tell me? See, there is what? Tobacco. There is what? Nicotine. Nicotine is especially going to stimulate 2 neurotransmitters. One is a dopamine. Second is acetylcholine. Because of dopamine, you are getting what? Kick. Because of choline, acetylcholine, you will be having what? Good attention, good concentration, good judgment power, good mathematic ability, good learning ability, good memory power, it means cigarette is good, right? See, so many benefits, no? Eh? You can say what? Acetylcholine is responsible for what? Right? Good attention, good concentration, right? No, attention hormone. Acetylcholine is what? Attention hormone, right? Attention neurotransmitter, you can say like that. Remember here, see here. When I say like this, no, acetylcholine is good for attention, concentration, judgment power, it means cigarette is good. Don't take it seriously. See, I was taking class somewhere, right? So I say the same sentence, like sarcastically. One student met me during interval. He told me, sir, because of you, I started it again today. Come on, don't do this, okay? More than 50% of the world's tumor, right now, that is because of tobacco. It means cigarette is bad. I have to be very much specific, remember. Now, one more point here that acetylcholine is, see, this also helps in, this also enables muscle action, enables muscle action. Here, if I have to integrate about acetylcholine with any clinical part, which one? What about Alzheimer's? Do you think in the Alzheimer's disease there is what? Degeneration of neurons producing acetylcholine? Remember? Yes, very easy to answer. Please remember all these points, right? Okay, fine. Okay, so now you tell me, see here, so we have learned about SSRI and SNRI. Two classifications we have completed. Remember, you have to memorize the name of drugs. Keep in mind. Okay, fine. Now see here, now, okay, now see here. Last time MCI question, they have asked, there was the difference between organic mental disorder and non-organic mental disorder. This was the question I'm telling you. Last time, this year only. So so January 2023 question. First question, how to differentiate organic and non-organic mental disorder. Remember here, see, first of all, see, in the class also, I've given you the example that if there is a patient after road traffic accident, you are getting, right now, where patient is having what? Very good. Yeah, this annotated PDF will also be shared. Okay, don't worry. This will be shared. Okay. Okay, fine. So see here, after road traffic accident, if you see head injury, are you going to do CT scan or not? Yes. So what is the investigation of choice here? What is the investigation of choice? NCCT is the investigation of choice in a case of acute head injury. Remember here, in this patient, you can say like this patient is A. In this patient, if you do CT scan, you can see some changes or not. You can see some changes on CT scan. Yes, if you can see some changes, it will be called as what? Organic disorder. Basically what? If there will be some medical cause, on a radiological investigation, can you see some changes in brain parenchyma, damage of brain parenchyma? Yes, damage of brain parenchyma. This is called as organic. If we have one more patient, patient B, who is actually a medical practitioner, who is standing in operation theater on the 4th floor, he looks very much fine, perfectly fine. Suddenly during this surgery, he is asking the nurse, Sister G, why this buffalo is singing a song for me in operation theater? Hey, come on. In operation theater, huh? Buffalo singing a song, huh? Auditory hallucination. Very easy to understand. Now if you do CT scan, can you see some changes in brain parenchyma? Obviously answer is what? No. No changes, mostly no changes in brain parenchyma on radiological investigation. Now this will be called as what? Non-organic mental disorder. Also called as what? Also called as functional mental disorder. Very easy to understand. At the same time, if I ask you, what about Alzheimer's disease? If you do CT scan, can you see some changes in Alzheimer's disease? Can you answer me? After neuromedicine, all of you, please write down. जल्दी लिखो. What changes? Write the change. Yes, cerebral atrophy. Alzheimer's disease. Remember here, Alzheimer's disease, you can see what? Cerebral atrophy. So on CT scan, I'm able to see some changes. No. So Alzheimer's will be considered as organic disorder, non-organic disorder. Answer is what? Organic disorder, very easy. At the same time, Alzheimer's will be seen in old age or young age, obviously old. So remember here, organic mental disorder mostly in old age, but non-organic. Remember here, most of the psychiatric conditions are what? Functional, non-organic. Psychiatric conditions will be starting in young age, right now, young age. Always keep in mind that for organic mental disorder, some medical causes will be there for sure. Some medical causes will be there for sure, but not non-organic, not necessarily, right? Okay, fine. So what are the examples of organic mental disorder? First of all, remember delirium and dementia. Delirium and dementia. Do you think there can be a clouding of consciousness or disorientation to time, place, and person in organic mental disorder? When I talk about delirium, answer is yes. Delirium, what is happening in the delirium? In delirium, sudden onset of symptom. Disorientation to time, place, and person. So I can say that, yes, there can be what? Clouding of consciousness. Clouding of consciousness. Yes, it can happen in organic, but non-organic, person will be well oriented. Person will be well oriented. Okay, fine. My dopamine is also here. Continue. Now, so remember here, sometimes examiners will be writing different terms. Clouding of consciousness, disorientation to time, place, and person. Right now, disorientation to time, place, and person. Altered sensorium. Asan bhasha mein, mental confusion. What is the meaning of disorientation to time, place, and person? After head injury, if a patient is getting admitted in your emergency department, and if you are wearing a white coat, patient is asking you, hey, are you Sanjeev Kapoor? Are you a chef? Hey, what kind of shopping mall is this? Huh? No music, no lighting. Oh my God, it is day or night. What does it mean? Patient is disoriented. Remember, disorientation can occur in organic, not in psychiatric. Schizophrenia patient will be well oriented. Easy to understand. Depression patient will be well oriented. So here example I can write down: schizophrenia, depression. Yes, these are what psychiatric condition. These are non-organic, right? Now, where will you see neurological deficit? Obviously in the organic, not in the non-organic. Hallucination can be seen in both. But what is the most common type of hallucination in organic? Visual. Keep in mind, one-liner question. But in psychiatric condition, most common is what? Auditory. Most common is what? Auditory. Most common is auditory. Overall, most common type of hallucination is which one? Overall auditory. Overall auditory. Out of these two, which can be acute? Can you write down, all of you? Organic or non-organic? Very good. Remember here, delirium is what? Sudden onset, acute. So organic is acute and non-organic is never acute. Remember here, psychiatric condition, it will take so much time. It will take very much long time. Psychiatric condition, okay, now see, schizophrenia will take many months, many years to develop, right? No, so remember here, non-organic is never acute. This will be what? Chronic, or you can say what? Very slow and slow progressive disease. Asan bhasha mein, in the easiest language, I can say organic disorder. This is the disorder of brain, and non-organic, this is the disorder of mind. So can you answer me the question what they have asked last time in FMG exam? Which of the following is not a sign or symptom of medical cause of psychiatric condition? Basically, organic disorder. Patient, like examiner has asked. Option number 1, old age onset. Option number 2, clouding of consciousness. Option number 3, acute onset can be there. Option number 4, auditory hallucination will be more common. Can you answer me, all of you? Jaldi, fast. Yes, very good. Right now, see, auditory, right now, because see here, more common is what? Visual hallucination. See here, See, the topic which I have explained you here, now the topic which I have explained you, this is a very easy topic, but you can easily get confused. But the table which I have shared here, remember here, from the basic things also they are asking the question. Now do remember here that non-organic mental disorder is further divided into two: psychotic condition and neurotic condition. Psychosis and neurosis. How to differentiate psychosis and neurosis? This is the favorite topic of MCI people. Very, very easy question. One-liner question they are going to frame here, right? Okay, fine. Okay, suppose if I have a patient A and patient B. Patient A is suffering from what? OCD of contamination. OCD of contamination means what? What is the full form of OCD? All of you? Obsessive and compulsive disorder, right? Obsessive and compulsive disorder. OCD of contamination, where a person is having what? Uncontrolled thoughts, right? Now, where a person is having what? Uncontrolled thoughts. That what? Hannah, your hands are dirty, dirty, dirty. Wash it, wash it. He knows that these thoughts are irrelevant. These thoughts are senseless. So do you think patient is aware about his condition? Yes. Patient knows that these are irrelevant thoughts, and I'm wasting so much of my time, my energy, and my money, right now, and I'm suffering from a disorder. So I can say that patient is aware about his disease. Awareness about disease is called as what? Can you answer me? Bolo. Awareness about disorder is called as what? Insight. It is called as what? Insight. Insight means what? Okay, remember here, insight means what? Awareness about disorder. Awareness about disorder. Very, very important. You should be knowing this. Awareness about disorder is called a what? Insight. Remember here, if insight is present, it is called as neurotic psychiatric disorder. Neurotic disorder means patient knows that he is a patient. Patient knows that he is a patient. उसको पता है कि वो बीमार है, उसको पता है कि वो patient है. That is called a what? Insight is present, right? Okay, fine. But what about patient B, who is suffering from delusion of grandiosity? Same example I will give you, which I used to give during my class. After watching Bahubali movie, a person starts behaving like Bahubali. I am Bahubali. When other people are saying, hey, you are just a common man. Shut up. He's saying, shut up. This is my Maheshmati. Now you tell me, do you think he knows that he is suffering from a disorder? No. Insight is absent or present? Insight is absent. Insight is absent. When insight is absent, it means what? He is suffering from a psychotic disorder. Psychotic disorder. You cannot take a chance to forget this word. This is what? Insight, insight, insight. Very, very important. Very, very. Right now? Okay, fine. Now the question is that OCD of contamination patient. Now OCD of contamination patient, whenever he will be using, suppose like if a patient OCD of contamination, whenever he is going to use public toilet, he can see that many people are standing in the queue. 5 people are already there. He will take a decision. Okay, let them wash first. I will wash in the last, because if I start now, there will be the biggest line in the history. So do you think his reality testing is, do you think his judgment power is normal or abnormal? See, judgment power is what? Normal. Do you think he is intact with the reality testing? He understands what is happening in and around? Yes, reality testing is also normal. But what about psychotic disorder? Remember here, judgment power, reality testing, both are, remember here, both are abnormal. Both will be abnormal. Delusion and hallucination. Delusion and hallucination, these two are psychotic symptoms. Delusion is a disorder of thought, and hallucination is a disorder of perception. Delusion and hallucination, these two are psychotic symptoms. So these are present in psychosis, absent in neurosis. Now when I talk about the personality, You tell me, personality will be preserved in psychosis or neurosis? Personality means what? Shirt, pant, well grooming, right now, so well groomed. Personality is normal or preserved. Personality is preserved in neurotic disorder, and personality is disturbed in psychotic disorder. So now you can easily understand that OCD of contamination is an example of neurosis. At the same time, you should know about depression. Remember here, depression also, right? No, depression also. So depression is also what? Depression is also neurotic condition. But psychosis, most important disorder is what? Schizophrenia, even mania. Basically, a schizophrenia patient does not know that he is a patient. He will say that he is normal, you are abnormal, like that. Very easy to understand. Please don't forget this. I will spend more time in first chapter and schizophrenia. In these two chapters, I will be spending more time because from these two chapters only, maximum questions are being framed. Third most important chapter will be substance abuse, right? No, fine. So like apart from that, eating disorder and some other disorders, I will not be spending so much time, right? Okay, fine. Chalo, fine. So now I hope that all points are clear to everyone. Now you see this question, the same question I have asked you during class lecture also. See, the purpose of showing you this question is to understand the framing of the question, because I can see here that most of you see many students are here like who have not attended my live lecture. So you can see this question and you will be having more clarity, right? Now, do understand this is the normal pattern of framing a question these days in psychiatry. Big question will be there, 5-6 lines will be there. One-liner questions are difficult. Big questions are easy to solve. Decode the language. Decode the language. I can see that. Many of you are doing mistake. Dr. Adnan is writing D. Dr. Vidya Pratap is writing D. Dr. Asab, C. Dr. Rizwan, you are writing C. Dr. Rajesh, you are writing B. Dr. Zainab, D. Dr. Swiss Pandey. Wow. Swiss. Good. Dr. Abhishek. Chalo, theek hai. I can see that 70 to 80% of you are right in this question, but still many of you are doing wrong now. First of all, you tell me what is the diagnosis. Can you answer me what is the diagnosis here? What is the diagnosis? Diagnosis is OCD of contamination, right? No? OCD of contamination. You can easily rule out. Just now I finished now. See, judgment power is normal, yes. Insight is present, yes. Because see, OCD is a neurotic condition. Reality testing is absent. No, reality testing is present. No, so this is wrong here. No, this is wrong. D is wrong here. But what about ego dystonic? Remember here, very important term. You always keep in mind. Always keep in mind. There are two words: ego syntonic and ego dystonic. These two words you cannot forget. Ego syntonic, ego dystonic. Syntonic means what? Agreeable to self. Agreeable to self. Dystonic means what? Disagreeable to self. Suppose, see, when I talk about personality disorders, now, personality disorders are ego syntonic. What does it mean? Patient will never accept that he is a patient. If any of your friends who is suffering from any personality disorder, no, he will be thinking that he is completely normal, other people are abnormal. What does it mean? Why? Because he's thinking that no, everything is fine, I'm okay, no problem at all. It means what? It is agreeable to him. He does not find anything wrong. This is called as ego syntonic. Ego syntonic. Ego syntonic means what? I'm fine. I'm okay. You are not okay. I'm okay, bhai. Who are you to ask me? Huh? This is what ego syntonic. But what about ego dystonic? Oh my God, something is wrong with me. Something is wrong with me. It means what? I'm not happy because of my disease. OCD of contamination. Here patient knows that. Your patient knows that he is wasting so much of time, so much of energy, so much of money. He knows that, oh my God, weird thoughts, irrelevant thoughts, senseless thoughts are there, and I'm not able to control it, right? No, because of this, he is going into depression also. So do you think he is happy in his life? No. Remember, OCD of contamination is what? Ego dystonic. And personality disorders are what? Ego syntonic. सर आज YouTube ad please off कर दीजिए. अच्छा YouTube ad आ रहा है इसमें क्या? See, that is not in my control. चलो fine, ठीक है ना? So now you can easily understand, no? Right? Okay, fine. So remember here, देखो, so far I have taught you some one-liner question. Insight. What is the meaning of insight? Can you answer me? Insight means what? Awareness about disorder. On the basis of insight, I have divided psychiatric condition into two. Right now, like neurotic disorder, psychotic disorder. Insight is present, neurosis. Insight is absent, psychosis. Next important catchy term is what? Syntonic. Ego syntonic and ego dystonic. Syntonic means I am fine, agreeable to self. Personality disorders. Ego dystonic. Oh my God, what is happening? When patient is not happy with his attitude and work, right? That is disagreeable to him. That is called what? Ego dystonic. Ego dystonic, right? All right. Now see here, let's talk about this mental status examination. See here, whenever I have a psychiatric patient, what is the name of clinical examination in a psychiatric patient? It is called as mental status examination. Mental status examination. Mental status examination. Here at the same point, examiner can confuse. See, this is what? MSE. Examiner can write MMSE also. What is the full form of MMSE? Mini mental status examination. Where do we use MMSE, by the way? Can you answer me? Where do we use MMSE? All of you, please write down MMSE. Yes, mini mental status examination. Where do we use? Organic mental disorder. Organic mental disorder. In a case of accident, head injury, in a case of Parkinson's, Alzheimer's, we have to use what? MMSC. Right now, when I talk about what? Like delirium, right now, delirium, MMSC. So now please answer me, what are the 5 components of MMSC? This can be your clinical examination in neuromedicine also, psychiatry also. So what are the 5 components of MMSC? First of all, I want to check orientation of patient. How much oriented my patient is. Second, after that, I will give him a white paper. I will ask him write 3 words. Write 3 words like hat, cat, mat, whatever. Okay. He has to write 3 paper registration. And then I would like to check his attention and concentration level. Then I will ask him, hey, which words you have written on that paper? Recall. I want to check what? Recall. Recall. And 5, I want to check what? Language of the patient. Language of the patient. So these are the 5 components of MMSC. Remember here, these are the 5 components. I have to check what? Orientation, registration, attention concentration, recall, language. In total, how much is the score of? In total, how much is the score of MMSC? In total, 30. 30. 30. Maximum score of MMSC is 30. Equal to or less than 24 will be considered as organic mental disorder. Equal to or less than 24 is called as what? Organic mental disorder. Very easy to understand. So if I give you 2 disorders here, schizophrenia and delirium, or schizophrenia or dementia of Alzheimer's, where will you do MMSC? Schizophrenia or Alzheimer's? MMSC. Answer is Alzheimer's. Alzheimer's. Right now, but when I talk about any psychiatric condition, what is the name of clinical examination? Only MSE. Mental status examination. Mental status examination, this part. So see here, see from this point you can expect one question. From this point, from this table you can expect one question. First of all, look at the general appearance of the patient. If patient is maintaining, hygiene, grooming or not, right? Speech rate and tone. So see why to look at the general appearance? We can understand patient is suffering from a disorder which can be higher socioeconomic status or lower socioeconomic status, right? Okay, fine. Speech, if patient is speaking a lot, Patient is speaking a lot. You can say what? He is suffering from mania. If patient is not at all speaking, that is called as what? Mostly patient is in depression. One more term is there, please write down, that is called a prosody of speech. See, this is called a prosody of speech. Prosody of speech. What does it mean? Prosody of speech means what? Emotion of speech. As per the expression, you can understand. Same word, different expression. Like one Hindi word is then acha. You would have seen that movie, na PK Amir Khan movie. In the beginning, you will say, like, expression पे भी ध्यान देना पड़ता है, right? अच्छा, 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 हमको सिखा रहा है. Same word, different expression means different meaning, no? This is called as prosody of speech. Prosody of speech. Remember here, words are difficult but important for them. Right? Prosody of speech. Now, mood and affect. Now, remember here, mood and affect. Mood and affect. See, this describe what? Emotion of the patient. Right? ओके डॉक्टर अमित, ये नहीं पढ़ाया आपने, अभी आगे टर्म लिख लो. जो भी एक्स्ट्रा पॉइंट, देखो हो सकता है कभी कभी क्लास में कुछ पॉइंट्स मिस होते हैं, माइट बी. अगर यहाँ पे एक्स्ट्रा मिले लिख लो, राइट डाउन. ओके फाइन. मूड एंड अफेक्ट डिस्क्राइब व्हाट? इमोशन. सो आई कैन से डिप्रेशन इज अ डिसऑर्डर ऑफ मूड. इजी टू अंडरस्टैंड. मूड डिसऑर्डर, डिप्रेशन. परसेप्शन. हाउ डू यू परसीव एनीथिंग? हाउ मेनी सेंसेस डू वी हैव? 5. विजुअल, ऑडिटरी, olfactory, taste and touch. Suppose if there is nothing but you can see something, visual hallucination. Suppose if you are able to hear some voice which other people cannot, auditory hallucination. You are a cocaine abuser and suddenly you are getting, oh my god, under my skin something is there, some insects are there, तो क्या बोलोगे? Tactile hallucination. क्या है वो? Tactile hallucination in cocaine. In the same manner, see, sometimes if you are having, like in any condition, in any pathology, if you are having a sweet gulab jamun, having it, right? No? And after that you are saying what? Oh, yeah, salty, very bitter. Might be gustatory hallucination. This is called what? Gustatory hallucination. Gustatory. Okay, fine. Suppose if a person is having what? Like some kind of problem in a smell because of any pathology. If he is going to use a public toilet especially of railway station, ammonia, full of ammonia. And then after that he's saying what? And right, so after that he's saying what? See, after using public toilet of the railway station, person, wow, what a fragrance here, man, what a smell. This is what? Olfactory, right? No? Easy to understand. Please write down. Please write down this word. Overall, what is the most common hallucination? Here only please mention it. Please write down. Most common is auditory. Most common is what? Auditory hallucination. Most common is auditory hallucination overall. Visual hallucination. This is most commonly seen in organic mental disorder. When I talk about tactile hallucination, where do we see tactile hallucination? First of all, cocaine. Please write down cocaine. This can also be seen in alcohol withdrawal syndrome. Alcohol withdrawal symptoms. Where does a patient have gustatory and olfactory hallucination? Please write down. Especially in temporal lobe epilepsy. Especially when there will be a problem in the temporal lobe. Very easy to understand. I hope all these points are clear to everyone. One question I would like to ask you here. Tactile hallucinations are also called as, what are the other terms we are using for tactile hallucination? Can you answer me? Bolo, all of you. For tactile hallucination, can you write down a few words? Tactile hallucination. Important. This is also called as what? Formication. Also called as Magnan's phenomena or Magnan's psychosis. Magnan's psychosis. Magnan's, also called as cocaine bugs. Cocaine bugs. Please keep in mind tactile hallucination, also called a formication, Magnan's phenomena or Magnan psychosis or cocaine bugs. These terms are repeatedly asked question in MCI. One liner question, but frequently. Where do we see cocaine, cocaine, cocaine? Second option, alcohol also. Keep in mind, very, very important. So now I can easily say that hallucination is a disorder of perception. Now, thought or cognition. Remember here, thought, especially you have to learn about what? Thought. Right now, thought. See here, I have to check the thought process of patient also. What actually my patient is thinking. What actually my patient is thinking. Remember here, what actually my patient is thinking. So disorder of thought is what? Delusion. Delusion is a disorder of thought. We should also know sometimes we have to, sometimes we are using the term cognition also. Basically, cognition is a broader term. This is the mental process by which we are learning something like speech, memory, action, behavior, orientation, right? No? But here, most important component is thought. So thought and cognition, sometimes these are being exchanged. So if I'm doing behavior therapy to improve the speech of a person, action, behavior, orientation, I'm doing behavior therapy. No, this is called a what? CBT. This is called as what? CBT, cognitive behavior therapy. Cognitive behavior therapy, most important line of management in psychiatry. Remember here, for a psychiatric patient, we are using what? Behavior therapy to improve the cognition is called as what? CBT. Given by whom? Given by Aaron Beck. Aaron Beck. Aaron Beck. Remember, all these points are very, very important. And higher mental function like attention, concentration, judgment power, memory power, abstract thinking, all these are what? Higher mental function. So remember here, all these points which I have taught you here, these are the components of mental status examination. Very, very important. Keep in mind. Okay. Chalo, fine. So can you answer me this question? Very, very easy for you. Now I think this should be the pace. This should be the piece of cake for you people now. Answer karo. Obviously, radiological investigation, you can easily rule out no CT scan, MRI in the see, these we are not using in the MSE right now. Radiological investigation, right now, radiological investigation is not the component of MSE, mental status examination. Very good. I can see that all of you are correct in this question. Very good. Now, see here, let's talk about the disturbances of emotion. We have to learn about all these. Why I'm explaining you all this? I could have left all these topics, but remember here, from here, you can expect some question. I have to divide. Remember here, the disturbances of emotions, I have to assess like quality of emotion, fluctuation of emotion. First of all, see here, I want to assess the quality of emotion. My patient is sitting in front of me here only, right? I have to check the quality of emotion of my patient. I can see that my patient, after abusing bhang, he is very happy, laughing, jumping, dancing. Euphoria. Right now? Euphoria. See, when my patient is happy, is laughing, jumping, dancing, when I'm asking, hey, what happened? I don't know. He's saying, what? I don't know. What does it mean? Eh? Euphoria. Excessive happiness without any reason. One more patient is there. He's very much silent, sad, depression. So depression and euphoria, these are the examples of what? Quality of emotion. Please write down two important terms here. Remember here, see here, normal mood is called as what? Normal mood is called as what? Euthymia. Normal mood is called as euthymic mood. Normal. This is normal. Mood elevation and mood, mood elevation, there will be what? Euphoria. Here it is what? Depression. Very easy to understand. Euthymic means normal. Please write down one more term. Dysphoric mood. Dysphoric mood means what? Irritated mood. Irritated mood. Associated with or accompanied by, you know what? Irritation with sadness also. This is called as dysphoric mood. If a person is having mania, hyper, mania can be two types. Euphoric also is laughing, jumping, working a lot, right? Euphoric. Person is working a lot, he's shouting, he's having so much energy, hyperactive, but he's very much irritated. So that will be called as what? Dysphoric. Happy, euphoric, mania. I hope these points are clear to all of you. Now, fluctuation of mood. Right? Fluctuation of mood. There can be emotional lability, labile. Labile means what? Emotionally unstable. Emotionally unstable. A person is laughing at one time, shouting at another time. Laughing, shouting. एक बार हंसता है, एक बार रोता है. Mostly वो हंसती है या फिर वो रोती है. This is called a what? Emotionally unstable. I'm saying what? Emotionally unstable. This is called as labile affect. This is called as what? Labile affect. Labile emotion, fluctuation of emotion. Can you tell me where do we see labile emotion, unstable emotion? Can you tell me? बोलो कहाँ कहाँ देखोगे? First of all, yes, bipolar disorder, borderline personality disorder. This can be seen in schizophrenia also. So when there is what? Severe fluctuation of emotion, severe fluctuation of emotion, it is called as what? It is called as labile, emotionally unstable. Opposite is what? No fluctuation, flat, affective flattening. What does it mean? There is no fluctuation. Your friend who has scored, see here, now MCI result is out. MCI result is out. Your friend who has scored a 243 mark. You are informing your friend, hey, result is out, you have scored 243. He's saying, acha. After that, you slapped him saying, acha. This is what? Affective flattening. Affective flattening. When ECG is like this, person is alive. When ECG is like this, flat, matlab gone. Khatam. Okay? Easy to understand. So affective flattening means what? No change in emotion. No change in emotion. Flattening of emotions. No emotions at all. Appropriateness and congruency. Very, very important term. Remember here, appropriateness and congruency. Appropriateness is as per social situation. As per social situation. Suppose if a person is in graveyard, Shamshan Ghat, Kabristan. If a person is in graveyard and after that he's meeting everyone, hey, wow, what a gathering here, man. You look so handsome today, huh? If a person is behaving like this in graveyard, what does it mean? Appropriate or inappropriate? Obviously, inappropriate. Simple, right? No? Okay. Now, congruency means what? When thought and speech are matching. When thought and speech are matching. See, whatever thought is there, speech should be same, no? Right? No, speech should be same also, no? So when thought and speech are same, it is called a word congruency. But thought and speech are different, it is called a incongruency. Incongruent means what? Opposite. Suppose if there is a patient of depression, depression patient is there, depressed. He's very depressed. He's saying what? I am the richest man on the earth. Does it suit him? Suit na kar raha tere pe. Huh? This is what? Incongruent mood, right? Depression with delusion of grandiosity is incongruent. But if we're saying what? Everyone is going to die. It suits you well, right? So this is the congruency. Very easy. Now you tell me which part of brain is responsible for production of emotion. Can you answer me? Bolo. Answer karo, all of you. Which part of brain generates the emotion? Answer please. Limbic system. Right now, this is what? Very good. Limbic system. Limbic system generates the emotion. Limbic system generates the emotion. So can you tell me 5 components, neuroanatomical structures of limbic system? Can you tell me? Mnemonic I have taught you, match, M-A-T-C-H, mammillary body, amygdala, thalamus, cingulate gyrus, hippocampus. These are 5 neuroanatomical structures which are responsible for production of emotion. But if a person is in graveyard, he is able to recall old jokes. He is getting laughter in graveyard. जोजो से हंसी आ रही है, बट रोके हुआ है, नहीं हंसना है. So which part of brain regulates the emotion? Can you answer me? You can get the emotion, that is because of limbic system, but not to laugh. Who is going to control your emotion? Can you answer me? Which one? Frontal lobe. Very good. Right now, frontal lobe. Frontal lobe. Remember here, very, very important. Yes, very good. So please write down, limbic system generates the emotion and frontal lobe regulates the emotion. All these points are important. 2 important words are also there, anhedonia and alexithymia. Very easy to understand. Anhedonia especially we see in which condition? In severe depression, in schizophrenia. Anhedonia means what? Inability to experience the pleasure in old activities. Patient will say, well, earlier I used to enjoy, but now I do not enjoy. पहले मजा आता था, अब नहीं आता है. This is called as what? Anhedonia. This is called as what? Anhedonia. Inability to experience the pleasure. Alexithymia means बताओ, inability to express and understand the emotion of. Emotions are there, but person is not able to express it. Person is not able to express it out. जज्बात हैं, दिखा नहीं पा रहा है. That is called as what? Alexithymia. Alexithymia. Remember, these words are important. So emotional problem classically very frequently we see in schizophrenia. My question is that, see here, see my question is that, yes, very good. Okay, fine. If a patient is not able to express the emotion, do you think there can be lesion, there can be any damage in any anatomical structure? Yes. Here I have taught you a match. Here I have taught you match, right? Remember here, this was last time NEET PG question. Damage of any of these neuroanatomical structures will be causing emotional problem. Last time there was the question in NEET PG, a person is not able to express his emotion after road traffic accident, after head injury. There can be lesion, there can be damage in which part of the brain? Option number 1, pituitary gland. Option number 2, corpus callosum. Option number 3, hippocampus. Option number 4, all of these. Answer please. Answer bolo, all of you. ओके डॉक्टर रॉय, सर का लेक्चर सुन के पहले भी मजा आता था, आज भी आता है. मतलब एनीडोनिया नहीं हुआ है भी है. चलो, आई एम ग्लैड. थैंक यू. Answer please, all of you. Dr. Himanshu, yes, very good, all of you. Very easy to understand, no? Hippocampus, right? Hippocampus, very good. All right. So now, disorders of perception. Illusion means what? False perception. False perception in the presence of any object. Basically, suppose if I'm showing my pen to my patient is saying what? Oh my God, this is revolver. This is illusion. Something is there, any object is there, but perception is false. That is called as illusion. After seeing a rope, if a person is getting scared, oh my God, a snake, that is what? Illusion. But hallucination is what? False perception in the absence of anything. Nothing is there, but person can see something. That is visual hallucination. Now you see this question. I have asked this question, maybe somewhere you would have seen this question. Yes, please write down. Please answer the question. A chronic alcoholic person has stopped taking alcohol for last 18 hours. He can hear the noises of small insects. He knows that he is hearing these noises because of alcohol withdrawal factor. Because of alcohol withdrawal factor. Basically, insight is present. So he is hearing some voices. What is the answer here? I think some of you might be marking. Answer batao pehle. You are writing delirium tremens. देखो, first of all, delirium, देखो, DT, when you talk about this, no, this will happen after 48 hours of cessation of alcohol. ठीक है ना? So this one is wrong. Answer is what? Remember, last time also, pseudo hallucination they asked. So hallucination and pseudo hallucination will always be important. Remember, there are 4 criteria to diagnose real hallucination. First of all, understand it. After that, we'll solve the question. There are 4 criteria to diagnose the real hallucination. First of all, this occurs in absence of any stimulus. As vivid as real. What is the meaning of as vivid as real? Exactly the same. Exactly the same. 100% same. 100% same to same. Right now? Okay. Experienced in outer objective space. Outer objective space. Basically, patient will say, what? Sir, I can hear some voices and these voices are coming from out of the wall. आवाज आ रही है बाहर से. I can hear some voices. Voices are coming from out of the wall. The patient will say, voices are emerging in my own mind, inner subjective space, pseudo hallucination, and involuntary. Whenever a patient wants, he cannot behave like he is hallucinating. So these are 4 criteria to diagnose hallucination. Hallucination is a psychotic symptom where insight is absent. But in this question, insight is present, no? So this is a case of what? Pseudo hallucination. Answer is what? Pseudo hallucination. Related to this topic, yes, related to this topic, multiple times they have asked the question. Multiple times they have asked. See, 2 years back in AIMS, they have asked this question. A patient is saying that he can hear some voices which are originating within his own mind. What is the diagnosis? Auditory hallucination or pseudo hallucination? What is the answer here? Bolo. A patient can hear some voices and patient is saying that he can hear these voices which are originating within his own mind. True hallucination or pseudo hallucination? Can you answer me? Answer is what? Pseudo hallucination. Remember here, it should never be inner subjective, always outer objective space. Again and again, I am telling you, these 4 criteria which I have written here, extremely important. You cannot take a chance to forget these points which I am teaching you. Okay? Right? See here, I'm doing rapid revision. Like actually, I will be finishing everything maximum in 4 hours. Maximum. Right now, 4 hours. But you can solve 70 to 80% question. If you already have attended my subject before, so then you can solve 100 question. But if you are attending for the first time, 70 to 80% you can solve. Okay, fine. I have taught you 4 criteria to diagnose real hallucination, but there are some special types of hallucination which do not obey all the criteria. First of all, hypnopompic and hypnagogic. Hypnagogic may mark go. These 2 are seen in sleeping disorder. Which sleeping disorder? Narcolepsy. Narcolepsy. What is the drug of choice for narcolepsy? Modafinil. Okay. Remember here, hallucination before going to sleep. Hallucination before going to sleep, before going to bed, before going to sleep is called as hypnagogic. Hallucination before getting up from the sleep, that is called as hypnopompic hallucination. Hypnopompic hallucination. Now synesthesia, stimulus in one modality will be producing hallucination in another modality. Will be producing hallucination in another modality. This is called as synesthesia, which is also called as a reflex hallucination. What does it mean? Patient will say what? doctor, whenever I am hearing the sound, see here, stimulus in one modality, hallucination in another modality. The patient will say what? Doctor, whenever I look at the tube light or whenever I look at any bulb or tube light, I start hearing the voices of Amitabh Bachchan. Stimulus in visual modality, hallucination in auditory modality. Easy to understand? So what patient is saying, whenever I see that tube light, whenever I see that tube light, I start hearing the voices of Amitabh Bachchan or someone else. Right? No, basically this is called as what? This is called as what? Synesthesia or reflex hallucination. This is seen in substance abuse also. Which substance abuse? LSD and cannabis. Cannabis is nothing but bhang ganja. LSD and cannabis. Please write down, after abusing, see here, after abusing cannabis, after abusing bhang or ganja, person will say what? I can watch, see here, I can hear light, I can watch music. I can hear light, I can watch music. So do you think what has happened? See here, do you think there is what? Senses got crossed? Crossing of senses. Okay, this is called as synesthesia or reflex hallucination. Okay, very easy to understand, right? Okay, functional hallucination, stimulus in one modality, hallucination in same modality. Patient will say what? Okay, doctor, whenever I'm hearing, see, whenever I'm making phone call to you, whenever I speak with you, whenever I hear your voice, suddenly at the same time I start hearing the voices of Amitabh Bachchan at KBC. See, stimulus in auditory, hallucination in auditory, it is called as functional hallucination. So remember here, four special types of hallucination. Hypnopompic, hypnagogic, sleeping disorder, now synesthesia and function. One more, fifth type also, please write down, extracampine hallucination. Extracampine hallucination. Seeing beyond the sensory range. Seeing beyond the sensory range. Seeing beyond the sensory range. Patient will be standing in a room. He can say that, yes, I can see one person is standing out of this wall. He is having a gun is in hand. When I will go out, he will kill me. Basically, he can see out of wall also. You can remember like that, no? Extracampine. Person is standing in a camp. He can see beyond camp also. Impossible, no? How can a person see beyond the wall? Extracampine. These are 5 special types. Okay, I have taught you all these most common hallucination. Can you answer me? Auditory. Inorganic, visual. Olfactory, gustatory, where? Temporal lobe. Tactile hallucination only in cocaine or somewhere else also? Bolo answer karo, all of you, please write down. Yes, Dr. Sudhanshu, yes. I can hear light, I can watch music. I can hear light, I can watch music, right? Very good. And cocaine, alcohol also, alcohol withdrawal syndrome also. Can you write down other names of tactile hallucination? Can you write down other names of tactile hallucination? Write down other names of tactile hallucination. Answer, please. Yes. Formication, cocaine bugs, right? Magnan's phenomena. Very good, very good. Chalo, fine. Now, disturbances of thought. See here, we divide, see here. We have learned all the disturbances of emotions. Very good. Now, we are going to learn the disturbances of thought. There can be flow of thought. Flow of thought or a stream of thought. How thoughts are flying. how thoughts are coming rapidly in the mind of the patient. That is called about a stream of thought. One example, flight of ideas. One example is what? Flight of ideas. Flight of ideas, which you can see especially in mania. Which especially you can see especially in mania. Let us see a flight of ideas, slowing of thinking, even circumstantiality disorder also. Nowadays, now circumstantiality. This is considered as a disorder of flow of thought. Earlier it was there in the form of thought, but now circumstantiality is a disorder of flow of thought. Circumstantiality means what? Ghuma phira ke answer karna. Giving unnecessary details before the final. Flight of ideas, there can be rhyming words also, multiple thoughts. Like there was a question in 2019 or 20 in FMG. After getting discharged from the hospital, patient is saying, what, I'm having so much money. I'm going to buy honey for my sweet Sunny. Honey, money, Sunny is what? Flight of ideas. You can understand like that. Okay, fine. Now, form of thought. Form of thought. I will give you all the examples of form of thought. See here, form of thought means what? Ideally, whenever I show you a bottle, cylindrical form, mobile phone, rectangular form. In the same manner, our thought should also be well organized, well associated. If thoughts are not associated, it will be called as what? Formal thought disorder. Formal thought disorder. I will give you all the examples. Next is content of thought. The actual content of thought. Disorder is called as what? Delusion. Delusion. Possession of thought. Patient can say what? His thoughts are under the control of someone else, like thought alienation. Remember? Thought alienation. Even obsession. Remember here, obsession means what? OCD, uncontrolled thoughts, where patient does not have control. So obsession is also the example of possession of thought. Remember your thought alienation means what? Patient is saying what? Someone can control my thoughts. Someone is inserting thoughts in my mind. Thought insertion. Insertion. Insertion, right? Someone can withdraw my thought. Someone can broadcast my thought. These are the examples of thought alienation. Let's learn all the examples of formal thought disorder. Remember here, first of all, derailment. See here, very frequently they are asking questions from these kind of topics which I am teaching you now, right now. Derailment, loosening of association, incoherence. Derailment, if there will be loss of association, loss of connection between two or more thoughts. If I ask the patient, hey, what do you know about Indian history? What patient is saying? See, Pandit Nehru was the first Prime Minister, or Dr. Rajendra Prasad was the first President of India. Sachin scored century. These two thoughts are associated. No, he was going on a rail, suddenly he got derailed. It is called as derailment. Loosening of association, loss of association, loss of connection, sudden loss of connection between the component of single thought. You ask the patient, hey, how are you feeling now? Patient is saying, I'm very hungry. It will rain today. Eh? Suddenly loss of connection between the single component, loosening of association. Incoherence, total lack of organization. Total lack of organization between the components of thoughts. If you ask the patient, where do you live? He's saying what? Andhra, Mark Zuckerberg, Instagram, Facebook, and etc. Did you understand anything? Arey कहना क्या चाहते हो भाई? This is called as incoherence. Tangentiality, answering in a distant related manner. Answering in a distant related manner. Right now? Distant related manner. Yes, very good, Dr. Anjali. Yes, Dr. Lokesh, Dr. Shubham Verma. Dr. Shubham is asking what the difference between derailment and loosening of association. Keep in mind, derailment means what? More than two thought problem or multiple thoughts. Loosening of association, single thought problem. That's it. Answering in a distant related manner is called as tangentiality. Keep in mind circumstantiality, giving unnecessary details before the final answer. बहुत सारा घुमा फिरा के आंसर करेगा पेशेंट, सब कुछ बहुत सारी उल्टी पुल्टी बातें, बहुत सारी बातें आखिरी में जाके आंसर करेगा. दैट इज circumstantiality. Tangentiality, patient will never give you direct answer. If you ask the patient who is your favorite actor, he will say what? He will say Bollywood is all about romance, Hollywood is all about action. Did he give you the exact answer? No. If you ask the patient, what do you know about Einstein? What patient will say? Science is a branch which is based on research and experimentation. Did he give you the answer? Exact answer? No. If this is the question, answer should be this, but answer should be like this. Distantly related, thoda sa touch karke nikal jayega. That is called as tangentiality. If I make a diagram like this, class 9th, one line, see in mathematics, one line which is going to touch only one point of circle at a point is called a tangent line. This is not going to touch the nucleus. This is not going to touch the center. This is called a tangent line. Tangent, answering in a distant related manner, tangentiality. But if you ask the patient, suppose if there is a junior doctor, senior doctor is asking him, beta, which specialization field would you like to take during your PG? And he's saying, sir, when I was in second year, I was liking patho a lot. PSM also good. You know, after that, when I joined pedia department, cute babies patient. Oh, yes, pedia. No, sir. But actually, you know, Dr. House is medicine is classy. But no, sir. One day what happened? No, when I entered operation theater, there I saw, oh my God, surgeons are playing with the blood. All right, sir. I would like to take surgery. Surgery, sir. See here, he gave the answer, but round and round, unnecessary details before the final answer is called as what? Circumstantiality. Circumstantiality is a disorder of what? Flow of thought, a stream of thought. But tangentiality is a disorder of what? Form of thought, answering in a distant related manner. Even remember here, see here, neologism means what? Neologism means what? Coining a new word. Coining new word. Especially all these we can see in schizophrenia. 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 Yeah, some of you are writing the Tintin Tapa, right? Tintin Tapa. Okay, fine. Chalo, Tintin Tapa example we can take. Or we can take some other, basically any new word which is never seen in any dictionary or anywhere. Suppose if a 19-year-old boy is asking his mom, Mom, I want my Tintin Tapa. What do you want? Arey, Mom, I want my pen. Like, why did you say, Mom, just now I coined a new word for my pen. Or maybe if a boy is using, he wants his notebook. He's asking, Mom, I need my Sanapai. What? Mom, please give me my Sanapai. What? Sanapai? You don't understand this, right? Arey, what do you want, beta? Mom, please don't waste my time. Just now I coined a new word for my notebook, Sanapai. Coining of a new word is especially seen in schizophrenia. Schizophrenia. Metonyms, word approximation. Word approximation. Using old word in a different fashion. I'm standing in operation theater. I want my surgical gloves. I'm asking the nurse, Sister Ji, I want my hand socks. Huh? For specs, I need my eye cover. For wristwatch, I need my time vessel. Old words in a different fashion. It is called as metonyms. Metonyms. Clanging, rhyming, but incomprehensible. Incomprehensible, which you cannot understand. Rhyming words are there. Dekho, flight of ideas mein rhyming words were there, but you could understand, no. But here, clanging, formal thought disorder. If you ask the patient, hey, what is the meaning of fragrance? He will say what? Absence, nonsense, presence, flatulence, fragrance. Did you understand anything? Now, focus here. Perseveration. Earlier, this was categorized as a formal thought disorder. Now, perseveration is also categorized as a flow of thought. Flow of thought. Okay? Flow or a stream of thought. Remember here, perseveration and circumstantiality, as per new updates, these are categorized as the disorder of flow of thought disorder or a stream of thought disorder. Perseveration means what? Unnecessary repetition of same thing. unnecessary repetition of same thing. If you ask the patient, what is your name? He will say, Akash. What is your father's name? Akash. Where do you live? Akash. What is your college name? Akash. This is what? Perseveration. Unnecessary repetition of same word, same thing is called as perseveration. All formal thought disorder. Remember, out of these 7, see here, only these 7. These 7 are formal thought disorder: perseveration, circumstantiality, flight of ideas, slowing of thinking, inhibition of thinking. These are the examples of flow of thought or a stream of thought. Please keep in mind. And these words are repeatedly asked. Now related to content of thought, delusion. What is the definition of delusion? Can you answer me? Delusion ka definition bolo. False, firm, fixed, and unshakable belief, which is based on irrational ground. I'm the most powerful man on the earth. This is called a what? Delusion of grandiosity. Although it's false, firm, but it is fixed, 100% fixed. Means you cannot shake. You cannot shake it. If patient is thinking that he is Bahubali, it means he is Bahubali. You cannot say you are a common person, he can kill you like that. Easy to understand? Remember, delusion is limited to a particular domain. Limited to a particular domain. Okay. Now let's understand. Delusion of persecution means what? A patient is having this kind of belief that someone wants to kill me or someone wants to harm me. That is called as delusion of persecution. Overall, this is the most common type of delusion. Delusion of reference. Patient will refer himself. Patient will refer himself for everything, whatever is happening in and around. Suppose the patient is standing here, AC fell down. Patient will say, what? I kept my hand in my pocket, that's why AC fell down. Seriously. He will refer himself. Whatever is happening here and there, he will refer himself. Delusion of reference. Suppose if patient is, suppose if he is in the bus, he travels in a bus, and now, suppose other people, unknown people, if they are talking, right? If they are talking, patient will say, oh my God, they are talking about me. They are talking about me. Delusion of reference. Delusion of love. MBBS first year, very common, huh? The most beautiful girl of my batch is in deep love with me, right? Very common, no? Eh? Delusion of love. It can happen to anyone. See, fantasy is fine, free of cost. Do whatever you want. But when it will be considered as a disorder, when it will become a problem. See, remember here, there can be difference in, difference in status also. Suppose if a rickshaw puller is thinking what? Angelina Jolie is his girlfriend. Aishwarya Rai is his girlfriend. Right? Although 100% false, but he is having this kind of belief. You cannot change it. When this will be the problem, see here, rickshaw puller, how much is age? 29 years. So delusion, he is saying what? Angelina Jolie is his girlfriend. His mom is saying what? When his mom is asking what? See, when his mom is asking what? Hey, now you should get ready for marriage. Now he says, no. My Anju, my Anju is waiting for me in America. Anju means Angelina Jolie. Easy to understand. Now this will become problem. Right now? Now when he does not want to talk to any other normal girl, now this is called a word delusion. Now this is a disease. Delusion of love, also called as fantasy lover syndrome, erotomania, and difficult term is what? De-Clermont syndrome. This is called a De-Clermont syndrome. Delusion of grandiosity. I'm the most powerful person on the earth. Right? Eh? Chalo, all right. Now, delusion of negation, last time, INICT question. Delusion of negation means what? Delusion of negation means what? Claiming of non-existence of something. Claiming of non-existence of any body part. Here patient is saying what, you know what happened? See my skull, this is empty. Aliens have already stolen my brain. Aliens have stolen my brain. My skull is empty. Patient will say, you know, yesterday my friend, he left to USA and what he did, you know, he stole my pancreas. In INI-CT, what question they have asked? They asked this kind of question that a severely depressed patient is sitting in OPD. He is saying that he cannot eat the food. On asking why he can't eat the food, patient is saying, I cannot eat the food because I do not have head. What the diagnosis here? Delusion of negation. Nihilistic delusion, right? No? Nihilistic delusion, also called as Cotard syndrome. Cotard syndrome was there in the option. Delusion of infidelity. Infidelity means what? Cheating on a spouse. Cheating on spouse. So because of this kind of delusion, person can have what? Morbid jealousy, pathological jealousy. Shakespeare wrote a novel on infidelity, Othello. That's why it is also called Othello syndrome. Remember, your delusion of infidelity is more common among male than female. It is more common in alcoholic case also. Alcoholic case also. See here, basically what is happening here, suppose if husband is claiming his wife that his wife is having extramarital affair, although she is 100% innocent, but he's having this kind of belief. No, he's having extramarital. So every time he keeps on asking her. Every time he keeps on checking her phone again and again. Any guest is coming, every time he's asking multiple questions. So basically, every day fight. After 1 month divorce. But if a wife will be having this problem, no, wife will be having delusion of infidelity, no divorce. Situation will be worse than. And after 1 month, when husband will be sleeping, he will remove them. He will cut the genital organ. It is called as Bobbitt syndrome. Please write down. It is called as what? Bobbitt syndrome. Bobbitt syndrome can be seen with. Bobbitt syndrome can be seen with the delusion of infidelity. Bobbitt syndrome means what? Mutation of male genital partner. Delusion of enormity. Any of my action can bring a big disaster. Any of my actions can bring a big disaster. Suppose a patient is having cough, he will not be coughing openly, he will be coughing like this. So why is coughing like this? He will say, if I cough openly, no, entire city of Hyderabad will do. He will not pass the urine in public place. Why? अगर मैंने सुसु किया यहाँ पे क्या हो जाएगा? Flood आ जाएगा. If I'm going to pass the urine here, there will be the biggest flood. This is called as what? Delusion of evil. I have not seen their question. On delusion of enormity in last 5 years, so you can expect. Delusion of guilt means what? Delusion of guilt, severe feeling of guilt. 15 years back, one of your batchmates, he borrowed money. Now he's meeting you and he is saying, hey, you know, God is not going to forgive me. No one is going to forgive me. I think you are suffering from him. You are suffering from financial crisis right now. Actually, because of me only, no? But all these are what? Delusion. Delusion of guilt can be seen in severe depression. Now look at this picture. What is the answer? Which type of delusion is this? Are you saying mic problem? Okay. Now is it fine? Is it fine now? Yeah, okay, now I think it should be fine, right? Okay. ठीक है. Okay, see, this is what? Delusion of grandiosity. This is what? Delusion of persecution. Picture number 1, picture number 2, picture number 3, picture number 4 and 5. So what about picture number 3? Delusion of reference. Picture number 4, delusion of infidelity. Picture number 5, she's saying what? Half part of her face does not exist. Delusion of negation. Delusion of, all delusions, all hallucinations are important. Now last topic here. See this one. Very good. All of you are doing great. Yes. Awesome. Awesome. FMT कब होगा सर? डॉक्टर मिजानुर रहमान यू आर आस्किंग. आई थिंक आपको स्केड्यूल मिल गया होगा, स्केड्यूल में होगा. अभी डेट मुझे तो नहीं याद है, बट FMT विल बी देयर. Dr. Syed Asif, yes, this PDF will also be shared. Don't worry. Okay. Now we are going to check what? Higher mental function. Higher mental function. Single number. Gradually increases to 2 number sequences, 3 number sequence, and so on, so forth. What is the name of this test? Bolo. Answer please. Okay. Now I'm going to check what? Higher mental function. Last time FMG question. Remember here, digit span test. Remember here, all these we are going to digit span test. If I'm asking the patient to count the number at the span of a digit, like I will ask the patient to count the number at the interval of 2. So he'll be counting like this: 2, 4, 6, 8, 10. This is called a digit span test or digit repetition test, especially to check attention level of the patient. Attention level of the patient, right? Now, I want to check the concentration level of the patient. I want to check the concentration level of the patient. Higher level of attention is called as concentration. Now, I will give him a difficult task. Subtract 7 from 100 and keep on counting. 100 minus 7 equal to 93. Then he has to count like 86, 79, 72, 65, 58. I can easily count because every time I speak the same thing, right? But patient will take some time. And patient will say what? Sir, 100 minus 7 equal to 93. After that, sir, 86, 79. Sir, India-Pakistan match was going on. Did you see that? See, suddenly loss of concentration. Very easy to understand. This is called as serial. This is called about serial 7 subtraction test. Last time this was the question. This was the question last time, FMG question. 100 minus 7 equal to 93 is a test used to assess which? Higher mental function. Okay? Concentration, or concentration is also called as what? Higher level of attention. Higher level of attention. Proverb test. Similarities test. See here, now you can easily understand here. See, what is the meaning of proverb test? I'm asking the patient, what do you mean by health is wealth? He's not understanding. Now, if I ask him, hey, what do you mean by a pen is mightier than the sword? Pen is stronger than the sword. Patient is saying, yeah, your pen might be of 15 kilogram. What does it mean? He's not able to understand the deeper meaning of my sentence, right? So basically, he's not able to understand what? His abstract thinking is poor. Abstract thinking is poor. Okay. In the same manner, similarities testing. I'm asking the patient, what is similarity between table and chair? He's saying what? Both are on the floor. But if he's saying that, yeah, both are made up of woods, now it's good. So remember, proverb testing or similarity testing we are using for what? Abstract thinking. Test judgment. I'm giving a test to my patient. What will you do if you see a house on fire? Patient is saying, I will make a selfie. Right? It means what? His judgment power is not good. It is called as what? Test judgment. Test judgment. Okay, so why we are using this? To check judgment power of the patient. Remember, when I am saying 2, 4, 6, 8, and this is forward, no. When 10, 8, 6, 4, 2, 0, that is backward, right? Remember, digit span forward test is better. Digit span forward test is better for attention also, concentration also, immediate memory also. I'm talking about immediate memory, right? Now you can easily solve this question. What is the answer here now? Now you can easily solve the question. Yes, this is a case of what? Number digit span test, right? This is called a what? Digit span test. This is called a what? Digit span test. Very easy to understand, right? Hello, fine. Now schizophrenia. See here, so let's understand schizophrenia. Next, very important chapter, schizophrenia. See, simple rule you have to keep in mind. If a patient is having only delusion, then he will be called as a case of delusional disorder. If he is having only hallucination, okay, hallucination case. Delusion, hallucination together, schizophrenia. In schizophrenia, many symptoms can be there. Multiple symptoms can be there. Suppose if you are getting a big question, multiple symptoms patient is having, and if you don't know the exact diagnosis, if you are not able to solve the question, if you see in the option, if answer is the schizophrenia, mark it, answer will be correct. But having said that, keep in mind, patient will be having more than one symptom. I am saying not only one, more than one symptom should be there. So what are the symptoms? Remember here, first of all, you have to keep in mind, either there can be delusion, hallucination, formal thought disorder, or disorganized symptom. Disorganized symptom behavior means what? You would have seen like in summer, if a person is wearing, five jackets, or if a person is wearing 5 t-shirts together, shirt, t-shirt, right? Okay, suppose if a person is wearing, 5 specs at the same time, you can see that what kind of abnormal person is, right? So that is called disorganized behavior. Disorganized behavior. Okay. Fourth point, motor symptoms. Physical symptoms, and fifth, negative symptoms. Out of these 5, remember, minimum 2 symptoms should be there. If 2 symptoms are there in the same patient, 100% diagnosis is schizophrenia. Remember here, these symptoms should be there for more than 6 months. This is the rule, that symptoms should persist for more than 6 months. So how much is the duration criteria for schizophrenia? More than 6 months, equal to more than 6 months. But this is given by as per DSM-5. Old classification. Now as per ICD-11, is saying why to wait for 6 months? Why to wait for 6 months? If patient is having equal to more than 2 symptoms even for more than 1 month, it will be called as schizophrenia. Remember here. So what is the new classification? What is the new criteria of diagnosis of schizophrenia? Minimum equal to more than 2 symptoms for more than 1 month, 100% is schizophrenia. Same symptoms like schizophrenia can occur. Same psychotic symptoms like schizophrenia can occur. Maybe because of any stress, loss in business, loss in exam, right? Maybe because of high fever. But duration is less than 1 month. If duration is less than 1 month, then please remember, this will not be considered as a case of schizophrenia. This will be considered as a case of what? Acute psychotic disorder. Acute psychosis or acute psychotic disorder. I hope all these points are clear to all of you right now. And remember, out of these 5, one more rule is there. Out of first, second, and third, at least 1 symptom should continuously be there for 1 month. 1 should continuously be there for 1 month. 1 month. I hope all these points are clear to all of you. Especially you have to emphasize on है ना? Okay, if I remember here, see, there are 5 symptoms. There are 5 symptoms. Out of these 5, minimum 2 symptoms should be there. For more than 1 month, this is the new classification. If examiner is especially mentioning DSM-5, no, then answer will be more than 6 months. More than 6 months. Now, let's learn here. See here, obviously, schizophrenia can come in family also. So monozygotic twins will be having more chances than dizygotic. See here, there was the question in MCI. Deletion of which chromosome can cause schizophrenia? Chromosome number 22. This is called as what? DiGeorge syndrome. DiGeorge syndrome. DiGeorge syndrome, also called as velocardiofacial syndrome. Velocardiofacial syndrome. Chromosome number 22. Very good. Very good. Dr. Murshid is asking too much ads. I do not have control on the ads. See, suppose if there will be so much of engagement, no, then there will be more ads because of YouTube, right? So YouTube is not our company, okay? See, like we are doing this through ISM EduTech, actually Prosium and Doc Tutorial, right? So you can manage, all right? Okay, chalo, fine, very good. All right. See, now next is what? Biochemical factors. Now we are knowing that increased level of dopamine, increased level of serotonin. These two are most important neurotransmitters. Anna? You are asking for ad, huh? Ad ke liye, is there something we can do? You ask them if they can do something with the ads, okay? Because the students are, yeah. Chalo, okay, fine, theek hai. I have asked the team to do something, all right? Chalo, all right. Remember here, now we are knowing the fact what? Increased level of dopamine and increased level of serotonin will be causing what? Schizophrenia-like symptoms. Apart from these two, yes, there can be what? See, there can be increased level of norepinephrine also, GABA also, glutamate also. But remember, especially these two, dopamine and serotonin. See, remember here, obstetric complications. Always keep in mind, schizophrenia is mostly seen in villages, right? In villages, right? Okay. So remember here, obstetric complications can lead to schizophrenia. Season of birth, low temperature, winter season, yes, it can cause. Do you think schizophrenia can be infectious? Actually, no. But as per the research, during pregnancy, if mother got exposed to influenza virus, right, there is very high risk of schizophrenia in the newborn baby. See here, late paternal age, social, yes, immigration, I am telling you, immigration. These are risk factors for schizophrenia. See, during the war, when so many people are going to travel to other countries, right? Right? And if so many people, so obviously in other countries, they will not be having equal rights. They will be abused physically, mentally also, they will be tortured. So there can be psychological trauma, no? So immigration is also the risk factor for what? Schizophrenia. In which a drug abuse, there is very high risk of same symptoms like schizophrenia. Please write down. Like cannabis, LSD, cocaine, even alcohol also. All rave drugs, hallucinogens like amphetamines, LSD. Now, remember who coined the term schizophrenia? It was coined by Eugen Bleuler. He coined the term schizophrenia. He gave 4 symptoms of schizophrenia. He said that 4 A's will be there, like autistic symptoms, ambivalence, affect problem, association problem. Now, autism means what? Socially isolated. Socially isolated. See, especially in this schizophrenia, person would like to stay alone in the dark room, closed room, right? Alone. Right now, some autistic symptoms will also be there. See, not exactly similar to autism of the pediatric age group, but some symptoms, and most importantly, what? Socially withdrawn. Patient would like to stay alone. Ambivalence means what? Inability to take a decision. Inability to take a decision is called as ambivalent. Suppose if you are going to shake hand with the patient, no. Now when you are, see, whenever you are going to shake the hand with the patient, now patient is going to take his hand from the pocket. Now he will be confused whether to shake or not, whether to meet, whether to greet or not, like this. Inability to take a decision. Ambivalence. Affect. Affect means what? Emotion, mood and affect. Remember here, mood and affect both are same, means emotion. Mood is long standing, affect is short standing. Remember like this. Short term expression of emotion is called as affect. Long term, for last 1 month I was very sad, for last 1 month, that is mood. So see, in schizophrenia, mood problem can be there classically. There can be anhedonia. Anhedonia means what? What is the meaning of anhedonia? Inability to experience the pleasure, right? So there can be anhedonia, alexithymia, there can be depression, there can be mania, right? And there can be affective flattening. Basically, one emotional problem can be there, very commonly seen among schizophrenia patients, right? There can be depression, there can be mania, there can be affective flattening, there can be inappropriateness of emotion. Schizophrenia patient can laugh in the graveyard, right? There can be incongruency, right? Association disturbances. Association, where I have taught you loosening of association, formal thought disorder. Formal thought disorder. Remember here, at least one formal thought disorder you can expect in schizophrenia. These are 4 A's of blue layer. Repeatedly, can you write down? See, can you write down in chat box what are the 4 A's of blue layer? Autism, ambivalence, affect disturbances, and association disturbances. Association disturbances, right? Repeatedly asked question. Examiner will ask you which of the following is not the component of 4 A's of Bleuler or Bleuler symptoms of schizophrenia, right? Okay, fine. Very easy to understand. अच्छा वो क्या था? Dr. Shubham, these are the risk factors for the newborn babies, right? Newborn. Okay, fine. Next question. See here, 4 symptoms you have to focus here, na? अच्छा वो क्या था? Giving unnecessary details before the final answer. It is called as what? Circumstantiality. अच्छा वो क्या था? Answering in a distant related manner. Not answering the exact answer. Answering in a distant related manner is called as what? Tangentiality. Tangentiality. Very good. Tangentiality. Tangentiality. Coining of a new word is called as what? Neologism. Neologism. Using old words in a different fashion is called as what? Metonyms. Metonyms, right? Very good. Now, one more scientist was there. His name was Kurt Schneider. He categorized all the symptoms of schizophrenia as first rank symptoms. First rank symptoms. Who gave? Kurt Schneider. Examiner can frame the question like this: which of the following is not a component of first rank symptom of schizophrenia? I'm not saying that all symptoms are supposed to be present in the same patient. No. Few of first rank symptoms can be there. This is called what? Schneiderian first rank symptoms. Remember how to memorize. There are 3 thought phenomena, 3 made phenomena, 3 auditory hallucination. When patient is having only thought problem, thought insertion, withdrawal, broadcast. What does it mean? Last time there was the question that a schizophrenia patient is saying what? Aliens are sending radiations to his brain and asking him to kill the neighbors. This is called what? Thought insertion. Someone is withdrawing my thoughts and utilizing it. Withdrawal. Oh my God, someone is going to broadcast my thoughts. Only thought problem. This is called about three thought phenomena. When thoughts will be converted into action, now it will be called as made phenomena. Now it will be called as what? Made phenomena, like made volition, made affect, made impulse. Made volition means what? Volition means against the will. Against the will. Whenever you are going to work in psychiatry department, you have to be very, very much cautious. Maintain a distance between the patient also. Suppose if you are talking to, suppose if you are speaking with the patient, and you are speaking like this, okay, what happened? And suddenly patient will slap you like this. So when patient is going to slap you like this, now after that when you are asking the patient, hey, why did you slap me? No sir, I did not slap you, sir. So that person who is there, he can control my action. And when I was actually controlling my hand, but that person can control my action, and suddenly I could not control, I slapped you. I am really sorry, I did not do this. No. This is called as what? Made volition. Against the will. मैं नहीं चाहता था कभी आपको मारना, मैंने नहीं मारा आपको, ना, मैंने नहीं मारा आपको, किसने मारा? उसने. Easy to understand? तो अब ये बताओ, पेशेंट डॉक्टर पे हाथ उठाए, उसको पनिशमेंट होगा क्या? है? If schizophrenia patient is going to murder, if schizophrenia patient is going to murder a person, will there be punishment? Huh? Answer is no. No, because he does not know what he is doing. He does not understand the consequences of any crime. Which IPC? Can you answer me? Which IPC? Yes, IPC number 84. IPC number 84. Which rule? McNaughton's rule. McNaughton's rule. McNaughton's, right? No, McNaughton's. See, this is also called as what? A right or wrong test. McNaughton's rule is universally, like everywhere we practice McNaughton's rule. McNaughton's rule in India, it is described by 84. Very, very important IPC. So, made volition against the will. Made affect. Affect means what? Emotion. Patient is admitted in your department. Patient is laughing at one time, shouting at one time, laughing one time, shouting, laughing, shouting, laughing, shouting. When you are asking the patient, hey, why do you do like that? No. That lady who is sitting in that corner, she can control my emotion. She can control my emotion. Whenever she wants, she can make me. Whenever she wants, she can make me cry. This is called as what? Made affect. Patient will claim what? Someone can control my emotion. Made impulse. Impulse means what? What is the meaning of impulse? Last time MCI, they have asked the question, what is the definition of impulse? Sudden urge to perform any action. And that can be injurious to other people. Impulsive control disorder. Right now? Right? So impulse, see, suppose a patient was having juice like this. When nurse came, suddenly he thrown the juice on the patient, right? This is so after when nurse is come, why did you do like that? No, I didn't do that. That guy, he created this impulse in me and I could not resist. Made impulse. 6 symptoms completed. Now there will be 3 auditory hallucination. 3 auditory hallucination. Patient will say, sir, voices are arguing about me. Voices are commenting on my action and I can hear my own thoughts. What does it mean? Patient will complain what? Okay, doctor, one thing, when I sit alone in the room, I can hear some voices and these voices are discussing about me only. They are abusing me. They are saying that I'm fat, I'm this, I'm that, right now? So patient will say, what patient will hear this kind of voices that, hey, how fat he is, how bad he is, how mad he is. Who is he here? He is the patient. He is the patient. As per English grammar, I, me, first person. You, your, second person. He, she, it, they, third person. That's why voices arguing is also called as third person hallucination. Third person hallucination. Keep in mind, voices are commenting on patient's action. Whatever patient will do, he will hear the voice because there is what? Running commentary. Dr. Shubham Verma is asking how we can understand that patient is actually the patient or he is acting. He is acting. For this, we have to admit the patient minimum for 1 month. We have to keep the patient under observation. We have to go for biochemical checkup also, right now, serotonin, dopamine also, right now, and we have to keep the patient under observation, right? So many signs and symptoms are there on the basis of which, because see here, how to differentiate a real patient and a fake patient? How to differentiate a real patient and a fake patient? Real schizophrenia patient will be same since morning to night time. Fake patient, no, he will start acting under the observation. Easy to understand? When he will see that someone is watching, he will start acting, he will start behaving like a psycho person. Second important point, real patient can survive without food, water and normal sleep for 1 day, 2 days and longer duration. But a fake patient, he is healthy person, no, he cannot survive without food, water and normal sleep. Okay. Real patient, schizophrenia patient will not have water for longer duration. So if you see the face will be dry, lips will be dry. But a fake patient will be healthy, maintaining grooming and all everything. Real patient will be cooperative. You do examination for 2 times, 3 times, no problem. But fake patient, if you repeat the examination again and again, he will be irritated. Because he will be scared. Oh my God, he can catch me. Doctor can catch me. Easy to understand? Right. Okay, fine. Now voices are commenting. Patient can hear running commentary. In the beginning, patient will be normal only. You cannot diagnose in the beginning that he is a schizophrenia patient, right now. So suppose if there is a patient who is living on 15th floor, in that building, 50 floors are there. See, in the beginning, whatever patient will do, he will hear the running commentary. Now, suppose if he's getting ready for the office. Okay, so now suppose if he's wearing shirt, pant, okay, everything. Right now, so when he's wearing the, now he's going to wear the shirt, now he's going to wear the tie, now he's going to wear the wristwatch, now he's going to wear the perfume, now he's going to take his bag, now he's moving towards the door, now he's going to lock the door, now he's moving towards the lift, elevator, now he's going to press ground floor. In the beginning, there will be only running commentary. But after a certain interval of time, there will be what? There will be the commentary. But there will be what? Which type of hallucination? Hallucination of the command. Hallucination of the command. In the beginning, only commentary was there. Now, command type. When he pressed ground floor, now he will hear the voice. Hey, why did you press ground floor? Press 50th floor. Let's go up. He will press 50th floor. Let's go up. Now he's on the top of the floor. Now when he's on the top of the floor, when he will be looking at the down, hey, you wanted to go there on the earth? You wanted to live with this kind of creepy people? These are not human beings. These are insects. You wanted to go there. Seriously, you are not human being. You are Superman. You are Spider-Man. You should not walk. You should fly, and he will fly. Fly means what? Two sides. So remember here, this commentary type, especially command type of auditory hallucination is most dangerous. Old question. Okay. Next is audible thoughts. Audible thoughts means what? Whatever patient is thinking, he is hearing it. Suppose if he is thinking that he is going for the lunch, he's going for the lunch. He's like, suppose if he's thinking that like he wants to meet his girlfriend, he's going like he's going on a date. Basically, whatever he is thinking, he will hear it. It is audible thoughts. I have taught you 9 symptoms. 9 symptoms, first rank symptoms. Next, somatic passivity. Visceral hallucination. Patient is having abdominal pain, but he's saying, what? No, aliens are sending radiations. That's why I'm having abdominal pain. He can feel the pain. And I'm having joint pain, I'm having this pain, that pain. My friend who is sitting in New York, he is sending infrared radiations from there. Somatic passivity. Delusional perception. A delusion is associated with the normal perception. What does it mean? When patient is looking at Omni car, see, as per the movies I'm saying, Omni car ka use kya hai batao? Especially to kidnap. As per the movies, I'm not degrading any car, okay, fine. As per the movies, है ना, ओमनी कार में क्या होता है, किडनैप करके लेके भाग गया है. So patient is having this kind of delusion. देखो, one delusion, okay, will be associated with normal perception. Whenever patient is looking at omni car, he's saying, oh my God, they're going to kidnap me. Oh my God, they're going to kidnap me. This is what? With the normal perception, delusion of persecution is associated. This is called as delusional perception. I have taught you all these symptoms in detail. Please remember, first rank symptoms, 4 A's of Bleuler. These are repeatedly asked question in MCI. Now, see this question, please. Dekho, in this manner, examiner will be framing the question. Can you answer this question? Which of the following does not describe the first rank symptom? Emotions can't be controlled by others. Obviously, made affect, it is there, right now. So answer is what? D only. Very good. I can see that all of you are correct. Very good, very good. Doctor, I can say Dr. Nasrina, Dr. Surbi, Dr. Adnan, all of you, Dr. Rizwan, Dr. Avas, Dr. Vidya. Very good, very good. Very good. Dr. Lone with the sky, Dr. Lalit, all of you are doing great. Yes. Now, what are the symptoms in schizophrenia? We see you have to focus on 5 symptoms. There are positive symptoms, there are negative symptoms. Disorganization symptoms, catatonia, violence, homicide. Remember here, these symptoms are very, very important. First of all, what is the meaning of positive symptoms? Positive symptoms means what? Add-on symptoms. Add-on symptoms means what? The symptoms which got added in the life of the patient. Earlier it was not there, but now these symptoms are there. Like delusion and hallucination. Psychotic symptoms are called as positive symptoms. These got added. Earlier it was not there, now it is there. Negative symptoms means what? Loss of normal function. Earlier patient used to laugh a lot, now he's not laughing. Earlier he used to talk a lot, but now he's not talking. Earlier he used to be very sociable, now he's not very sociable. These are negative symptoms like avolition. Avolition means what? Lack of drive to do goal-directed activities. Apathy, loss of interest in activities. Asociality means what? Asociality means what? Patient is no more social. Person is no more social. Earlier he used to attend all marriage functions, all parties, but now he's not attending anything. Earlier he used to work a lot, but now he's not working. Earlier he used to be very social, but now he's not. Asociality. Anhedonia, inability to experience pleasure. Alogia, loss of, like decrease in verbal communication. Affective flattening. Affective flattening. All remember here, examiners are asking this kind of question. Which of the following is not a negative symptom of the schizophrenia? Now, disorganization symptoms. What are the disorganization symptoms? Formal thought disorder. Disorganized behavior means what? Wearing 5 shirts. Wearing nothing also. Wearing nothing and running on the road. That is also what disorganized. Very easy to understand. Right. Inappropriate affect, laughing in graveyard. Catatonia was coined by Carl Baum. Carl Baum. Okay. So see, related to schizophrenia, I have mentioned here important names of scientists. First of all, who coined the term schizophrenia? Eugen Bleuler. Who gave first rank symptoms? Kurt Schneider. Who explained about catatonic symptoms? Carl Baum. What I'm saying is that catatonia means what? Motor symptoms. One more important scientist who explained about schizophrenia for the first time. He was Emil Kraepelin. Emil Kraepelin, who explained about dementia precox. At that time, there was no name like schizophrenia. There was a name like dementia precox and manic depressive illness. Everything was fine. But he said that this can be seen only in precox. Precox means what? Young age, adolescent age. Schizophrenia can be seen. Remember here, mostly schizophrenia will start in adolescent age group. This is 100% true. Schizophrenia will start in young age, mostly. All psychiatric condition, all non-organic condition can start in young age only. Young age only. Organic, old age, I have taught you in the beginning. But remember, schizophrenia in some cases can start even after 45 years of age also. This is called as late onset schizophrenia. So this word got disqualified. That's why new name came schizophrenia. Okay, fine. Now these are what kind of pictures I'm showing you now here. These are what? So see what symptoms I'm showing you here now. What are these? Remember, these are called as motor symptoms. These are catatonic symptoms. Catatonic symptoms. This is called as what? Moving like a wax is called as waxy flexibility. Moving like a candle wax. This is maintaining a posture due to sudden neurogenic block. This is called what? Catalepsy. Catalepsy. Remember here, catalepsy is seen in schizophrenia. Be careful. There is one more word that is called a cataplexy. Cataplexy is what? Sudden loss of muscle tone. This is seen in narcolepsy, sleeping disorder. So be careful about these words. Be careful. This is catalepsy. Cataplexy is seen in sleeping disorder. Okay. So basically sudden neurogenic block, sudden muscle rigidity. I was doing physical examination. I asked the patient to abduct the shoulder like this. Now suddenly there was neurogenic block. Now patient will be moving like this. This is called as what? Catalepsy. Maintaining any kind of posture is called as posturing. Posturing. Making odd facial expression is called as grimacing. Grimacing. Mimicking speech of the examiner is called as echolalia. Echolalia means what? Mimicking speech of the see here, mimicking speech of the examiner. जो बोलोगे वही बोल उसको repeat करेगा. That is called echolalia. But this picture, what I am showing you here, mimicking action is called as what? Mimicking action is called as echopraxia. Even see some other motor symptoms. Can you tell me some other motor symptoms? Yes, some other motor symptoms like stupor. Stupor means what? Immobile, posturing, waxy flexibility. Okay. Automatic obedience, negativism, hyperactivity. All these are what? Motor symptoms. Halten. See, even one more is important, that is called a perseveration. What is the meaning of perseveration? Unnecessary repetition of same thing. For one time I asked the patient, show me your tongue. Only for one time I asked. But after that, whatever I'm asking my patient, again and again he shows it. Again and again he's showing the tongue. This is called as what? Perseveration. Remember here, all these are what? Yes, all these are what? Catatonic symptoms, motor symptoms. Remember here, last year they have asked about echolalia. So motor symptoms are important, right? So Halten, perseveration, waxy flexibility, all these are important. But you have to know one update here. When I talk about catatonia, earlier catatonia was considered as only a symptom. But as per ICD-11, catatonia is no more a symptom. There is update. Catatonia is a new diagnosis now. Catatonia is a new diagnosis now. Catatonia is a new diagnosis now. Right now, this can be seen in some other disorders also, like severe depression, autism, dissociative disorder. This can be because of some medicines also, right? Okay. Now see this question. Now we are going to learn about pathophysiology. From here we can expect one question. Solve this question now. Some of you are marking B and some of you are marking A, right? Here patient does not maintain, see here patient does not have hallucination, and here patient does not have delusion and hallucination. Here patient is having what? Here remember, here patient does not maintain hygiene and grooming. Hygiene and grooming. So basically I would say what? Negative symptoms, right? No, negative symptoms. Now let's understand here. See here, first of all, symptoms in schizophrenia are happening because of what? Dopamine. Because of dopamine. How many dopaminergic pathways are there? 4. Mesolimbic tract, mesocortical tract, nigrostriatal pathway, tuberoinfundibulum tract. We have learned all these points here that, see, decreased level of dopamine in nigrostriatal pathway will be causing Parkinson's-like symptoms, right? Okay, in tuberoinfundibulum tract, apart from dopamine, is one more hormone is there, that is called as what? Prolactin. That is called as prolactin. Prolactin. What is the relation between prolactin and dopamine? Both are opposite to each other. If one will increase, another will decrease. There will be what? Negative feedback. One will increase, another will decrease. I hope all of you know that if there will be hyperprolactinemia, there can be multiple symptoms, right? No? What are the functions of prolactin and oxytocin? Milk ejection, secretion, right? For the symptoms of schizophrenia, especially these two tracts, mesolimbic and mesocortical, these are responsible. Remember here, first of all, what are the positive symptoms? Delusion and hallucination. What are the negative symptoms? Where there will be what? Loss of normal function, like anhedonia, asociality, he's not maintaining like anything, right? Of alogia, all these. Remember, what is the pathophysiology of these? Increased level of dopamine in mesolimbic tract will give rise to positive symptoms, and decreased level of dopamine in mesocortical tract will give rise to negatives. Simple. Keep in mind, very, very important. What I'm saying here, that increased level of dopamine in mesolimbic tract, because of this there will be positive symptoms like delusion and hallucination, and decreased level of dopamine in mesocortical tract will be causing what? Negative symptoms. One more point you should know here. Remember here, what about medications? Patient respond well to medication if positive symptoms are there, so good prognosis. Patient do not respond well to medication, right now, and they have poor prognosis if there will be negative symptoms. So see, positive symptoms, responding well to medication, good prognosis; negative symptoms, poor prognosis. Easy to understand. What is the pathophysiology? Remember, a pathophysiology is what? Increased level of dopamine in mesolimbic tract, positive symptoms. Decreased level of dopamine in mesocortical tract, negative symptoms. I hope all these points are clear to all of you. Now you can answer me this question. Okay, no, so negative symptom, decreased level of dopamine in mesocortical pathway. Very easy to understand. I hope all these points are clear to all of you. In this same manner, see here, I'm telling you this pathophysiology is very, very important for the exam. Very, very important. This is what you are going to learn in the treatment part also. Now we are going to learn last topic here in the schizophrenia treatment protocol. First of all, if you have a schizophrenia patient, we have learned all these facts that in the beginning, there was a concept of only dopamine, dopamine, dopamine. In the beginning, there was no concept of serotonin. So scientists were knowing that only because of increased level of dopamine, 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 there will be what positive symptoms or there will be psychotic symptoms. So scientists made a drug, D2 antagonist. First time, scientists made what? D2 antagonist. So it was called as first generation antipsychotic drug. Since typically it was blocking dopamine, it was called a typical antipsychotic. Typical antipsychotic. Now, let's understand here that. So what are the examples of typical antipsychotic drug? What are the examples? Bolo, are you able to recall? At least haloperidol you should keep in mind. Haloperidol, most important drug. Even some other like flufenazine or even the chlorpromazine, these are what? First generation drug. First generation, right now? First generation drugs. See here, so what are the side effects we are going to learn here? Side effects and all we are going to learn. My question is that, suppose if there is a normal person, what will be the level of dopamine in all their tracts? Everywhere it will be normal, 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 and normal. But suppose if there is a schizophrenia patient, what will be the level? Remember here, in mesolimbic tract, it will be increased. In mesocortical tract, it will be decreased. Here, normal, here, normal. So now you are giving first generation drug. Like I'm talking about haloperidol. So haloperidol is what? Dopamine antagonist, no? So this is going to decrease the level of dopamine, right now? Decrease the level of dopamine. So it is going to decrease the level of dopamine in mesolimbic tract. But what about mesocortical tract? Further decrease. Nigrostriatal pathway, since you have given medicine from outside, no? You have given medicine from outside, so this is going to decrease the level of dopamine in all dopaminergic pathways. Right, here also dopaminergic pathways. Tiburoinfundibulum, here also dopaminergic pathways. I hope you are able to recall that positive symptoms like delusion and hallucinations were there because of increased level of dopamine in mesolimbic. So when you are giving medicine from outside, what will be the response here? There will be improvement in positive symptoms. Improve hoga, right? Very good for the patient. But you remember this fact that negative symptoms were there because of decreased level of dopamine in mesocortical tract. So now what will happen? There is a further decrease, no? Further decrease हुआ यहाँ पे, so क्या होगा यहाँ पे now? Now there will be worsening of negative symptoms. Nigrostriatal pathway, Parkinson's-like symptoms, some motor symptoms, some neurological symptoms. Patient is complaining about, doctor, medicine which you have given me, like haloperidol you gave me, right? Doctor, after taking this medicine, what is happening with me? See here, no, I'm not able to sit at one place. I have to keep on moving from here to there. Acute akathisia. Sometimes I'm having sudden muscle contraction of my neck, deviation of eyeball. Oh my God, sometimes I'm having what? Sudden as a laryngospasm also, right now. So sometimes I'm having the jaw lock also, dystonia. What are these? क्या है ये सब? Extrapyramidal symptom. These are what? Extrapyramidal symptoms. Remember here, what is the logic behind extrapyramidal symptoms? What are the logic behind extrapyramidal symptoms? Decrease the level of dopamine in nigrostriatal pathway. Same table Can be asked in physiology question. A patient of schizophrenia was started on haloperidol. Now patient is complaining that, sir, sir, I'm not able to sit at one place. What is the pathophysiology? Decrease of dopamine in nigrostriatal pathway. Decrease of dopamine in nigrostriatal pathway. Now, one more serious complication is happening. I have a patient of schizophrenia. She is only 21-year-old female, unmarried. She is complaining, doctor, the medicine which you have given me, after that I am having galactorrhea. Galactorrhea. Why galactorrhea? Because a decreased dopamine level will cause what? Increased level of prolactin. Increased level of prolactin. So galactorrhea, right? No? Right? So this is so actually this is very much wrong for the patient, right? No? Wrong for the patient, right? Some other patients are complaining what? Lack of libido also. Lack of libido. Right? No? Lack of libido. Erectile dysfunction also. Right? No? So basically, so many side effects are happening. And now my question is that, do you think when I have given first generation drug, drugs, did I support my patient more or I have harmed my patient more? There was improvement only in the positive symptoms. There was improvement only in the positive symptoms. But there was worsening of negative symptom, extrapyramidal symptom, galactorrhea, some sexual side effects and all. Very easy to understand. So it means what? My patient is in trouble. Only first generation drug. Remember here, all extrapyramidal symptoms are happening because of what? Because of dopamine, only dopamine. So doctors were in trouble. Fine. Now one day what happened? I have taught you that symptoms like schizophrenia can occur in drug abuse also. There was a young patient who abused LSD. He had all symptoms of schizophrenia. Doctors did urine examination. And they found there was very increased level of, very high level of serotonin metabolite, right? No? Very high serotonin. So doctors thought, hey, only dopamine should be increasing. No, see, in a urine, if increased level of serotonin is there, what does it mean? It means what? There is very high level of serotonin in his body. There is what? Very high level of serotonin in his body, right? No? I know. So doctors made hypothesis, oh my God, what does it mean? It means for schizophrenia, serotonin is also responsible. They did examination to all the schizophrenia patient and now they have found in a schizophrenia patient there is increased level of dopamine also, increased level of serotonin also. 5-HT is what? 5-hydroxytryptamine. 5-HT is serotonin. Now there was a new hypothesis that there will be increased level of what? Dopamine. Increased level of what? Dopamine and serotonin. So now they made one more drug that was having antagonistic effect. That was having what? Antagonistic effect on D2 and serotonin both. Remember here. Now the new drug, D2 blocker, serotonin blocker also. Since typically it was not blocking dopamine, it was called as what? Atypical antipsychotic. क्या बोलोगे इसको आप? Atypical antipsychotics. Second time it was formulated, so second generation drug, right? No, second generation drug. So can you give me some example of second generation drugs, right? I have taught you in my class also, right? Mnemonic क्या था बताना जरा? Cosrac. Most important drug is what? Clozapine. Remember here, see, this is short form. Cosrac, C for clozapine, O for olanzapine, Z for ziprasidone, R for risperidone, A for aripiprazole, Q for quetiapine. All these drugs, please write down. Please write down and please memorize. Remember, your first generation haloperidol. Keep at least haloperidol in mind. Second generation drug क्या है बताओ? Cosrac. Minimum 6 drugs you have to keep in mind. Most important drug is clozapine. Most important drug is clozapine. Very, 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 very important. Very, very important. Right now, very, very important. Right now, very, very important drug. Okay, fine. Thank you. All right. Please write down here. When I talk about typical antipsychotic drug, no, so neurological side effect. Neurological side effect. You can say extrapyramidal symptoms because of dopamine only. But atypical, remember here, very less extrapyramidal symptoms. Mostly there will be metabolic side effects. Mostly there will be what? Metabolic side effects. What are the metabolic side effects? Increase sugar, increase lipids, hyperlipidemia, hyperglycemia, increase weight gain, sedation, right now, sedation, hyperglycemia, hyperlipidemia. Remember here, for clozapine, we should know some points because this is the most important drug. Remember, this is the best antipsychotic, I'm saying best. Clozapine, first of all, least extrapyramidal symptom. You should know what? Least extrapyramidal symptom. But maximum weight gain. Maximum weight gain. Remember, this is the drug of choice. This is the drug of choice for treatment resistant schizophrenia. Treatment resistant schizophrenia. This is the drug which decreases suicidal, what? Suicidal tendency. In psychiatry, there are only 2 drugs which are anti-suicidal. One is the lithium, mood stabilizer, and another is clozapine, anti-suicidal drug. Okay, lithium is a mood stabilizer drug. All right. Yes, very good, very good, very good. Yes, I can see that most of you are able to answer here. Now, clozapine, okay, these side effects are manageable, but there are some grave side effects. There are some lethal side effects of clozapine, and this you should be knowing. Some lethal side effects like of clozapine or granulocytosis. Seizure, and myocarditis. Granulocytosis means what? Destruction of WBC and neutrophils. Remember, so what does it mean? If you want to start a patient on clozapine, what is the most important blood test which you are supposed to perform? CBC. CBC is mandatory. CB's complete blood count is mandatory before you start a patient on clozapine. Remember here, when you are supposed to, suppose if in the beginning WBC neutrophils were normal, when you are supposed to stop it, when WBC is less than 3500, when neutrophils are less than 1500, please stop. Please stop. Now, one more patient is there who is already on. Carbamazepine. Which is the drug of choice for trigeminal neuralgia. There is already a patient who is on, already on carbamazepine. Now he has started developing psychotic symptoms. Can you prescribe him clozapine? Answer me yes or no. Yes or no? Answer is no. Carbamazepine should never be combined with clozapine. Carbamazepine should never be combined with clozapine. Why? Because for carbamazepine also you should know what are the grave side effects. Carbamazepine, granulocytosis, aplastic anemia. So carbamazepine also, clozapine also, both have same grave side effect. There will be superimposition of what? Destruction of, okay, so destruction of blood cells. So that's why carbamazepine and clozapine should never be combined. Never, never, never. Keep in mind, this can be your pharma question. Very easy to understand. Apart from agranulocytosis, what are the other serious side effects of carbamazepine? Any skin related problem? Can you answer me? Very serious emergency. Carbamazepine, I'm asking. Steven Johnson syndrome, right? Steven Johnson syndrome. Aplastic anemia, so blood related issues also, right? And this can cause what? Hyponatremia also. Hyponatremia also. So whenever you start a patient on carbamazepine, you have to check sodium level. See, now let's talk about carbamazepine and oxcarbazepine. Carbamazepine and oxcarbazepine. Remember, both can cause hyponatremia. But remember, hyponatremia will be seen more in oxcarbazepine. Remember it. This time, INI-CT question. INI-CT question. Hyponatremia is more with oxcarbazepine than carbamazepine. Right? Chalo, fine. Aage badhenge. Okay, fine. So now you tell me clozapine. Okay, clozapine. This is second generation drug. So this is going to what? This is what? This is having what? Antagonistic effect on dopamine as well as serotonin. But one more plus point. This is having partial agonistic effect on dopamine also, partial agonistic effect on serotonin also. Partial agonistic effect. Okay. Main is antagonistic. Main is antagonistic effect. But partial agonist support. So now what is the main function here? To balance dopamine, dopamine, dopamine. To neutralize the dopamine. Okay. So now whenever I'm starting a patient on second generation drug like clozapine, right? All of you, first of all, please write down the full form of COSRAC in chat box. All of you, please write down without seeing the notes. Bolo, COSRAC full form. Clozapine, olanzapine. Dekho, write down. All of you, write down. Yes, clozapine, olanzapine, ziprasidone, risperidone, aripiprazole, quetiapine. Very good. Memorize the name of drug. Psychopharma. 5 to 6 questions will come, I'm telling you. Okay. Now, second generation drug. Suppose if I'm starting my patient on aripiprazole. So what it is going to work here now? It is going to balance, it is going to neutralize the dopamine. See, suppose if it is increased here, so it is going to decrease it or making it normal. If it was decreased, it is going to increase or making it normal. Here also neutral, here also neutral. So whenever we are giving second generation drug, second generation antipsychotic drug, now there will be improvement in positive symptoms also, negative symptoms also. Right now, positive symptoms also, negative symptoms also. So what should be the drug of choice now? Drug of choice for schizophrenia is what? Atypical or second generation antipsychotic drug. Overall best medicine is what? Clozapine. See here, apart from, see, so what can be the side effects of clozapine? Obviously, hyperglycemia, hyperlipidemia, weight gain, sedation, and one more, cyalorrhea also. Cyalorrhea means what? Excessive salivation. Now you tell me, see here, what should be the protocol to start the patient? What should be the protocol to start the patient of schizophrenia, right? Okay, fine. Yes, very good, very good. I can see that most of you are able to answer. Most of you are able. Yes, very good. So see here, see this question and try to answer. Most of you are marking the answer A, right? Very good. 100% wrong. Dr. Karthik, Dr. Shubham Verma, okay. Okay. All of you should try. Who is not responding to clozapine? No, who is not responding to clozapine? Now let's see this. Dekho, what is the protocol? How we are going to start the treatment of schizophrenia patient? Always see step number one. Step number one. Always start with atypical antipsychotic. Always start with atypical antipsychotic drug, except olanzapine and clozapine. Olanzapine and clozapine, I have to preserve it for future. So I can start my patient on any antipsychotic like aripiprazole or risperidone. Okay, fine. After that, I'm calling my patient to come after 6 weeks. But when patient came after 6 weeks, no, there is no response. Now change. Other atypical antipsychotic. Again, except olanzapine and clozapine. Again, you call your patient to come after 6 weeks. Again, when patient came, there is no response. Now, step number three. Now you shift the patient on a typical antipsychotic like haloperidol. Again, you call your patient after 6 weeks. Again, there is no response. Again, there is what? No response, right now? Now, patient will be called as a case of treatment-resistant schizophrenia. Treatment-resistant schizophrenia. Now, what should be the drug of choice? Now, drug of choice should be clozapine. Clozapine is the drug of choice for what? Treatment-resistant schizophrenia. Again, you call your patient after 6 weeks. Again, if there is no response, last option is what? ECT, electroconvulsive therapy. Electroconvulsive therapy. Right? So, what is the answer here now? When patient is not responding to clozapine, then what should be the answer? Last option is what? Electroconvulsive therapy. Remember here, there are different types of schizophrenia. Like, there are different types of schizophrenia. One is called as paranoid type of schizophrenia. Second is a catatonic type of schizophrenia. Third is hebephrenic schizophrenia. Hebephrenic or disorganized. Paranoid, overall, this is the most common type. This is having late onset but good prognosis. Catatonic, motor symptoms are there. Now, this is having best prognosis. What I'm saying here that this is having best prognosis. Hebephrenic schizophrenia, also called a disorganized, this is having early onset, bad prognosis. I'm not saying worst. It is saying what? Bad prognosis. But worst type of personality. Worst personality. What does it mean? You might have seen a naked person running on the road. Right now? You might have seen what? Naked person running on the road who has not taken bath for last 1 month. Right? Playing with the stool, shouting, abusing everyone. So the dirtiest type of person, or that person will be called as a case of what? Hebephrenic or disorganized type of schizophrenia. Worst personality, but bad prognosis. Fourth type, these three you keep here. After that, if you have a patient who does not come under any of these categories, he will be called as a case of what? As a case of undifferentiated. Fifth, simple type of schizophrenia. Simple type, this is rarest type, but Worst prognosis. Worst prognosis. Simply it is schizophrenia. No history of positive symptoms, only negative, negative, negative symptoms, right? Okay, fine. Now, 6 is undifferent. See here, 6th is what? A residual type of schizophrenia. Patient started having positive symptoms, but left only with some residue of negative. 7th is post-schizophrenic depression, which is having maximal level of what? Suicidal tendency. Remember here, ECT, electroconvulsive therapy, no, this can be supportive in all types of schizophrenia. Having said that, if patient is presented to you after 2 years, if patient is having schizophrenia for more than 2 years, no, he will be called as a case of which type of schizophrenia? Chronic schizophrenia. Remember, ECT is not productive here, useless. ECT does not work in long-standing schizophrenia. After 2 years, if a patient is coming to you, or if a patient is having schizophrenia for last 2 years, ECT will not be that much effective, right? ECT will not be that much effective. So remember here, what kind of question? One-liner examiner question examiner can ask. Best prognosis, catatonic. Worst prognosis, simple. Late onset, good prognosis. Okay. In paranoid, personality is preserved. Even in which drug abuse, paranoid type of schizophrenia can be seen. Remember, cocaine. Okay. Hebephrenic, early onset, bad prognosis. So this classification, the 7 types which I have written here, no, this is as per DSM-5 and ICD-10, but there is a new update in ICD-11. As per ICD-11, new classification of schizophrenia is what? If a patient is having first time attack, it is called a first episode. If patient is having attack and one more history is there, before also patient had schizophrenia, multiple episodes. Third, if patient is having many relapses for more than 1 year, then it will be called as what? Schizophrenia continuous. This is what as per ICD-11, new classification. First episode, multiple episode, continuous, right? Okay, fine. Now, see here. Now, what is the definition of treatment-resistant schizophrenia? Treatment-resistant schizophrenia. When a patient is not responding to minimum, equal to a minimum 2 antipsychotic drugs. When patient is not responding to minimum or equal to 2 antipsychotic drugs, patient will be called as a case of what? Treatment-resistant schizophrenia. Now, what should be the drug of choice? Clozapine. My question is that this time, actually in NICT they asked, a patient of schizophrenia was started on antipsychotic drugs. Patient did not respond to 2 antipsychotic drugs. Now patient is started on drug A. After starting the patient on drug A, patient is complaining of hyperglycemia, hyperlipidemia, excessive salivation, weight gain. What is the name of drug A? Please answer, all of you. Name of drug A? Very good. Now you can easily solve, right? Drug A is nothing but, all of you, write down. Jitna samajh mein aa raha likho. Yes, drug A is what? Clozapine. Now you can easily understand clozapine is most important. Don't get confused with clonazepam. Clonazepam is benzodiazepine. That is different. This is clozapine. Very important drug for your exam, for your patients. Now solve this question. Read this question and try to solve. Yes, He developed what? Rigidity, inability to move his eyes. So basically, this is what? A type of extrapyramidal symptom. Type of extrapyramidal symptom. Let's learn all extrapyramidal symptoms one by one. Okay. Which of the following drugs should be added to the treatment? This is the question here. So let's learn about extrapyramidal symptoms. Acute dystonia means what? Sudden muscle contraction. Sudden muscle contraction. Like there can be sudden neck muscle contraction. This is called as what? Wry neck. Also called as torticollis. Like patient will become like this. This is called what? Torticollis. Torticollis. See, there can be what? Jaw lock. Jaw lock. Deviation of eyeball. Laryngospasm. These are acute dystonia. Dystonia. So, what is the drug of choice? We have to give what? Anticholinergic drug. How to treat acute dystonia? Anticholinergic drug injection. We have to give which one? Either we are going to use promethazine. Very, very important. Promethazine. Benztropine. Or even you can go with what? Diphenhydramine. These are the drugs which we are using to treat what? Acute dystonia. Now, acute akathisia means what? Restlessness. Restlessness. Here, patient will not be able to sit at one place. Patient will keep on moving from here to there, again and again, right now. Inability to sit, fidgeting of legs, right now. So there will be symptoms like anxiety, and this is acute akathisia. There can be suicidal behavior also. What is the drug of choice? Beta blocker. Which beta blocker especially drug of choice? Remember, propranolol. Propranolol. Neuroleptic malignant syndrome. Very, very important. What is the meaning of neuroleptic malignant syndrome? You might have learned about this, no? See, there will be what? Very, very high fever. Okay? Very high fever, severe body pain, severe body spasm. There will be what? Sweating. Right now? Very, very high fever. There will be what? Sweating. There can be seizure. If you do blood test, increase level of CPK enzyme. Increase level of CPK enzyme. This is called a neuroleptic malignant syndrome. What is the drug of choice to treat this? Drug of choice is what? Dantrolene. 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 Okay, dantrolene. Very, very important drug. Remember here, all these drugs are important to treat extrapyramidal symptoms. Very, very important. These are acute symptoms, and long-standing, obviously, there will be what? Tardive dystonia, dyskinesia. Tardive dyskinesia means what? Like a rabbit-like feature. There will be what? Face will become like puffy, protrusion of tongue, lips and all. Rabbit-like symptoms, no? Okay, fine. So what to do? See, first of all, anticholinergic drugs should be given. And after that, you have to shift the patient to second generation drugs, because extrapyramidal symptoms are mostly because of what? Third generation drugs. Patient can also develop Parkinson's like symptom because you are decreasing dopamine level. So drug induced Parkinsonism can also be there, right? I hope all these points are clear to all of you. So now can you answer me what is the answer here? What about this question? This is a case of what? Rigidity, inability, acute dystonia. Dystonia, right now? So we have to give which drug? Anticholinergic. Out of these, which one? Promethazine. Promethazine drug. I hope all these points are clear to everyone. Very good. Very good. Now see some new drugs. If patient is having schizophrenia with major depression, new drug is brexpiprazole. If patient is having schizophrenia with bipolar, new drug is cariprazine. Cariprazine, please memorize. If patient is having schizophrenia with Parkinson's associated psychosis, there is only one drug recently approved, pimavanserin. So I have taught you 3 new antipsychotic drugs: brexpiprazole, cariprazine and pimavanserin. Pimavanserin. Please memorize the new drugs. Very, very important. Old question I have asked you before also. Answer please. Capgras and Frigoli, very important. Capgras and Frigoli. Dr. Surbhi Singh B, Dr. Learn with the Sky Singh B, Dr. Lalit, Dr. Adnan, Dr. Zana, very good. All of you are saying Frigoli only, Frigoli, all of you? Okay. One is called a Capgras, another is Frigoli, syndrome of subjective doubles. All these are what? All these are called as delusion of, see, remember here, so especially this is called what? Delusion of misidentification. Especially we have to focus on Capgras and Frigoli. Capgras and Frigoli. See, what is the meaning of Capgras syndrome? He is male and she is female. See, when patient is saying that she is my wife. No, she is not my wife. No, she looks like my wife. So what is claiming here? A real person is replaced by an imposter. It is called as Capgras syndrome. One is replaced by another person. It is called as Capgras. What patient is claiming here? A real person is replaced by an imposter. It is called as Capgras. How to memorize? In a football ground, natural grass is replaced by artificial grass called as Capgras. Remember like this. In the same manner now, Frigoli. Frigoli. Here patient is saying that he is a beggar. No, he is not a beggar. No. He is my brother only. My brother has taken the appearance of a beggar and now he is disguising me as a beggar. So here in Frigoli syndrome, patient is saying what? One person can change multiple appearances. One person can change multiple appearances. Same person can change multiple appearances. That is called as what? Frigoli syndrome. So Capgras, what does it mean? One is replaced by another. Two people are involved in Capgras syndrome. Frigoli, one person can change many appearances. That is called a what? Frigoli syndrome. So what is the answer here? Answer is Frigoli syndrome. Last time in MCI they have asked question, in which type of dementia Capgras syndrome will be seen? Remember here, there is a type of dementia that is called a dementia with Lewy body. Please write down dementia with Lewy body. Here patient will be having maximum visual hallucination. Maximum visual hallucination. Right now, patient is having maximum visual hallucination, so patient can have delusion of misidentification. So remember here, delusion of misidentification can be seen with dementia with Lewy body. Last time MCI question I'm telling, right? Okay, fine. Now one more time. See, do you think all schizophrenia patient will be mentally retarded? No. I have explained you about Professor Nash, John Nash, who got Nobel Prize. And schizophrenia patient can be genius also. But some patients can have schizophrenia with mental retardation also. Mental retardation also, that is called a what? Prof schizophrenia. Okay, and this is a Van Gogh. This is a Van Gogh. Van Gogh was a famous painter. Van Gogh was a famous painter who was suffering from schizophrenia, who chopped his own ear, left ear actually. Okay. So schizophrenia with self-mutilation is called a Van Gogh syndrome. Mostly person will be very much oriented in this schizophrenia. No disorientation, no mental confusion. But in some cases, there can be schizophrenia with disorientation. Schizophrenia with mental confusion. Dream-like state. Oniroid means dream. It is called as oniroid type of schizophrenia. Okay. Remember one more type of schizophrenia. One more scientist was there. His name was T.J. Crow. He divided schizophrenia into type 1 and type 2. In type 1, everything is good. Good prognosis, responding well to medications, right? Type 2, everything will be bad. Bad prognosis, responding bad to medications. Very easy to understand. Type 1, type 2, old type of questions. Okay. T.J. Crow classified schizophrenia into type 1, type 2. Okay. In this manner, we have completed each and every point. See here, I have covered, see here, for first chapter and second chapter, we have spent, we actually spend a lot of time. So, but actually it's worth, I'm telling you, it's worth. Now, and now some small chapters. Eating disorders. How many eating disorders you know? Can you write down in chat box, all of you? Anorexia nervosa. All of you write down, jitne bhi aate hain, likho. Write down all types of eating disorders which I have taught you. Yes, at least you will have anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, and pica. At least these 5 you should know. Out of these, please remember here that overall most common type of eating disorder is a binge eating disorder. Most common type is what? Binge eating disorder. Now, remember when I compare anorexia nervosa and bulimia nervosa, first of all, let's learn about these two. Question is that why there is eating disorder. First of all, eating disorders will be more common among male or female? Much more common among females. Ratio is a 10:1, but this can be seen among males also, right now? Okay, so why they have this kind of eating disorder? Because these people are what? Image conscious, weight conscious, figure conscious. Young girls, especially teenagers, they would like to become what? Like Deepika Padukone, like Angelina Jolie, right now, figure maintaining and all. I know after eating disorder, they will become what? Malnourished Angelina Jolie. Weight loss can be there. But these, remember here, anorexia nervosa, bulimia nervosa, these are what? Image conscious, weight conscious, figure conscious, right? See here, she appears to be very much fine, but whenever she is looking herself into the mirror, she is thinking that, oh my God, I'm becoming fat. So what she will do? She is going to restrict the food. She will not, this is the maximum lunch what she is having now. So either there will be maximum restriction, or even if she is going to eat more, even if there will be a binging. What is the meaning of binging? Binging means what? What is the meaning of binging? Binging means overeating. Binging means what? Overeating. Binging means overeating, right? Overeating. Binging. Yes. So even if she is going to eat a lot, after that, there'll be what? Feeling of guilty, right? There will be what? Feeling of guilty. Now she is going to have what? Now she is going to do what? She is going to vomit out. She is going to vomit out. That is called the purging episodes. So basically, so these are called as what? Compensatory behaviors, right now? These are called what? Compensatory behaviors. Okay, fine. Compensatory behaviors. Either there will be what? Binging. After binging, there will be what? Purging episodes. Purging means what? What is the meaning of purging? To vomit out. She will insert the finger into the mouth. After that, she will vomit out, or excess use of laxatives, right? So now you tell me, if she, first of all, either she is not going to eat, there will be a problem for sure. Yes. If there is maximum restriction, yes, problem there will be there. Overeating and over vomiting also, there will be secondary complications, no? So see, let's learn here, very easy to understand and very important topic. First of all, suppose if I have two patients, patient A and patient B. Patient A is having maximum restriction. Maximum restriction means what? She is eating very less. For last 1 week, she is eating every day only one bread. That's it. See, both are image conscious. What I'm saying is that both are image conscious. Maximum restriction, if there is a maximum restriction, do you think there can be nutritional deficiency? Maximum restriction. So do you think there can be nutritional deficiency? All of you? Yes, there will be what? Nutritional deficiency. Nutritional deficiency. Do you think there can be situation like starvation? Starvation. Yes, there can be situation like a starvation. Right? There will be situation like a starvation. Right? Very easy to understand. Right? There will be a situation like a starvation. Starvation means what? Do you think there will be definition? See, there will be what? Say there will be deficiency of carbohydrate, fat, protein, minerals. Easy to understand? Yes, there will be different. There will be a deficiency of all these. Right. Now, remember here. Now, when there will be deficiency of nutrition, do you think there will be weight loss? There will be weight loss. Yes, weight loss. So, do you think because of these nutritional deficiency, do you think there can be imbalance in hormone also? Yes, there will be what? Decreased level of LH and FSH. LH and FSH. Now tell me, do you think there can be amenorrhea also? Yes, amenorrhea. Amenorrhea can also be there, right? Amenorrhea can also be there. Do you think there can be sexual problem also? Yes, lack of libido, delay in secondary sexual growth. Do you think there can be edema also? Edema. Yes, loss of protein, loss of albumin, right? Now, because of decrease in albumin, there will be what? Edema. Because of loss of nutrition, do you think each and every muscles will also be affected? Yes, heart will also become weak, heart muscle. So, what will happen here now? So, what will happen now? Now, there will be what? Decrease heart rate. There will be what? Decrease BP. Hypothermia also. Hypothermia also. If you see face, okay, forearm and the back, there will be what? Lanugo. There will be what? Lanugo. Okay, very easy to understand. Patient A. Patient B is having more purging. See here, more binging and more purging episode. Basically, she is eating full plate biryani, full plate. But after 3 to 4 hours, she is realizing the fact, oh my God, I have eaten a lot, right? Now you tell me, if after 3 to 4 hours, if she is going to vomit out, do you think there will be a situation like a starvation? No starvation. No starvation. So if there is no starvation, what will happen to weight? Weight will be decreased or normal weight? Normal weight. What about sexual function? Normal. Libido? Normal. Secondary sexual growth? Normal. What about menses? Mostly normal. Sometimes abnormal also. Sometimes, but mostly normal. Okay, fine. Now see here, A was having maximum restriction. A is what? A is anorexia nervosa. B is having more binging, more purging. B is what? Bulimia nervosa. Now, out of these points, now you can easily understand which one is more dangerous. Anorexia is more dangerous or bulimia is more dangerous. Remember here, dangerous. Anorexia is more dangerous than bulimia. But which one is more common? Remember, is bulimia is more common than anorexia. Bulimia is more common than anorexia. My question is that if she is going to insert the finger again and again in the mouth, do you think there can be erosion over the knuckles? Yes, it is called as what? Russell sign. It is called as Russell sign. Do you think there can be the risk of dental caries also? Yes, dental caries. Do you think there can be inflammation of salivary gland also? Salivary gland? Yes, there can be parotitis. Again and again vomiting. Do you think there can be metabolic abnormality? Metabolic alkalosis. Remember here, Russell signs and all these can be seen in both anorexia also, bulimia also, but more common in bulimia. Than anorexia. Remember, all these points are important for your exam. Very easy to understand, right? Remember, earlier there were 2 criteria to diagnose anorexia nervosa. 2 criteria, weight loss and amenorrhea also. Remember, amenorrhea can be seen in approximately 89% people, 89% patient, not 100%. What about the boys boys will be having anorexia there? No problem, right? No. So now there is only one criteria to diagnose. Remember, now there is only one criteria to diagnose anorexia nervosa, and this is what? Weight loss. This is what? Weight loss. How much is the normal BMI? Normal BMI is 18.5 to 24.9. Remember here, if BMI is less than 18.5, 100% patient is suffering from what? Anorexia nervosa. Now there is only one criteria to diagnose anorexia nervosa, and that is what? Weight loss, weight loss, weight loss. Now answer me one question. Suppose if I have a patient in my OPD, I have one patient in my OPD, 17-year-old girl. On examination, I can understand that she is image conscious. Russell signs are also positive. Menses are normal. So far, what is the diagnosis? Menses are normal. No amenorrhea. What is the diagnosis now? Anorexia or bulimia? Bulimia nervous so far. But the fourth option is, if along with all these symptoms, if BMI is less than 18. Now what is your answer? Now answer will become what? Bolo? Now answer will become what? Anorexia nervosa. Anorexia nervosa. Very easy to understand, right now? Because Russell signs can be seen in both, right now? Image consciousness, both, right now? Okay, fine. All right. I hope all these points are clear to all of you. Remember here, because of the image consciousness and all, patient can go into depression also, social phobia also, patient can commit suicide also, right? Okay, fine. Now, are you going to, for the treatment, are you going to admit both or only one? Remember how to treat? How to treat anorexia? Hospitalization is mandatory. What is the most important factor for hospitalization? It is what? Weight loss. Right? It is what? Weight loss. Increase the calorie by 500 every day. Most important, supervise the patient for 2 hours after taking meal, because she can go to washroom and she can vomit out, right? CBT is always most important. You have to what? Motivate the patient to eat well, eat healthy. Suppose if it is not working out, then we can use SSRI, fluoxetine. We can use what? Fluoxetine, SSRI, good food, good mood, good sleep. We can also use a TCA, because in TCA also we are going to increase the level of serotonin, right? Cyproheptadine and antipsychotics like Olenza can also be used. Why? Because their side effect is to increase the weight. Yes, side effect. This is what? Side effect. Bulimia nervosa we can treat on OPD basis. Cornerstone of eating disorder is always what? CBT, CBT, CBT. But if patient is not responding, then last option is what? SSRI. Okay, anorexia nervosa and bulimia nervosa should be clear to everyone. I'm telling you, very, very important, very, very important. Now, can you solve this question? Here also patient is having same symptoms like anorexia nervosa, restrictive type, nutrition deficiency, weight loss. She avoids eating because she does not like the smell of the food. Remember here important thing is what? She is not image conscious. This is the point. This is the point I am telling you. This is the point here. She is not image conscious. Let's see this question. One more disorder is there, that is called as what? That is called as avoidant restrictive food intake disorder. These patients also do not eat the food. But why they are not eating the food? Because they do not like the taste or smell of the food, right now? So remember here, that's why they do not eat, that's why they avoid. It is called as avoidant restrictive food intake disorder, right? It is also called as functional dysphagia. Remember here, same symptoms like anorexia nervosa will be there. Weight loss will be there. So how to differentiate? Remember, these people do not eat because they do not like the taste or smell of the food. That's why they avoid. But they are not image conscious. They are not image conscious. No disturbance of body image. They are not image conscious people. Right? Very easy to understand. Right. So here, answer is what? Answer is avoidant restrictive food intake disorder. Now, look at this patient. Do you think he would like to become like Hrithik Roshan? Obviously, no. Binge eating, foodie people, food lovers. So obviously, weight gain will be there here. Weight gain, right? Now, how to differentiate bulimia nervosa and binge eating disorder? Compensatory behavior in bulimia nervosa is there? Yes, it is there. Binge eating? No, foodie people. Weight in bulimia nervosa? Normal. But binge eating? Weight gain. Now, one question. If patient is having, see here, if patient is having weight loss and image consciousness, what is the answer? Bolo, answer bolo sab log. All of you, without seeing the notes, please keep on writing. Weight loss, image consciousness. Anorexia nervosa. Image consciousness, weight is normal. What is the diagnosis? Bulimia nervosa. Weight loss, no image consciousness. Avoidant, restrictive food intake disorder. Easy to understand. I hope all these points are clear to all of you. Remember here, one more eating disorder is there, that is called a pica. Pica means what? Appetite for non-nutritive substances. Appetite for non-nutritive substances, that is called as pica. Psychological disorder, right now? Okay, fine. When a person can eat brick, chalk, right now, brick, chalk, clay, even hair, even fecal matter, that is called as pica. Now, personality disorders, very, very important. First of all, what is the meaning of personality? Remember here, first of all, personality disorders, mention here that everyone will be having different way of responding to a particular situation, right now? Different way of responding to a particular situation, right? Okay, power of adjustment. So see, almost all of us will be having. Dr. Shubham is asking what is the treatment for bulimia? Yes, for bulimia, first of all, behavior therapy, CBT. CBT. If patient is not responding, then we can go with SSRI and, we can start, like some kind of TC also, right? Okay, fine. Personality disorders, almost all of us will be having some problem, some kind of personality issues. But remember, if it starts hurting you, if it starts creating problem in your personal life, family life, social life, right now, and the professional life, then it will be called as personality disorders. Remember, personality disorders starts in young age, adolescent age, okay? And personality disorders, remember here, young age and personality disorders, these are egosyntonic in nature. Egosyntonic means what? Person is completely normal, agreeable to say, no problem at all, I am okay, you are not okay, I am okay, man. See here since this is egosyntonic, so the patient never wants to take any treatment. Patient never wants to take any treatment. See, now wait for some time. Write down in chat box, what are the new antipsychotic drugs I have taught you? Please write down all of you. Write down all of you. 3 new antipsychotic drugs. Bolo ek baar. Brexpiprazole, cariprazine, and what? Pimavanserin. What is the full form of Cosrac? Write down Cosrac. Full form of Cosrac. Clozapine, olanzapine, ziprasidone, risperidone, aripiprazole, quetiapine. If there will be acute dystonia, what should be the drug of choice? A cholinergic, like, write down. Promethazine, venstropine, or diphenhydramine. Acute akathisia, beta blocker, propranolol. Neuroleptic malignant syndrome, drug of choice, dantrolene. Okay, dantrolene. Very good. So remember, personality disorders start, see here, this will start in young age, egosyntonic. That's why personality disorders patient, they never want to take any treatment. So first of all, I'm going to teach you as per clusters. Okay, as per ICD-10 and DSM-5. First of all, old classification. Cluster A people will appear to be odd, and eccentric. Will appear to be odd. देख के लगेगा कि this guy looks very, very odd. So here there are three personality disorders: paranoid, schizoid, schizotypal. If a person is always suspicious, remember here, always suspicious of other people, always suspicious, right? Now these kind of people, they believe in conspiracy theory. They question on the loyalty of their friends also, and they feel that everyone wants to harm them. So that's why they will always be in the revenge mode. Okay, revenge mode. Remember, paranoid personality disorder. See, now you tell me, when a person is always suspicious about others, without any reason, always suspicious, हमेशा दूसरों पे शक करना, always suspicious about other people. So this will be more common among male or female? Male or female? Always suspicious? Okay, you are writing about females. No, for females it is considered as normal. Normal. Chalo, jokes apart. Remember, paranoid personality disorder is more common among male. Paranoid personality is more common among males. So remember, paranoid is always suspicious, right? They believe in conspiracy theory, right? Always in the revenge. They keep grudges, many grudges. Schizoid people, socially isolated, socially detached, and emotionally cold. And socially detached, right? Remember here. So schizoid people means what? See, schizoid people, these people are emotionally cold, and most of the time these people are what? Socially isolated. Emotionally cold, even if you appreciate, no problem. Even if you criticize, no problem. So lack of sexual activities, lack of family activities, lack of social activities, lack of friends. Schizotypal people, they will appear to be very much odd. Odd speech, remember, everything will be odd. Odd speech, odd dressing, odd thinking process. These kind of people, they believe in magical thinking, very superstitious. They believe in other world also, one more world also. Remember, under super stress, they can have delusion and hallucination also. Oh my God, what I'm saying here, that in this personality disorder, psychotic symptoms are also happening here. That's why, as per a new classification, new update, schizotypal is no more a personality disorder. This is considered as, schizotypal is considered as at the borderline of schizophrenia. Cluster A, paranoid, schizoid, schizotypal. Now cluster B, full of drama. So this will be more common among male or female? Bolo, full of drama and tantrum. So you are writing females, huh? Okay, so I will divide equally. Okay, I will divide equally. First of all, histrionic people. Histrionic obviously more common among female. Histrionic means what? Full of drama, full of tantrum. Okay, remember here, full of drama, full of tantrum. Most important is what? They will be having what? Attention seeking attitude. Why they are full of drama? Why they will behave in, like in an extrovert manner, emotionally labile manner? They will exaggerate everything for simple thing. They will make something like, oh my God, what has happened? That is what? Histrionic. Why they are behaving like this? To get attention. If they do not get attention, they can start behaving in seductive manner also. There can be suicidal gesture. What I'm saying, suicidal gesture means what? Only acting. No real suicide. A girlfriend is asking her boyfriend that if you are not going to take me out for shopping, I will jump from ground floor. Eh? This is called as what? Suicidal gesture. Only gesture, right? No? Attention-seeking attitude full of drama. Narcissistic, this is more common among male. This is more common among male. Remember only one word, self-love. Excessive sense of self-importance. I am this, I am that, I am the boss, I am this, right? This is narcissistic personality. Right now, self-importance, excessive self-importance. They always anticipate admiration from other people. Means everyone should be talking about me only, me only, me only. If these kind of people are standing with their friends, everyone should be speaking about them only. This is what narcissistic. These kind of people can be selfish also, right now. I remember here, these kind of people are emotionally fragile. Emotionally fragile. Emotionally fragile, so they can easily slip into depression also. Now, antisocial personality disorder means what? These kind of people are involved into illegal activities like a robbery, stealing the objects, fight with other people. Antisocial, old name psychopath, sociopath, right? Antisocial. This is also called as dissocial. This is also called as a dissocial personality disorder. So obviously these kind of people, they do not have any regards for other people. They do not feel guilty about their action, right now. Substance abuse, especially alcoholism, is very common. Remember, there can be history of conduct disorder when he was a child. Conduct disorder. Antisocial means what? Age should be more than 18. Conduct means what? Age should be more than 15. You might have seen a child, very aggressive child, very aggressive, violent child, harming plants and animals. That is called as what? Conduct disorder. Borderline personality disorder. Remember here, this is more common among female. Frequent mood swings without any reason. Frequent mood swings without any reason. This is also called as emotionally unstable personality disorder. Emotionally unstable personality disorder. Very, very important. Frequent mood swings without any reason. See here, like when you look at this photo, now you can understand this man. Even he does not know why she is shouting. Frequent fights, frequent breakups, extreme level of emotional lability. Right? This is called about borderline personality disorder. There can be self-destructive activities also, slashing of wrist, overdoses of medicine. So please write down here, suicidal tendency can be seen. Suicide can be seen in borderline also and antisocial also. Drug abuse can be seen in borderline also, antisocial also. Very, very easy to understand. I hope all these points are clear to all of you. Here we are, see here, borderline personality disorder. If you do not treat on time, there is very high risk of developing what? Bipolar disorder. So how to treat? First of all, see, for all personality disorder, first of all, how to treat? Psychotherapy. Psychotherapy. Apart from that, as per the symptoms, we have to start medicine, right? Borderline, we have to start mood stabilizer also, antidepressant also, sometimes antipsychotic. One behavior therapy for borderline. For simple behavior therapy, we have CBT, cognitive behavior therapy. For borderline, we have what? DBT, dialectical behavior therapy. We motivate the patient not to harm. Dialectical behavior therapy. Last cluster C, these kind of people will always be anxious and fearful. Avoidant means what? Fear of rejection. Suppose if a first year MBBS student, 17-year-old boy, he proposed 17 girls and got rejected everywhere, right? After that, do you think he will develop fear of rejection? Yes, fear of rejection. Fear of rejection. That's why these kind of people will avoid meeting other people. No, avoid. That's why they will be having what? Lack of confidence. Dependent, seeking excessive amount of advices from other people. For simple thing, these kind of people will always be dependent on other. Okay, dependent personality. Obsessive and compulsive personality and OCD of contamination, both are different. OCD of contamination is what? Ego dystonic. But obsessive and compulsive personality is syntonic. Here a person will be showing what? Perfectionism. Perfectionism. Person will be focusing more on minute details. Minute details. For everything, they will be showing what? Perfection. That's why they will always be delayed. They will always be late in delivery of the task, right? Obsessive and compulsive type of personality disorder. Personality disorder. So see, remember here, cluster A, cluster B, cluster C as per old pattern. Old pattern. But as per a new pattern, as per ICD-11, ICD-11 has removed ABC. ICD-11 has classified as the mild, moderate, and severe. Mild, moderate, and severe. This is a dimensional approach. Suppose earlier a person was there who was only harming plants and animals. Mild antisocial behavior. After that, he did robbery. Moderate antisocial. After that, he did murder. Severe antisocial. This is the new classification. Okay, fine. Now, which of the following is incorrect? Answer, please. Yes, Dr. Sara is here. Hello, hello, good evening. Dr. Adnan, Dr. Shubham, Dr. Helping Healing Hands. Yes, very good. Dr. Helping Healing Hands, less than 15 for conduct disorder. For conduct disorder. See, personality disorders, I have explained you everything. Cluster A, cluster B, cluster C. Now the new classification is what? Mild, moderate, and severe. One more classification. See, one more classification is there. Person can be type A, person can be type B, person can be type C, person can be type D, and type A. Type A, full of competition. Full of competition. Very competitive, very ambitious. Right now, so, and sometimes you might have seen these kind of people, like these kind of managers, like they will be talking with their, like they will be talking with their managers, they will be talking with their employees. Hey, do it fast. I don't have this much time. Always time urgency they will be having, right? So see, full of competition, very competitive, very ambitious, right? No, very ambitious, right? Okay, fine, very ambitious. At the risk of heart attack in future, coronary artery disease, at the risk of myocardial infarction, at the risk of a stroke. Type B people, easy going, entertainment, no risk of heart attack. Relaxed people, cool people, type B. Type C means what? Stressed people, stressed. Every time you will see these kind of people will be full of stress. Right now, full of stress. So these kind of people, they keep all the emotions inside, and emotions are like energy. If you are keeping all the emotions inside, no, there will be what? Weak immune system. They are at the risk of cancer in future. Cancer in future. Type D, depressed people. Negative thoughts. They are also at the risk of heart attack in future. Coronary artery disease. Type H, you might have seen in every batch, there will be a self-claimed monitor. A person who wants to control other people. Hardiness type personality. That is called a type H. Personality disorders, I have completed everything. Now, which of the following is incorrect? Egosyntonic? Yes. Schizotypal is no more a personality disorder? Yes. New classification is mild, moderate, and severe? Yes. Other psychiatric illness associated with narcissistic, remember here, narcissistic personality disorder, no? These people are emotionally fragile. They will not be able to tolerate even the simple criticism, and they can easily slip into depression, not OCD. Remember here, they are at the risk of depression. Sleep disorders. The next topic, sleep disorders. There are two types of sleep pattern, REM and non-REM. REM and non-REM. Rapid eye movement, non-rapid eye movement. See, remember here, first of all, we should know there are two types of sleep disorder. One is called as dysomnia. Another is called as parasomnia. Dysomnia means what? When sleep is the problem. When sleep is the problem. Like insomnia and hypersomnia. So can you define insomnia first of all of you? How to define insomnia? Very, very important for your exam, and you might be suffering also right now. Insomnia means what? You are going to bed at 9 p.m. and falling asleep by 1 a.m. again and again in the night. So what does it mean? There is problem in sleep induction. Problem in sleep induction. Sleep induction problem. You are not able to maintain the sleep because every time you are having dream, oh my God, result out, oh my God, hall ticket didn't come, oh my God, so every time, oh my God, 114, oh my God, 153. Basically, again and again, you are getting up in the night time. So you are not able to maintain the sleep. You are not able to maintain the sleep. Okay? You are not able to maintain the sleep. See, there can be early morning awakening. Patient will say, sir, earlier I used to get up by 7, but these days without alarm, I am getting up by 5. Early morning awakening, classically seen in depression. Fourth point, non-restorative sleep. Patient is saying, what, sir, I am sleeping for 5 hours, but I do not feel fresh. Depression. So these are the definition of, and so insomnia. How to treat? We can give benzodiazepine. But benzodiazepine is having what? Severe addiction. That's why now we are using what? Z compounds. All of you, please write down some examples of the benzodiazepine. All of you, please write down some of the examples of benzodiazepine. Likho. All of you, all of you. Alprazolam, clonazepam, diazepam, lorazepam, oxazepam, clodiazepam, all these. Dekho, for every group of the drugs, you should know 4, 5, 6. Okay. What are the Z compounds? There are only 3 Z compounds: zaleplon, zolpidem, isozopiclone, Z compound. So remember here, benzodiazepine is having severe addiction. This is having what? Severe addiction. That's why here maximum we are giving to the patient for 2 to 3 weeks. Ideally, we should stop before 2 weeks, because after 2 weeks there is very high risk of dependency. That's why we are using Z compounds. Now melatonin agonist receptor is also there. No, melatonin receptor agonist, which one? Ramelteon, right? Ramelteon. Very easy to understand. These are the drugs which we are using for what? Insomnia. Now, one syndrome which is associated with insomnia, can you answer me? When patient is sleeping, where he is having what? Sensation of insects around his legs. Sensation of insects around his legs. And because of this, he keeps on moving his legs and he is not able to maintain the sleep. What is the diagnosis? This is called as what? Answer, please. Ekbom syndrome. It is called as what? Ekbom syndrome. Restlessness, feeling of sensation around the legs, right? Ekbom syndrome, also called as what? Restless leg syndrome, delusional parasitosis. How to treat? Okay, remember dopamine agonist we are giving ropinirole, dopamine agonist. Okay, we can also use the pramipexole. Remember, all these points are important. Now, let's learn about parasomnia. Parasomnia means what? Abnormal events during the sleep. It can happen during non-REM means what? Non-rapid eye movement sleep. Non-rapid eye movement sleep, right? Deep sleep basically, right now delta wave will be more prevalent here. Deep sleeps where person is not able to recall anything, almost unconscious. Patient does not remember anything, right? There can be what horrible level of dream that is called a power nocturnus. Sleepwalking, somnambulism, this occurs here only. Bruxism, teeth grinding, sleep talking, somniloquia. Sleep-related enuresis, bedwetting. The question is how to treat all these. Mostly these are related to young age. As per the age, patient will improve. What about bed-related enuresis? Bedwetting. We can use a medicine that is called as desmopressin. But if examiner is asking you what is the treatment of choice for bedwetting, answer should always be bed alarm. Answer should always be what? Bed alarm. There is a type of bed alarm. What kind of bed alarm here? See here, like either mother is going to keep an alarm, and after every 2 hours she is getting up and she is going to take the baby to washroom, right? And one more bed alarm is there. See here, like there will be a small electronic chip. This will be implanted in the underwear of the patient, like underwear of the child. Whenever even a single drop of liquid is going to touch that, no, after that there will be what? Heavy, no, after that patient will get up, that child will get up, right? So in this manner, child will become very, very cautious. And yes, remember here, treatment of choice is what? Bed alarm. Bed alarm. Parasomnia during a REM sleep, nightmare. This is milder form of horrible dream. Nightmare patient will be able to recall, but what about power nocturnus? Will not be able to recall. Even narcolepsy also mostly we see during REM only, right? Okay, all these points are important related to your exam. Now, see what will be the symptoms in narcolepsy. You have to be careful that, see here, 4 symptoms you have to keep in mind. 4 symptoms. Okay, 4 symptoms you have to keep in mind. See, narcolepsy means what? First of all, patient will have, see here, first of all, there are 4 stages of non-REM. Stage 1, then stage 2, then stage 3, then stage 4. After that there will be repetition of a REM. This is, see, this duration is how much? This duration, this is called as a REM latency. This will take minimum 90 to 100 minutes. This will take how much? 90 to 100 minutes. So after every 90 to 100 minutes, if there is a repetition of REM cycle, it is normal. But what if REM cycle is reduced? REM latency is reduced less than 60 minutes. So within every 1 hour, patient is getting up again and again, again and again, again and again. So mostly patient is in a REM only, no? That's why patient is having what? Hallucination also, right? No? Hallucination before going to bed and before getting up, right? Patient can have catalepsy. Catalepsy means what? Sudden muscle contraction. Sometimes, say yes, suppose there will be severe sudden muscle contraction of a lower limb, person can fall in the ground also. So like some kind of the jerky movement, patient was having something in his hand. Whenever you are going to speak some kind of emotional thing to your patient, oh yes, oh yes. So this is what? This is called a cataplexy. Most common symptom is what? Sleep attacks. Most common symptom, irresistible urge to sleep again and again. बात करते करते सो जाए. Hypnagogic, hypnopompic hallucination. Sleep paralysis most dangerous. Eyes are open, but patient is not able to move his upper limbs and lower limbs. This is called about sleep paralysis. So there are 4 symptoms of narcolepsy. Narcolepsy is important. Narcolepsy is important. Okay, remember here. Okay, fine. So over, what is the root cause here? First of all, decreased or reduced latency of REM sleep. REM sleep. How to treat? We are using which drug here? Especially modafinil. Modafinil. Remember here, gold standard method to study sleep pattern is what? polysomnography. Polysomnography. Remember here, polysomnography, where we have to check intraocular movement also, ECG or heart rate also, brain wave also, EEG also, SpO2 also, all movements basically. Remember, we have to check saturation of oxygen, not the carbon dioxide. Now, mood disorders. See here, especially we have to look for these 5 major mood disorders. A patient is having only depression, severe depression, it is called as major depression. This is what? Unipolar. Patient is having depression with mania, it is called a bipolar. Milder form of mania is called as hypomania. Milder form of or you can say what, less severe form of bipolar disorder. This is called a what? Cyclothymia. In the same manner, milder form or less severe form of major depression, it is called as dysthymia. Keep in mind, duration criteria is extremely important. Symptoms for more than 14 days, major depression. For bipolar disorder, equal to or more than 7 days. Hypomania, 4 days. Cyclothymia and dysthymia, symptoms should persist for more than 2 years. More than 2 years. Now, see, now you can ask me, what is the meaning of dysthymia? Major depression, yes, we are going to see major depression. Yes, we are going to discuss very soon. But let's understand the meaning of cyclothymia. Milder form of bipolar. Dysthymia means what? Milder form of major depression. What does it mean? And I'm saying duration should be more than 2 years. Suppose if there is a new engineer, 23-year-old male, he's saying, doctor, you know one thing, since my BTech, since my college, since my first year, I never used to enjoy. My friends used to have fun, but I never used to have that much. Basically, most of the time I used to be hopeless only. I never used to enjoy. Now, if I'm asking my patient, see, so did you had suicidal thought? No. Weight loss? No. Milder form of major depression for more than 2 years is called as dysthymia. Remember it. Now, hypomania and mania. How to differentiate? Hypomania is what? Mild. Mania is very serious. Remember, mania, hospitalization can be needed. Hypomania, not needed. Mania, psychotic symptoms can be seen. Delusion, hallucination. Here, hypomania, no. See here, normal activities or daily life. Okay, now life activities will be affected. Hypomania, not affected. Duration criteria for mania, more than 7 days. Hypomania, more than 4. Very, very easy to understand. Remember here, when I talk about major depression, this is more common among females than males. What is the most common age group? Mid-age group. After 35, or you can say on an average 40. But when I talk about bipolar disorder, this is more common among male than female. Almost equal, but slightly higher among male. And this is a young age. See here, remember, this is a young age. Mania is more commonly seen in young age people, less than 25. Keep in mind, major depression, mid-age. Remember, all these points are important. Major depression is responsible for maximum daily disability adjusted life year. Why depression is happening? Due to decreased level of serotonin, norepinephrine, and somewhat dopamine also in limbic system. Remember here, there is one more neurotransmitter that is called as BDNF, brain-derived neurotropic factor, which I have taught you in detail during the class. Remember, increased level of BDNF will cause mania, decrease will cause depression. BDNF, brain-derived brain-derived neurotropic factor, right? No, brain-derived neurotropic factor. Okay, Dr. Adnan, yes, suicidal tendency is seen in mania. Very good, very good. Yes, so mania is actually what? Very much violent, very much aggressive, right? No, so very much serious, right? All right. I hope all these points are clear to all of you. Now, let's see this question and try to answer. Answer, please. Yes, I can see that most of you are marking the answer as what? See, atypical depression you are saying, right? Atypical depression you are saying. Okay, fine. Chalo, theek hai. We can discuss. Yes. See, remember here, there are different types of depression. First of all, most important is what? See here. See here. Suppose you would have heard, no, that in depression, patient is eating a lot or patient is not at all eating. Patient is sleeping a lot or not at all sleeping. But when I talk about typical depression or typical patient will not eat, patient will not sleep. Typical depression, lack of mood, lack of food, lack of sleep. That's why there will be what? Lack of energy. That's why lack of attention, lack of concentration, lack of judgment power. That's why there will be what? Remember, there will be what? Negative thoughts also. Negative thoughts also, right? See here there will be what? Severe feeling of guilt. Severe feeling of guilt, right? So obviously now suicidal thoughts will be there. And when patient is not eating, when patient is not sleeping, obviously there will be what? Weight loss. There will be what? Weight loss. There will be weight loss. Remember here, out of these symptoms, most important you have to keep in mind suicidal tendency, weight loss, and yes, lack of mood. Afterwards, this can converted into anhedonia also. In the beginning, lack of mood. Last time there was the question, what is the key feature of depression? What is the key feature of depression? Can you answer me? Lack of mood, suicidal tendency, anhedonia, or weight loss? What is the key feature? Without loss of mood, without lack of mood, how there can be depression? See here, anhedonia will take some time. Suicidal tendency will take time. From the beginning to the last time, lack of mood will be there. Low mood, basically sadness. So lack of mood, please write down. This is key feature of depression. Key feature, low mood, lack of mood or sadness. Very, very important. Anhedonia will take some time. First of all, lack of mood, low mood. Out of these, if equal to more than 5 symptoms are there, for more than 14 days, 100% patient is suffering from what? Typical depression. Typical depression. Now, there is a type of depression where there can be reverse of biological symptoms. Reversal biological symptoms. Now, patient is eating more, hyperphagia, sleeping more, hypersomnia, right? No, hypersomnia, right? No, hypersomnia basically, say when I talk about narcolepsy, no, narcolepsy means what actually? What? Sleeping a lot, or hypersomnia type, right? Okay, fine. So here also patient is sleeping a lot, sleeping, because he's eating a lot. So there is what? Weight gain. In typical depression, every time patient will be having lack of mood, low mood. But in atypical, no, if something good will happen at home, any marriage, birthday party, or any good thing, patient will start feeling happy. This is called as what? Reactivity of mood. This is called a what? Mood reactivity. Sometimes there can be feeling of discrimination. Patient will complain his family members that you people are not loving me anymore. You people are not caring about me, right? That is called interpersonal sensitivity. Sometimes patient will say, sir, I'm sitting in a corner and I'm not able to lift my hand like this, so heavy. Heaviness of limbs, it is called as what? Laden paralysis. Laden paralysis. Very, very important. Remember, for all depression, first line of management is always SSRI, SSRI, SSRI. But atypical depression, no. First line is what? MAO inhibitor. After that, SSRI. Now, one more typical type of depression, melancholic, which is what? Old age depression. Which is what? Old age depression. Melancholic means what? This is English word. Melancholic means what? Isolated, alone, sad. In which age there will be, more isolation? Old age, right? No, old age. Here, person will be having severe feeling of guilt. Severe feeling of guilt. Remember, miserable feeling will be there. This is the most important word related to old age. Miserable feeling. Miserable feeling. Profound feeling of guilt. Here, old person will be having this kind of thought process that I could not make so much money. I could not make good relations and all, right? So miserable feeling, see here, early morning awakening and very, very high risk of suicide. So keep in mind different types of depression: typical depression, atypical depression, melancholic depression. Very easy to understand, right? Now, see, if you see depressed patient, no, you look at forehead, physical signs. Every time they'll be like this, no, like this. So because of this, what can be there here? There can be what? Contraction of muscles here, forehead muscle, like procerus muscle. You will see something like this over the forehead. This is called as omega sign. Like this, omega sign. Near the nasal corner, even orbicularis oculi, upper eyelid can become like this. This is called as what? This is called as Viragatford. So there are two physical signs of depression. There are two physical signs of depression. Omega sign, Viragatford. This can be your image-based question. How to treat? These days, drug of choice is SSRI. Okay? And when to take a decision to start the patient on SNRI? When patient, see, in the beginning I have taught you, when patient is having what? Lack of energy, lack of motivation, lack of drive. Then SNRI. What are the two examples I have explained you about SNRI? Can you tell me answer? Venlafaxine, desvenlafaxine. MAO inhibitor. Related to MAO inhibitor, there was question last time, FMG. Okay. First of all, understand, along with when patient is already on MAO inhibitor, along with MAO inhibitor, which food beverages should not be given? Remember, when patient is already on MAO inhibitor, no, we should not give what? Cheese, red wine, or beer, right? Why? Because there is something called as what? Tyramine, which is having sympathomimetic activity. See, when a person, see the tyramine, when a person is going to consume cheese, red wine and beer, no, after the there will be what? Release of tyramine that can easily be digested by monoamine oxidase, which is there in the GIT. Easily it can be digested. But when patient is on monoamine oxidase inhibitor, no, like salicylic, when patient is going to have cheese or red wine, no, now there will be release of tyramine. Monoamine oxidase inhibitor is there, no, so no metabolism of, no digestion of tyramine, and tyramine can escape to systemic circulation. This is having sympathomimetic activity, and what it will do, it is going to increase the blood pressure like hell. That can, see, this can cause what? Lethal hypertension. Lethal hypertension. This is called as what? Cheese reaction. This is called as cheese reaction. How to treat? How to treat this? Phentolamine, right? This time, yeah, so this was the question last time. Now, remember here, earlier we were using TCA. What is the full form of TCA? Tricycling or tetracyclic antidepressant. Like you can take the example of imipramine, amitriptyline, amoxapine. Now TCA is not the first line drug. Why it is second line drug? Very, very important. TCA is not good for the patient, but TCA is good for the medicos, because TCA toxicity will become your question. Remember here, TCA was, see here, now you should understand, TCA was inhibiting, it was blocking serotonin and norepinephrine. Ideally, it should be increasing only these two. Yes, it was increasing these two. When it was increasing these two, my patient would have been what? Very, very much happy. But problem with the TCA is that this is also having antagonizing effect on muscarinic receptor. Antagonizing effect on muscarinic receptors. Histaminic receptor, alpha 1, alpha 2, sodium gated channel of heart, and it is also causing metabolic acidosis. This time INICT question also. Remember here, now we are going to understand here TCA toxicity. Remember here, now because of muscarinic, when there is what? Anticholinergic side effect, patient is saying what? Doctor, the medicine which you have given me, amoxapine, after this, I'm not able to see clearly. I'm having blurred vision. I'm having dry mouth, dry belly, constipation. I'm having a urinary retention also. So a patient of BPH is there with depression. Can you start the patient on TCA? No. A patient of glaucoma is there with depression. Can you start on TCA? No. Simple. Okay. This is also going to disturb the sweating, the sweating mechanism, right? It is also going to disturb thermoregulatory center. So there will be what? No sweating. So because of this, there will be what? Hyperthermia, not hypothermia. Remember here, see, it will cause what? Hyperthermia. See, this will cause what? Hyperthermia. This is also cause mydriasis. Because of histaminic, patient is complaining what? Is the medicine which you have given me, every time I'm sleeping. Sedative effect. Because of alpha 1, patient is having low BP, hypotension, every time giddiness. Because of sodium gated channel problem, patient is complaining of what? Severe palpitation. There is having arrhythmia. Because of tissue hypoxia, it is calling. See, this is going to cause what? Metabolic acidosis. So if I ask you, if you have a patient of TCA toxicity, which investigations are mandatory? First of all, the ECG, mandatory, you have to do. ABG, yes, you have to do. Right? No, ABG, why? Metabolic acidosis, very, very dangerous, very, very dangerous, right? So when you do ECG, everything will be increased. Wide QRS, wide PR interval, right, axis deviation and all. So ECG, metabolic acidosis. So how to treat the patient? How to treat the case of TCA toxicity? Serum alkalinization. Injection of what? IV sodium bicarbonate. Remember, TCA toxicity, very, very important topic for your examination. How to treat TCA toxicity? Serum alkalinization. IV injection of what? Sodium bicarbonate. Very, very important. Please remember here all these signs and symptoms. This time in NICT they have asked, which of the following symptoms cannot be seen in TCA toxicity? One option was mydriasis. Second option was there hypotension. Third was there somewhat, I think, arrhythmia. And the fourth was there hypothermia. So answer will be what? Can I say answer will be what? Hypothermia, right? Because here there will be what? Hyperthermia. More side effects you should know here. See here, because of excess of serotonin. See here, every time it should be stable. Excess of serotonin. Now remember here, there can be what? Disorientation also, mental confusion also. There can be seizure also. Remember, all these points are important related to TCA. Okay, fine. Now let's solve some questions related to treatment of depression, antidepressant drugs. So can you solve this question now? See this question and try to solve, all of you. I can see that I'm taking longer duration for the class, but I'm telling you, like we are going to solve all the questions in exam, okay? Most of the antidepressants will be having sedative side effects. But remember this point that SSRI and SNRI will decrease the duration of sleep. Decrease the duration of sleep. I'm not saying they cause insomnia, no. They decrease the duration. So remember here, option A, B, TCA, mirtazapine, and option D, trazodone. Write down A, B, and D. They will cause a sedation. They are going to increase the sleep duration. They will cause more sedation. So if you have a patient with depression, like suppose if you have a patient of depression with insomnia, which drug you should be choosing? Mirtazapine or either option number D or TCA. Remember here, but if there is a patient with depression, with hypersomnia, then you can choose what? Option number C, SSRI, SSRI. Last time they have asked one question in NEET PG, which antidepressant has a side effect of priapism? Answer is trazodone. Side effect of what? Priapism. What is the meaning of priapism? Painful erection. Next question. See, most of the antidepressant drugs will increase the weight, except few. Can you solve this question? Remember, especially you have to remember at least two drugs. Only one SSRI, which is neutral to weight, fluoxetine. And one more drug, bupropion. These two drugs are there, these drugs are what? Neutral to weight. So answer is what? C. Answer is C. Bupropion is NDRI, noradrenergic dopamine reuptake inhibitor. Remember, bupropion we are using in what? Depression, very important, ADHD, and anti-smoking drug also. Anti-smoking drug. Remember, all these points are important. Next question. See, this was the question of MCI. Can you solve this question and answer? Patient is complaining of what? Sexual side effect. Sexual side effect. So now you are going to switch the patient to which drug? Imipramine is what? TCA. Venlafaxine, SNRI. Escitalopram, SSRI. What about bupropion? It is what? NDRI. Keep in mind. See, always keep in mind. Any drug which is going to increase the level of serotonin. Serotonin can affect both testosterone as well as the dopamine. Dopamine is responsible for the kick, no? Dopamine is responsible for kick, for orgasm. There will be kick obviously after the orgasm, right now? So remember here, increased level of serotonin is going to disturb both dopamine is also and testosterone also. So if there will be what? Any drug which is going to increase the level of serotonin because of what? Dopamine alteration, what will happen? Difficulty in achieving the orgasm. Difficulty in achieving the orgasm. Testosterone, what is the side effect here? Now lack of libido, erectile dysfunction. So any drug which is going to increase the level of serotonin, that will be having sexual side effect. This is TCA, it will increase serotonin for sure. Venlafaxine, serotonin. Escitalopram, serotonin. In bupropion, do you see serotonin? No, noradrenergic, dopamine reuptake inhibitor. So bupropion is having what? Least sexual side effect. Remember here, see here, SSRI, obviously sexual side effect will be there. What are the most common sexual side effect? Delayed ejaculation. Why? Because it is affecting what? Dopamine. Delayed orgasm. Very easy to understand. So what are the antidepressants which have lesser sexual side effect? First of all, bupropion. Bupropion, very, very important. After that, mirtazapine, trazodone, agomelatine, vilazodone, or vortioxetine. Remember, all these drugs you have to memorize. They have lesser sexual side effect. Most preferred is what? Bupropion. Now see this question. What is the answer here? Bolo. You are saying postpartum psychosis? Yes, most of you are saying what? Postpartum. Most of you are saying what? Postpartum psychosis. Yeah, this is the right answer. Very good. Remember here, last time also there was question related to postpartum blues or psychosis they have asked. See here, postpartum, very, very important. Psychiatric aspect of pregnancy. There can be postpartum blues, postpartum psychosis, postpartum depression. Most common is, see, remember, most common is postpartum blues. Okay, this is BPD. So let's understand here that whenever there will be postpartum blues, postpartum blues. See here, this can be seen in approximately 75% of the mother after delivery. Okay, but this is happening within 1 week, within 3 to 5 days. This is important. Duration is important. Do you think there will be the tearfulness? Yes. Sleep problem? Yes. But do you think there will be suicidal tendency or thought of harming the baby? Depressive episodes? Risk of depression? No. So how to help? Only emotional support. But when we talk about postpartum depression, this can occur in approximately 10 to 15% of the mother. But duration, this can happen very, very late, within 3 months after delivery. 3 months, I'm saying 3 months. Are you going to see tearfulness, anhedonia, sleep problem here? Yes. Are you going to see suicidal tendency in mother? Thought of harming the baby, depressive episodes in future? There's the risk of episode. Yes, for everything it will be there for sure. Yes. Symptoms of postpartum depression with delusion and hallucination. This is called as postpartum psychosis. But duration of postpartum psychosis is within 3 weeks. Now understand here, postpartum blues will happen in 3 days. Postpartum psychosis, 3 weeks. Postpartum depression, 3 months. 3 months. Remember it, very, very important. Okay, now very, very important. Now you can easily understand this question and answer here. See here. Here she's claiming what? Her baby is not the real one. Someone has already stolen. Means nihilistic delusion, Cotard syndrome. 20 days within 3 weeks. So this is a case of what? Postpartum psychosis. Now see, remember here, for depression, yes, we can use what? For depression, we can use ECT. But the question is that ECT can be used in all cases of depression? In all cases of depression? Not all cases of depression. Remember here, In which condition it can be used? If there is a depression with a suicidal tendency, depression with psychotic symptoms, depression with stupor, or if patient is not responding to other modalities of treatment. Okay, ECT. But remember here, for ECT we have to give anesthesia. There are some side effects, right? Now methotrexate we are using, so that's why we have a new procedure now. This is called as what? TMS. TMS full form. What is the full form of TMS? Transcranial magnetic stimulation. Here we are using what? Magnetic field to stimulate the nervous system. Here no need of anesthesia. Remember, here side effect will be what? TMS, headache only. Next. Now see this question. See this question and try to answer. Answer please. Okay. Yes, this is a case of what? See here, when a person is what? Hyperactive. When a person is what? Hyperactive. Working a lot, right now. See, remember, yes, this is a case of what? Actually, mania. This is a case of what? Mania. Mania. Let's understand the meaning of mania. See, mania means what? Mania means what? Hyperactivity. See, person will be what? Hyper, over talkative, overwork, right now, over sexuality. See, whatever person will be doing, he will be doing a lot. Over religious activities, over donation, over charity, over shopping, foolish business investment. But remember here, person will be working a lot, but he will not feel tired. Why? Because mania, see, in mania, what will happen there? There will be increased level of dopamine. Increased level of dopamine. Okay. So, and there will be obviously flight of ideas will be there. Remember, you should know decreased need for sleep. When person will be sleeping only for 2 to 3 hours, 2 to 3 hours, but full of activities, full of energy. Why? Because of dopamine. So decreased need for the sleep will be there. Mania means what? Hyper. Okay, fine. Now the question is that, see, now related to mania, treatment protocol is important. My question is that if you are receiving a patient of acute mania in emergency department, if there is a patient of acute mania, he is very hyper, he is very loud, he is very much destructive, shouting, screaming, he is very much violent, very much aggressive, what should be the first line of management? What should be the first line of management? Bolo, which drug will you give at first? Suppose if you are thinking lithium, okay, you can give mood stabilizer. Okay, chalo, one more point here. Out of these symptoms, no, minimum symptoms, like it should be 3 to 4 symptoms for more than 7 days. Okay. This is the criteria. Question is that, but if a person is very hyper, for bipolar, for mania, okay, no, for mania, we can give what? Mood stabilizer. My question is that if a person is having only depression, we are calling it what? Unipolar. If I'm saying if a person is having only mania, can we call it unipolar or bipolar? Always keep in mind, mania never occurs alone. If a person is having mania, no, depression will be accompanied for sure. So remember, once a person is bipolar, he is always bipolar. If a person was having depression for last 4 years, he will be called as a case of what? Unipolar major depression. Unipolar depression, unipolar depression. But even one episode of mania will be there. Now he will always be called as a case of bipolar, bipolar, bipolar. So mania is always bipolar. Okay. So we can use what? Then like mood stabilizer. Okay, fine. So first of all, write down a few mood stabilizers. Most important is which one? Lithium, valproate, carbamazepine, and lamotrigine. Out of these, I hope all of you know that lithium is gold standard drug, gold standard mood stabilizer, best. Anti-suicidal also. But lithium is a notorious drug also because of narrow therapeutic index. My question is that lithium can be given during pregnancy or not? Because as we have learned in pharmacology that lithium can cause teratogenic effect like Abstein's anomaly. My question is that lithium can be tried during pregnancy, yes or no? Yes or no? Bolo. Remember, although lithium is a notorious drug, although it can cause Abstein's anomaly, but it can be tried. It can be given even during pregnancy because Abstein's anomaly it can cause, but how much is the ratio? 1:1,000. 1:1,000. Ratio is very, very much less. Okay, 1:1,000. So yes, lithium can be given even during pregnancy. Remember, which mood stabilizer should never be tried, should never be given during the pregnancy? Valproate, because it can cause what? Neural tube defect. Which one? Spina bifida. Spina bifida. What is the safest mood stabilizer? Safest is what? Lamotrigine. Safest is lamotrigine. Okay, fine. Remember here, in acute condition, if you are giving lithium, now how much is the half-life of lithium? Can you answer me? Lithium half-life, how much? 1.3 days. But lithium will achieve its plasma concentration after 3 to 4 half-lives, no? So lithium will achieve its plasma concentration only after 5 to 7 days. Since lithium is a notorious drug, we should do therapeutic drug monitoring. Plasma concentration. When should you be taking the first blood sample for a TDM of lithium? Lithium will achieve its plasma concentration only after 5 days, no? So if you are starting lithium today, in a case of acute lithium, it will start working after 5 days. So remember here, so lithium in acute condition, it will not be that much supportive. So when should be the first blood sample should be taken now? First blood sample after 5 days only. After 12 hours of last dose. We have to ask the patient that, say here, lithium mostly we are giving TDS or BD. So we ask the patient, we are starting lithium today. On day 5, night dose you take. In the morning dose, don't take. First of all, you come to hospital. I will take sample to check right now. After that, you can take morning dose. All these points are important related to lithium, right? Okay. Remember here, why person is hyper? Why he is this much? Because of dopamine. So always remember, first drug to be given in a case of acute mania is always antipsychotic. Antipsychotic drug like olanzapine. Along with this, yes, we can add lithium. Lithium should be added. Although lithium will start working after 5 to 7 days. But see here, in the beginning, patient is hyper. No, we have to control his hyperactivity. No, so with the help of antipsychotic. First drug of choice for acute mania is always what? Antipsychotic. Along with this, please give benzodiazepine also to calm down the patient. Antipsychotic can be stopped after 2 to 4 months. Benzodiazepine can be stopped within 2 to 3 weeks. After that, lithium should be continued minimum for 9 to 12 months. So how much is the duration of treatment for bipolar disorder for the mania here? 9 to 12. My question is that If you are getting a patient of, suppose if you are getting a patient of bipolar disorder, no, bipolar disorder, right? Bipolar depression means is a case of bipolar, but only depression is there. Only depression is there. Can you start your patient on antidepressant? Or you should add some more drug? My question is that, can you start, a patient is having only depression, bipolar depression, only depression. Can you start your patient on only on antidepressant? Answer is no. Monotherapy should not be given. Monotherapy should not be given. Because see here, depression will improve, more improvement. Now there will be what? Drug-induced hypomania. So antidepressant should always be combined with mood stabilizer drug. This is the rule. This is the rule. Now see these 5 questions and try to answer me. See these 5 questions. Question number 1. Can monotherapy with antidepressant be started in a case of bipolar depression? Answer please. No. So what should be the combination? Antidepressant with mood stabilizer. What is the first line of management in acute mania? Can you answer me? Second question now. Second question now. First line of management in acute mania. Antipsychotic, right? Antipsychotic. Okay. Third, can lithium be used during pregnancy? Answer is yes. Safest mood stabilizer. Which one is the safest mood stabilizer? Can you answer me? Lamotrigine. See here, mania can be 2 types, euphoric and dysphoric. For euphoric mania, what is the drug of choice? Drug of choice is lithium. But for dysphoric mania, drug of choice is what? Valproate. Even after road traffic accident, also person can have mood disorder if there will be damage of limbic system, hypothalamus, mammillary body and all, right? Okay, fine. So my question is that even in a case of accident or organic mental disorder, after accident, if a person is having bipolar, so drug of choice is valproate. Minimum duration for the treatment, 9 to 12 months. In this manner, question will be framed. See, remember here, suppose if a patient of depression was there on treatment for more than 2 years, he will be called as a case of what? Resistant depression. What is the new drug for them? Esketamine. Esketamine, this is enantiomer of ketamine. So ketamine drug, no, always a risk of what? Always the risk of addiction, dependency. So there is a new drug. Esketamine is what? Esketamine is what? Nasal spray for the treatment of resistant depression. Every week, actually weekly, along with oral. Now, postpartum depression, there are 2 new drugs you have to keep in mind. First of all, brexanolone, and now recent most drug is Zurzuvae, okay, which is sold as zuranolone. Remember, brexanolone we are giving IV infusion, but Zurzuvae we have to give what? Oral drug. These are new drugs. Remember here, very, very important drugs. Now, acute lithium toxicity. When a patient is on lithium, yes, lithium can create problem in all the organs. Remember here, lithium can create problem in all the organs. Like CNS में, this will be causing what? Coarse tremors. Endocrine, it will cause hypothyroidism because it is going to affect TSH. GIT, nausea, vomiting. Renal, it will cause polyuria because of that polydipsia. Finally, it will cause what? Secondary what? Basically, it will cause what? Nephrogenic diabetes insipidus. For diabetes insipidus, how to treat now? We can give what? Thiazide diuretics, right? No, thiazide. We can also give a spironolactone, thiazide. Okay, thiazide and spironolactone. Last time they have asked what is the relation between thiazide and lithium. Thiazide and lithium. Remember, when a patient was already on lithium, patient started having diabetes insipidus, right now. After that, if you have to start the patient on, see here, thiazide. Now thiazide also, lithium also. Thiazide will decrease lithium clearance. Thiazide will decrease lithium clearance. Lithium clearance. Remember, thiazide can increase the risk of lithium toxicity. Thiazide can increase the risk of lithium toxicity. Skin folliculitis. Folliculitis. Rashes. Teratogenic effect abstains. So how to treat? See, remember here, overall, when we do plasma concentration, no, how much serum concentration we should be maintaining? Remember, 0.6 to 1.2. After more than 1.5 concentration, no, there will be a risk of toxicity. So always keep in mind that lithium concentration should always be less than 1.5, less than 1.5. So first of all, stop the lithium, right now. And after that, we can do the lavage also. And if there is what extreme condition of lithium toxicity, then final last option we are left with dialysis. That's it. Sexual disorder. See this question and try to solve. See, an extreme degree of sadism in with a person after mutilating the body, sucks or licks the wounds. Right now, so this is the type what, see here. Eating the flesh of the victim to derive sexual pleasure. This is a type of what? Paraphilia, where person eats, right? This is called what? Necrophagia. Necrophagia. Remember, in sexual disorder, please revise all paraphilias. Okay, like sadism, masochism. See, there is a paraphilia where until and unless a person is not going to murder his or her partner, he will not be getting gratification. That is called as what? What it is called as? Lust murder. And that is called what? Lust murder. Also called as erotophonophilia. See now, which type of paraphilia is this? See, remember here, which type of paraphilia? Paraphilia, you have to revise. I have taught you all in detail, right? Paraphilia. See here, when a person is going to watch other people having sex, after watching the sexual intercourse, if a person is having sexual gratification, it is called as what? Or if a female is undressing herself, and if a young man is watching her secretly, voyeurism. That is called as what? Voyeurism. Also called as scotophilia. One more name. Bolo, one more name. Peeping Tom. Do you think voyeurism is a punishable offense? Yes. Which IPC? Which IPC voyeurism, peeping Tom? Which one? IPC number batao. IPC number 354. C. 354. C. Very, very important, right? No? By using, see, after using inanimate objects like undergarments of female, handkerchief, sandals, if a person is deriving sexual pleasure, it is called as what? Bolo? Fetishism. Fetishism. After exposure of genital organ to any stranger, if a person is getting sexual pleasure, it is called as what? Exhibitionism, right? This is called as what? Exhibitionism, right? Okay, fine. See, remember here, Remember here, by using enema, see what is the meaning of clismaphilia? Can you answer what is the meaning of clismaphilia? Clismaphilia? After using what? Enema. Necrophilia means what? What is the meaning of necrophilia? Desire of having sex with that dead body. Eating dead tissues is called as what? Necrophagia. So paraphilia, you have to revise. Now remember here, see here, 4 phases of sexual response cycle. First, desire, then excitement, then orgasm, then resolution. See here, first of all, male and female should have desire. Okay. Then excitement. Remember, how will you understand that male is excited and female is excited? They both will be having what? Increased blood pressure, pulse rate and respiratory rate. How will you understand male is excited? There will be what? Erection. How will you understand female is excited? There will be what? Vaginal lubrication. There will be what? Vaginal lubrication. Orgasm phase, male and female. Male orgasm means what? There will be ejaculation. Female will be having what? Involuntary contraction of outer third of vagina. All right. Resolution, body will go back to normal phase of like resting phase. For excitement, how much is the duration for excitement? Minutes to hours. Orgasm, how much is the duration? 3 seconds to 15 seconds. This is having shortest period. Resolution, 10 to 15 minutes. 10 to 15 minutes. Now, related to this, disorders are being asked. I have taught you that during excitement, there will be what? Erection, no? So, which disorder belongs to excitement phase of sexual cycle? Can you answer me? Erectile dysfunction. Erectile dysfunction. I have taught you ejaculation will be there during orgasm. So which disorder belongs to orgasm phase? Bolo answer karo. Yes. Answer is what? Premature ejaculation. Premature ejaculation. Very easy to understand. Premature ejaculation. Remember, female can have multiple orgasm at the same time, but male will be having what? Only one orgasm. Remember all these points. Now, related to disorder, they are asking the treatment. Premature ejaculation, first of all, behavior therapy. Squeeze technique. This time, actually, so last time, INI-CT question. Squeeze technique. See, premature ejaculation means what? There are premature ejaculation. Remember, this can be mild, moderate, and severe. Mild. See, remember here, when a person is having ejaculation within 13 seconds to 1 minute. Moderate, 15 to 30 seconds. Severe, less than 15 seconds. Less than 15 seconds. Severe premature ejaculation. So my question is that squeeze technique, you have to ask the patient that whenever you feel that there will be ejaculation now, apply a pressure over glands. And because of this, there will be what? Backflow of semen. Backflow of semen, right? Squeeze technique. Stop-start technique. Stop-start technique. Ask the patient that whenever you feel that you are about to come or there will be ejaculation, stop for some time. Then restart. Again stop, then restart. This is called as what? A stop-start technique. Remember, which drug can be used for the treatment of premature ejaculation? Answer is what? SSRI. Why SSRI? Because side effect of SSRI is what? Delayed ejaculation. That's why it has become the drug of choice for what? Premature ejaculation. Which SSRIs are more preferred? Can you name? Please write down. Paroxetine and dapagliflozin. Paroxetine and dapagliflozin. Very, very good. Very good. Yes. Okay, fine. And one more is there, that is called what? Dual sex therapy. Dual role sex therapy. Where suppose if you are getting a couple and the couple are saying what? Sir, we are married for 7 years, 8 years, but now we do not have that feeling for having sex. We love each other, right? But So here you have to teach the patient how to seduce your partner without touching the genital organ. Right now, how to improve foreplay. This is called a dual sex therapy. Keep in mind, this is behavior therapy. And you have to treat only the couple, not the individual. This will become your question. Erectile dysfunction. Erectile dysfunction. Mostly this is psychological. So, suppose if a person is having erectile dysfunction, which drug should be given? We should give a drug which can increase the blood flow to the penis. Phosphodiesterase 5 inhibitors like sildenafil, tadalafil, vardenafil. This can increase the blood flow to the penis. More the blood flow, longer the erection. There is only one injectable drug which we are injecting into corpora cavernosa or urethra, not in the vein or artery or intramuscular or subcutaneous. No. Remember here, this is alprostadil. These are drugs you are supposed to learn. Remember here, these drugs you are supposed to learn. So basically, here I have taught you sildenafil, vardenafil, tadalafil. Viagra. For females also, to increase the libido, we have some drugs like filibanserin. To increase the libido, to increase the desire in females. So this is called a female Viagra. No, that's why filibanserin is called as what? Pink Viagra. Pink Viagra. But remember here, this is completely contraindicated with alcohol because it can cause a severe hypotension. That's why we have one more drug now, new drug, that is bremelanotide. Okay, bremelanotide. So flibanserin and bremelanotide, two drugs I have taught you for hypoactive sexual desire in females. All drugs which I am teaching you, please revise. Okay, you will get the PDF. Please revise it. Very good. Now some culture bound syndrome, especially we have to emphasize on Kuru and Dhat. Earlier I was not teaching culture bound syndrome, but now we should know why. Because last time NEET PG they have asked this question. NEET PG or INICD somewhere they have asked this question. Dhat syndrome, especially in the young boys, when they will start having ejaculation in the young age, they will be confused actually. Oh my God, what is happening to my body? And they will feel that they are becoming weak or losing virility, using maleness because of what? Loss of semen. Sometimes they will be feeling what? Oh my God, here my blood is coming out with the semen. Sometimes suppose if they have UTI and if they can see white discharge, sometimes maybe, or sometimes they can feel that oh my, the semen is also coming out along with the urine. Blood in semen or semen in urine. This is called as Dhat syndrome. Right now, if you visit North India, like especially if you are visiting, like UP, like near to Ghaziabad, like on the big wall, they will be writing Dhat Pat ka ilaj kare. Aap aaye bawasir ka ilaj kare, right? Actually piles and all. Basically, so this is a kind of, this is a kind of culture bound syndrome. Dhat syndrome, young age disorder, but like after that, as per the age, patient will become normal, no issues at all, right? So here young boy will be having what? This kind of feeling that he is losing his virility or maleness because of this. This is Dhat syndrome. Koro syndrome. Here person is having this kind of belief that his penis will retract back into the abdomen and he will die. Lata syndrome. See, remember here. See, there'll be what? Exaggeration startles, right? Exaggeration of startles, even with the minimal stimuli. This is called as Lata syndrome. Keep in mind, Koru and Dhat. Now, neurotic stress related. Here we are going to learn about anxiety disorders. First of all, panic disorder. Yes, I will explain you in detail. Panic disorder. Anxiety means what? Physical symptoms. Anxiety means what? Physical symptoms in response to an unknown stimuli. Right? Overall, most common psychiatric disorder is anxiety. Suddenly, if there is what? Restlessness, nervousness, tachycardia, sweating, right now, sweating, hyperreflexia, increased frequency. There can be diarrhea also. These are the symptoms of anxiety. See, anxiety means what? Nervousness. Means only nervousness, tachycardia, palpitations and all. Same symptoms like anxiety with heart attack like symptoms. It will be called as what? Heart attack like symptoms? Panic attack. Panic attack. Pain in chest, breathlessness, choking sensation, right? I know. Panic attack. First time, panic attack. Right? Okay, fine. Now, let's learn here. See, panic disorder we are going to learn in detail. Specific phobia means what? Fear of some particular things like fear of spiders, arachnophobia, fear of dogs, cynophobia, fear of heights, acrophobia, fear of dogs, cyno, fear of death, anatophobia. Agoraphobia means what? Agora is a bigger term. Fear of places from where escaping can be difficult. See here, no? Fear of places. See here, what is the meaning of agoraphobia? Fear of places from where escaping can be difficult. This can be closed space, this can be open space. Going somewhere alone is also problematic for the patient. That is also agoraphobia. If you ask the patient, use public transportation, he will be uncomfortable. Agoraphobia. Specific means what? To a particular situation. Fear of fire, pyrophobia. Fear of water, hydrophobia. Easy to understand right now? Okay, fear of animals, zoophobia. Fear of strangers, xenophobia. So these are actually what? Specific phobias. Now, social phobia means what? Social anxiety disorder. Don't think that fear of gathering or fear of so many people. No. Social anxiety means what? Social phobia means what? Fear of being watched or fear of being judged. Fear of being judged. What other people will think about me? What other people will say about me? This is called as what? Fear of being judged or fear of being watched. Okay, now fear of getting embarrassed in a particular situation. This is called as social phobia. Social phobia, fear of being watched. Generalized anxiety disorder, free-floating anxiety disorder. So many thoughts are coming to your mind. Now, selective mutism means what? Mute at the selective places. You might have seen a child or you might have seen some other people, right? You might have seen other people that they will be normal. But like suppose if I talk about a child, especially in front of the mathematics teacher, he will be silent, mute. After that, there can be restlessness, nervousness, tachycardia, selective mutism. Separation anxiety disorder. See here, all these are types of what? All these are types of what? Anxiety disorders. Anxiety disorder. Panic disorder is also a type of anxiety disorder. Separation anxiety disorder means what? If you ask a child that tomorrow I'm going to shift you to a hostel, for sure there will be bed waiting tonight. Why? Separation anxiety disorder. Child will be thinking what? Oh my God, I'm going to get separated from the family, from my home. Separation anxiety disorder. See this question and try to solve. Sudden onset of breathlessness. See the symptoms here. Breathlessness, anxiety, palpitations, feeling of impending doom due to particular fear. It happens very often, but symptoms are persisting for 15 to 20 minutes. Physical examination does not reveal any abnormalities. So what I'm explaining here that, see here, this is a case of what? Yes, all of you are correct here. This is a case of what? Panic disorder. This is a case of panic disorder. Panic disorder, very, very important. Panic disorder. Remember here, same symptoms of anxiety with heart attack symptoms, like feeling of impending doom. See, first of all, was severe pain in chest, severe palpitations, breathlessness, choking sensation. Patient will say, "What? Oh my God, doctor, I can feel my heartbeat. I can feel it seems that my heart will come out, right? No, my heart will come out. Fear of dying, fear of losing control." Remember, a most important term you have to keep in mind, what? Feeling of impending doom. feeling of impending doom. Doomsday means last day on the earth. Oh my God, I'm going to die, I'm going to die, I'm going to die. This is called as panic attack, panic disorder. More common among females than males. Symptoms will be persisting for 20 to 30 minutes. 20 to 30 minutes. How to treat? Especially what? We have to use what? SSRI with behavior therapy. SSRI, we can also use benzodiazepine with behavior therapy. So panic disorder, you can easily understand. Find a feeling of impending doom, please keep in mind, okay? Fine. So I have explained you the difference between anxiety and panic disorder, right? There should be no confusion. There should be no confusion. Next question. Phobia. First of all, you tell me what is the diagnosis? Yes, this is a case of what? This is a case of agoraphobia. No, this is a case of agoraphobia. See, a fear of closed place, only closed, then claustro. Fear of dark place, then nycto. Fear of closed, open, going somewhere alone, right? No, this is agoraphobia. So there are 4 most important line of management for phobia, which I'm going to teach you. Remember here, best is behavior therapy. Suppose if a patient is having cynophobia, yes, I can use a medicine, SSRI, benzodiazepine, beta blocker. I can use propranolol. But do you think if a person is scared of dogs, if I give him a tablet of SSRI, after that he will become Shaktiman? Obviously no. Right? No. How to treat phobia? Expose the patient to anxiety provoking stimuli. Exposure therapy is behavior therapy with the medicine overall best. Behavior therapy with the medicine is best. So remember, you should know 4 line of management. First of all, systemic desensitization, where I have to expose the patient to anxiety provoking stimuli, and along with that, medicine also. Systemic desensitization is best. Therapeutic graded exposure, only exposure. Flooding, severe form of exposure to the anxiety provoking stimuli. If a patient is having what? Arachnophobia, fear of spiders. Now, if you know that in a small room, so many spiders are there. Now, suddenly you are going to push him there. Suddenly in front of so many spiders. So this is what? Severe form of exposure to anxiety provoking stimuli. This can be dangerous. This is flooding. And modeling means what? Where clinician is also participating. Where I am also demonstrating the method. It is called as modeling. So there are 4 methods of treatment for the phobia. Systemic desensitization is best. See this question. I have solved this question before also. Okay, Dr. Ting Tong, yes. This PDF is already shared in the Telegram group also. Annotated PDF will also be shared, okay? Hello, yes. Yes, easily you can see this question. You can easily solve this question. This is a case of what? OCD, right? This is a case of what? OCD. OCD means what? Obsessive and compulsive disorder, right? No, OCD. Now see, remember here, when a person is having what? Uncontrolled thoughts. That, see, suppose see here, no? See this photo, you can easily solve. Suppose if a person is having this kind of thoughts that your hands are dirty, 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 he knows that these thoughts are irrelevant. Uncontrolled thoughts, obsession. When he wants to resist, he is having anxiety. To release the anxiety, he has to wash it. That is called as compulsion. So first of all, this is OCD of contamination. After closing the room, if a person is going to check the room again and again, whether I have locked or not, right? This is called as OCD of pathological doubt. This lady, when she cuts vegetable, no, shape and size of every vegetable should be equal to 0.6 centimeter. Even if one size is 0.5 or 0.7 centimeter, no, she will be having so much anxiety. This is what OCD of symmetry. Right? Okay. So remember here, 4 major symptoms: OCD of contamination, of dirt and germs, pathological doubts of rechecking the door again and again, symmetry, maintaining the shape and sizes, and some people can have OCD of intrusive thoughts and images also. Intrusive means what? Weird. Thoughts and images also. Suppose if a person is having this kind of thoughts that he is having sex with the God, whenever he will be having this kind of thought that hey, he's having sex with the God, after that what will happen? Oh my God, how could I think like this, right? So this is what? A kind of OCD disorder. Now after that, what he will do? After that, he will start reciting holy verses of holy book. This is called as what? Compulsion. So 4 major symptoms you should know: contamination, pathological doubt, symmetry, and intrusive thoughts and images. Now 5 new types of OCD are added in ICD-11. Hoarding disorder. Hoarding means what? To keep on accumulating. To keep on accumulating the things. See these pictures, you can have more clarity. A person is not discarding any old stuffs for last 14 to 15 years. 14 to 15, old undergarments, old books, 4th, 5th class mathematics. Who will keep those books? Obviously, no. When you have old stuffs, obviously you are going to throw everything. No, you are going to throw everything, right? Okay, fine. Basically, you have to discard the things. No, you have to discard the things, right? Ideally, you should discard it. But a person is having obsession of losing something important. Losing something important. So he does not discard anything. He keeps on accumulating old stuffs. So now situation will be like this. This is called as what? Hoarding disorder. This is called as hoarding disorder. Body dysmorphic disorder. Obsession of misshaped of any body part, like nose, skin, or nails. This is a type of OCD. See here, body dysmorphic disorder. She looks perfectly fine, but she keeps on looking herself into the mirror. Oh my God, I've become fat. So every time she's looking in the mirror, she does not have anything just below her eye. But now again and again, she's looking into the mirror. Oh my God, I have got what? Black eye bag. This is also a type of what? Body dysmorphic disorder. Okay. Suppose if a female, she has read about deviated nasal septum, no? DNS. Deviated nasal septum, DNS. Okay, right? Now again and again she's coming to doctor, see my nose is deviated. See, no, doctor, please check, my nose is actually deviated. Please check. After you say, hey, no, it looks fine. Like everyone does not have a straight nose, so it's fine. No, doctor, this is a case of deviated nasal septum. I think you should do, rhinoplasty. You have to operate. Hey, do you have any breathing problem? No, but no problem. Again and again she will come to you because she is suffering from what? Body dysmorphic disorder. Next is olfactory reference syndrome, where a person is having this kind of obsession that he is emitting a foul smell. He is emitting foul smell. He is emitting a foul smell from his body or from his mouth. That's why whenever he is going to meet someone, he will maintain a distance. Right? This is called as olfactory reference syndrome. Now, body-focused repetitive behavior disorder. Hair pulling disorder called as what? Trichotillomania. Excoriation or skin picking disorder. Let's see here. See, this is repeatedly asked question. See, skin excoriation disorder. When you are getting one pimple, ideally you should not be touching it. Ideally, don't touch, right now. But see here, what we will do. Like every time we are doing like this, every time, because of this, many more pimples will come. This is also a type of obsession. Skin excoriation disorder. Suppose if you are having a small skin here, dead skin here, every time we are removing it now. Why? This is what? A skin excoriation disorder. Okay, this is a type of what? OCD. This can be seen even in substance abuse also, like cocaine, amphetamine. How to treat? Remember, for all OCD, Remember, for all OCD of contamination, OCD is what? Ego dystonic. Remember here, it is what? Ego dystonic, right? Not dystonic. There will be imbalance of which neurotransmitter? Serotonin. So which drug is given along with the behavior therapy for OCD? Can you answer me? Yes. We have to give what? SSRI. We have to give what? SSRI. SSRI. See here person knows that he is wasting so much of time or energy. The patient can easily go into depression. Along with OCD, which other psychiatric illness is seen? It is depression. For depression, how much is the duration criteria? 14 days. For OCD also, duration criteria is 14 days, right? 14 days. So we have to add SSRI with behavior therapy like habit reversal. What is the meaning of habit reversal? Suppose if a patient every time she is going to itch here, so right here we have to ask the patient, whenever you feel that you are going to do like this, stop your hand, stop like your hand. This is called what? Habit reversal. Don't do this. Habit, hair pulling. This is extremely important topic for your exam. Extremely important topic for your exam, right? Okay, fine. See, earlier hair pulling was considered as impulsive control disorder, but now hair pulling disorder means what? Trichotillomania. Hair pulling, trichotillomania, hair pulling disorder like this every time, no? This is a type of OCD now. After hair pulling, person can eat the hair also, no? This is called what? Tricho. Hair eating is called as what? Trichophagia. After that, do you think there can be obstruction of hairball in GIT? Right? What it is called as? It is called a what? Trichobezoar. It is called as trichobezoar. Remember here, this picture was asked in last exam, last FMGE exam. Trichotillomania is very, very important. Right? Hairball obstruction inside the GIT, it is called what? Trichobezoar. You might have seen a psychiatric patient who can eat raw vegetables, big potato like this. Obstruction by vegetable material, it is called as phytobezoar. Sometimes, so basically bezoar means what? Indigestible material inside the GI. Sometimes, see here, there can be accumulation of milk also. Milk also. So it is called what? Lactobezor. It is called as a lactobezor. Some people can take many medicine at the same time. So many drugs, so many of the tablets, accumulation, obstruction because of the drugs or tablets. It is called a what? Pharmacobezor. So remember, when I talk about trichobezor and all, how to treat the patient? Last option is what? Surgical removal only. The drug to be added, SSRI, right? SSRI, very, very easy to understand, right? Very easy to understand. I know. Now, one more is here. See here. Hypochondriasis. As per DSM-5, it is a type of somatic illness. But as per ICD-11, new, now it is considered as a type of OCD. Hypochondriasis means what? Illness, anxiety disorder. Same like MBBS first year students. Like whatever he will be learning, he will keep on asking you, doctor, I think I'm also having this problem. That is called as what? Illness, anxiety disorder. Your patient will keep on coming to you again and again. Doctor, I think there is something wrong in my body. So you please do one thing. You do the X-ray of entire body, right? That is called as hypochondriasis. Very easy to understand. Hypochondriasis. Now, how to treat OCD? First of all, remember here, how to treat CBT, exposure. Remember, exposure and response prevention. The exposure and response prevention. Exposure and response prevention therapy, ERT, is the best. Right now, along with this, suppose the patient is not improving, then please add a medicine also, SSRI or clomipramide. Very, very important to treat OCD. Impulse control disorder. What is the meaning of impulse? Last time this was the question. Sudden urge to do something, right? Which can be injurious to other people. Suppose if a person is having this kind of urge to burn something, that is called a what? Pyromania. To set something on fire. Aag laga do, right? Pyromania. Kleptomania, stealing the object. My question is that why kleptomania you are not keeping as antisocial personality disorder? How to differentiate antisocial personality and kleptomania we are keeping in impulse? How? Remember, antisocial means what? Robbery, no. Robbery for expensive things only. Only for expensive things. Robbery for expensive things, right? But kleptomania means what? Urge, irresistible urge to steal anything, either tissue paper, pen, pencil, anything is here, no. There is only urge. If there is a tissue paper here, no. Here person will be having urge to steal something, like person will be looking here and after. This is kleptomania, irrespective of economic values. Right now, irrespective of economic values. This is called as kleptomania. Even a rich people can suffer from this disorder. Intermittent explosive disorder, destroying destructive activities. Destructive activities. What is the meaning of intermittent explosive disorder? What does it mean, explosion? Any boy or any young person or any man who is suffering from explosive disorder, what he will do? He will take one hockey, he will go out of the home, he will see 5 cars, he will break the windows of all the cars. See, whenever a young boy is there, he will enter the kitchen, he will break many plates. After that, his mother will break him. Easy to understand? This is called as what? Intermittent explosive disorder. Compulsive sexual behavior. See, excessive sexual desire in male or female. In male, excessive sexual desire, it is called as what? Excessive sexual desire in male is called as what? Satyriasis. See, in female, it is called as what? In female, nymphomania. Remember, satyriasis and nymphomania, no, these are what? These are what? Compulsive sexual disorder, actually, a type of impulsive control disorder. Person will perform sexual activities in one day for 5 times, 6 times. He will not be able to control. After that, he or she will have that kind of, that kind of regret, that kind of feeling of guilt. Aniomania means what? Aniomania means what? Irresistible desire to do shopping. Dipsomania, irresistible desire to have what? Alcohol. Mutilomania, mutilate the animal. Mutilating animals. Any boy who is suffering from mutilomania, what he will do? He will keep one blade in his hand. He will walk on the road. He will see any animal, he will give, so he will mutilate the animal. So first of all, he will give one slash here, second animal, third animal. Basically, he is giving slash, or he is mutilating the animal. Last time, NICT question. Gambling is also impulse control disorder. See this question now. See this question and try to answer, please. Yes, this is a case of what? Very good. This is a case of PTSD. This is a case of PTSD. After the trauma, there is what? A stress disorder. So see here, what will be the symptoms of post-traumatic stress disorder, PTSD? What will be the symptoms here? Suppose a simple logic is that, suppose if a 19-year-old boy who reached airport to receive his parents, he got very excited because flight is about to land. He could see flight is landing. He got very excited. But suddenly during landing, plane got crashed. He was allowed to go inside. He could see the separated head of his father from the body. Do you think every time he will be having a flashback and a nightmare? Yes, flashback and nightmare. Flashback and nightmare. Again and again he will be having the same dreams, nightmare and all. Do you think he will be having normal mood? No, anhedonia. Anhedonia. Do you think he will be able to speak normally? No, a startle response, right? A startle response. Do you think he would like to go back to airport again? Obviously, no, avoidance, right? He will be able to sleep properly? Obviously, no, insomnia. All these are the symptoms of what? PTSD. Remember here, PTSD is more common among females. And this is the disorder of a young age. Always keep in mind, young age disorder. Remember here, how much is the duration criteria for PTSD? More than 1 month. More than 1 month. Same symptoms like PTSD. Duration less than 1 month is called as what? Acute stress disorder. PTSD symptoms can occur even after 6 months also. After 6 months, no, PTSD with a delayed onset. With a delayed onset. Sometimes same symptoms like PTSD within 2 days. Within 2 days. It is called as what? Within 48 hours, it is called as what? Acute stress reaction. Acute stress reaction. PTSD. Now you can easily understand here. Right now, PTSD, see here, I have explained you panic attack, panic disorder, PTSD, acute stress disorder. How to treat PTSD? Remember here, PTSD should be treated with the help of what? SSRI, first line of management. But best is always behavior therapy. We are also using one therapy that is called as EMDR, eye movement, desensitization and reprocessing. Keep in mind that treatment of PTSD, SSRI with behavior therapy. Most important line of management is what? Behavior therapy. Now see this question. See this question. Yes, this is a case of what? Hypochondriasis. This is a case of what? Hypochondriasis. See, remember here, very, very important. See, somatoform related disorder. Somatoform related disorder. Sometimes patient can have some symptoms. Patient can have some symptoms, but there is no pathology. In spite of reassurances, in spite of negative results, patient will keep on coming to you again and again, again and again, again and again. Okay, no? Even if you're asking, hey, nothing is there, but patient will keep on coming to it. This is called a what? Somatoform disorder, also called as what? Unexplained disorder. So if patient is having more than one symptoms, patient number 1, patient number A. If patient is having pains at multiple sites or pains at 4 sites, like shoulder pain, back pain, abdominal pain, joint pain. Patient can have GIT symptoms like nausea, vomiting, diarrhea. Patient can have CNS symptoms like mental confusion. Patient can have sexual symptoms like lack of libido. If patient is having more than one symptom, no, it is called as what? Somatization disorder. Somatization disorder is also called as Brequet syndrome. Brequet syndrome. Now, if patient is complaining of only pain, somatoform pain disorder. Hypochondriasis, no, or minimal symptoms. Minimal symptoms. Only ideas of having a disease. Only ideas of having a disease. That is called as hypochondriasis. Doctor, I think there is something wrong in my body. Please check. I think so. Something is wrong. Hypochondriasis. Also called as what? Illness, anxiety disorder. Remember, as per ICD-11, hypochondriasis is what? A type of OCD. But as per DSM-5, this is a type of somatoform disorder, right? Now, what about this one? What about this one? Please answer. See this question and try to answer. See this question. See, sometimes there can be some patients who love to stay with you people, who loves to stay with who loves to get the attention of doctors and paramedical staffs. So patient will fake some symptoms. Patient will be faking some symptoms to get hospital admission, right? It is called as what? Factitious illness. It is called as what? Factitious illness. Remember here, it is called as what? Factitious illness. It is also called as hospital addiction. Hospital addiction. When patient is faking the symptom, it is called as Munchausen syndrome. When a caregiver, like mother, is faking symptom for the baby, it is called as what? Munchausen syndrome by proxy. Munchausen syndrome by proxy. When patient is faking the symptoms to get hospital admission, patient will keep on insisting for multiple tests, multiple things. Okay, patient will fake the symptom. Patient will say, doctor, I'm having lower abdominal pain right side. Nausea, vomiting also. I think you are suspecting appendicitis. Now do one thing. Admit me for 2 days. Do whatever investigations you. It is called as what? Factitious. What about this one? Answer please. See here. Psychological stress can produce some physical symptoms. Physical symptoms. So that person can get love, respect, and attention. Psychological stress can produce physical symptoms. So that person can get love, respect, and attention. This is called as dissociative disorder. It's called as what? Dissociative disorder. What to do? I think yeah, if you have another pen, please give me. Okay, fine. See here. So basically what I'm saying here, see here, psychological stress can produce physical symptoms. Psychological stress can produce physical symptoms. So that person can get what? So that person can get what? So the person can get attention. This is called as dissociative disorder. Dissociative disorder, also called as conversion disorder. Old name was hysteria. Remember, this is more common among females. This is more common among females. This is called as what? Dissociative disorder. Dissociative disorder. Old name hysteria. Please write down dissociative disorder. Keep in mind, when a person is having, these kind of symptoms, suppose if there is a patient of dissociative disorder, a person can become what? Person can become fully paralyzed also. Yes. See, this is called about dissociative disorder. Yes, chalo, theek hai. So remember what is happening here. There is something called as the labella indifference. Labella indifference. Labella indifference. Ideally, when I will be losing one eyesight, I will be very, very much concerned. I would like to see my ophthalmologist as soon as possible. But dissociative patient, no, they will be unconcerned about the result, indifferent about the result. Suppose if they are losing one eyesight, they will say, "What? No problem. I'm having one more eye." This is called as the labella indifference. Labella indifference. Please remember, this is important topic. Labella indifference seen in dissociative disorder, also called as conversion disorder. Conversion. Remember, this is seen more among females. More among females. Yes, yes, yes. Mother died, vitella, yes. Easy to understand? So now you tell me, see, this is more common amongst females. So what will be the answer? This was the last time INICT question. Answer is what? D only. Answer is D only. Psychoanalysis. See here. Psychoanalysis chapter. See why we are using psychoanalysis to bring out old memory into the conscious memory. It is called as abreaction process, by which the forgotten memory we can retrieve back to the conscious memory. Sometimes what is happening here, whenever a doctor and patient, whenever a doctor and patient, when doctor is doing what? Psychotherapy, when doctor is doing what? Psychotherapy, if, see, many a times what will happen, patient can develop some emotion for their doctor. It is called as transference. But sometimes doctor can also develop feeling for their doctor. It is called as what? Counter transference. These two words are important, transference and counter transference. Whenever I talk about psychoanalysis, who is called as father of psychoanalysis? Father of psychoanalysis? Sigmund Freud. Sigmund, very, very important person, right? Sigmund Freud. All right. Now, see here, he gave a structural theory of mind. He divided mind into id, ego, superego. Remember, only a few points we should know here. Most important topic. See here. First of all, Sigmund Freud gave topographical theory of mind. He divided mind into conscious, preconscious, unconscious. All right. After that, he gave a structural theory of mind. He divided mind into id, ego, superego. After 1 week, you have exam, and one part of your mind is saying what? I want to enjoy. I want to enjoy. So that is what? I want to enjoy id. But one part of your mind will say what? You cannot enjoy. You have to study. You have to study now because you have exam. That is called as what? Superego. Remember, id works on pleasurable principle, but superego works on moral principle, who speaks about ethics. So in between, ego has to come and it has to behave. So like ego will say, both of you, don't fight. Do one thing. You study for 4 hours and watch a movie for 1 hour. Again, you study for 4 hours. Again, you watch a movie for 1 hour. In this manner, now you will say, yeah, this is the right idea, right? Now, so that is, see, balancing is done by ego. So ego works on reality principle. Id has completely unconscious domain, but ego has unconscious as well as conscious. Superego, unconscious and conscious. Remember, defense mechanisms, no, all defense mechanisms are being played by, all defense mechanisms are played by unconscious domain of ego, except one, conscious. Which one? Suppression. Okay. Now, see this question. Solve the question now. Psychosexual stages of development. See, earlier there was only one news that only adult can derive sexual pleasure, but Sigmund Freud said no, even a 1-year-old child can also derive sexual pleasure. Everyone said no, how it can be possible? So Sigmund Freud said that there are 5 stages of sexual cycle, no? 5 stages, right? No, 5 stages. 5 stages, oral, right? See, in between 0 to 1.5 year, anal 1.5 to 3 year, phallic 3 to 5 year, latent 5 to 12, genital more than 12. Sigmund Freud said that oral means what? A child will have this kind of, like this kind of activities of deriving sexual pleasure, that child will derive how? After biting, chewing, sucking. Okay? This is the method of a child to derive sexual pleasure. Up to 1.5, that is fine. After 1.5, there should be shifting to other stage, right? He said that as per the age, there are 5 stages, but there can be fixation at a particular stage, and that can result into another mental. Anal stage, when a child will be toilet trained. In the beginning, when mother is going to clean the toilet, okay, fine, that will be a kind of, sexual pleasure, fine. Up to 3 years, it is okay. This is called an anal stage. But if a 9-year-old boy is there, still he is enjoying. What does it mean? Oh my God, fixation has happened at anal stage. Fixation at anal stage can result into OCD. OCD. This was the question in last FMG. OCD. OCD can develop after the fixation at which stage? Anal stage, anal stage, anal. Right now? OCD. Now, phallic stage 3 to 5 years. See here. For male and female. For both center of attraction organ will be what? Penis. See, you might have seen a 4-year-old boy, every time he will keep on playing with his, like every time he will keep on rotating his penis. Even a girl child will be asking her mom, where is my penis? She will ask her mom, oh my God, my brother is having something extra, where is mine? And she will hold her mother responsible for this. A girl child will think like this, that she had a penis, but her mother has castrated. During this stage, a son will have sexual attraction towards his mother. It is called as Oedipus complex. At the same time, daughter can have sexual feeling for her father. It is called as what? Electra complex. Electra complex. So during Oedipus complex, no, son will be having this kind of feeling that if my father will come to know about this, he will castrate me. It is called as what? It is called as castration anxiety. And girl child will always be thinking about what, where is my penis, right? So she will be what? Penis. Up to 5 years, it is fine. Sexual feeling in the son for mother, in daughter for father. Up to 5 years, you might have seen girl child will always be sitting in the lap of father. A boy child will always be holding his mother, right? Now, up to 5 years, it is fine. It is psychological, it is natural. But if a 15-year-old boy is having sexual feeling for his mother, what does it mean? Fixation has happened at phallic stage. And this can result into neurotic illness. This can result into hysteria. Fixation at phallic stage can result into hysteria. Latent stage, most of the time, child will be sexually inactive. Child will focus more on learning skills. More than 12 years of age, a child will be, so now, genital organs. See here, after 12 years, after puberty, a person can derive sexual pleasure with the help of what? Genital organ. Fixation at latent and genital can result into neurotic illness. Fixation at phallic stage can result into hysteria. Fixation at latent and genital can result into neurotic illness. Fixation at anal stage can result into OCD. Now, the most beginning phase of life is oral stage. Fixation at oral stage can result into severe illness like schizophrenia, mood disorder like depression, substance abuse like alcoholism, personality disorder like dependent personality, See, this table is extremely important for your exam. 5 stages of psychosexual stages of development, 5 stages. Oedipus complex, Electra complex, very, very important. Sexual attraction of son towards his mother, Oedipus. Sexual attraction of girl child towards her father is called as Electra complex. Very, very important. Please go through all these. Organic mental disorder, especially, see this question, what is the answer here? Answer, please. This is a case of what? Acute delirium. Remember here, just 2 days after the admission, Suppose if a patient was admitted after their burns, and what happened for last 14 days, I was doing the dressing. But what happened today? Yesterday I forgot to do the dressing, and today what happened? Suddenly now when I'm going to see that patient, now patient suddenly he's like, hey, who are you? Who are you? What are you doing here? What are you doing here? Basically, now he's not recognizing me. He's not recognizing his family member. He's saying, oh my God, where I am? Oh my God, this is jail or what? Oh my God, a scorpion, a snake. A snake is going to kill me. Please remember here, sudden onset of symptom, acute onset of symptom, sudden what? Altered sensorium or disorientation to time, place and person. After that, patient can have what? Insomnia, irritation, agitation, agitation. This is called as what? Delirium. This is called as what? Delirium. Acute condition of what? Delirium. Delirium is always acute, sudden onset, sudden onset. Remember, here also there is what? Disorientation of time, place and person. Person is having hallucination also. Most common will be what? Visual hallucination. Okay, easy to understand. This is called as what? Delirium. Delirium can be because of what? Delirium can be because of what? Long, like long-term hospitalization, major surgeries, after drug abuse, after alcohol, right now? Okay, fine. See here, so I have taught you that in delirium, delusion and hallucination can be seen. Okay, fine. Schizophrenia also, na? How to differentiate? Remember here, first of all, delirium is always acute. Schizophrenia is never acute. See, in delirium, there will be what? Altered sensorium or clouding of consciousness or mental confusion. Schizophrenia, no. Schizophrenia mein patient will be well oriented. Okay. In delirium, most common hallucination will be what? Visual. But schizophrenia, most common will be what? Auditory. In delirium, delusion will be there, but only for short term. Short term. Schizophrenia, long and constant. In this manner, they are going to frame question in psychiatry, how to differentiate delirium and schizophrenia. Delirium and schizophrenia, right? How to treat? Treat the root cause. Treat the root cause, right? No, treat the root cause. Very easy to understand, right? In the same manner, dementia. What is the meaning of dementia? Organic mental disorder, you should know about delirium, dementia. Dementia is what? Dementia is old age. Decline in cognition. Decline in cognition. Very slowly, or you can say what? Very slowly, progressively. Without any problem in consciousness. Without any problem in consciousness. There will be no problem in consciousness. This is called as dementia. How to differentiate delirium and dementia? Delirium is always acute. Dementia is never acute. Dementia is very, very slow. In delirium, there will be clouding of consciousness. Dementia, no clouding of. In delirium, there can be fluctuation of symptom. Here, no fluctuation. Very easy to understand. Delirium and dementia, keep in mind, very, very important. If patient is having delirium dementia together, it is called as beclouded dementia. It is called as what? Beclouded dementia. Dementia is of two types. One is called a cortical type, cortical dementia. Another is subcortical. If there will be damage in cerebral cortex, there will be amnesia, aphasia, acalculia, apraxia, agnosia, right? Like in Alzheimer's. In Alzheimer's. CJD, right? Alzheimer's. Subcortical, when subcortical structures are involved. Any example of subcortical? Can you give me the example here? Where cerebellum, basal ganglia are involved. Motor symptoms are there, something like this. So yes, like Parkinson's, Huntington chorea, Wilson's disease, these are subcortical dementia. Remember here, overall, most common cause of dementia is what? Alzheimer's. Alzheimer's, right? Dementia, most common cause. Remember, dementia with Lewy body. Dementia with Lewy body. Mixed presentation. Cortical, subcortical also. Here there will be Maximum visual hallucination. Maximum visual hallucination. So in dementia with the Lewy body, there can be delusion of misidentification. No. So yes, last time question, dementia with Lewy body, yes, Capgras syndrome can be seen. Capgras syndrome. Capgras, right now, where a real person is replaced by an imposter. This is what delusion of misidentification, right? So this can be seen with dementia with Lewy body. Remember here, dementia with the Lewy body. Remember here, dementia with the Lewy body. Okay? All dementia will be old age problem only. Old age problem, right? Old age, except one. Which type of dementia can occur in young age? Remember, if any patient who is suffering from Down syndrome, he can start having dementia at the age of 35. So remember here, early age dementia is seen in Down syndrome. Now next chapter, child psychiatry. See this question. See this question. See, whenever there will be problem in social interaction, problem in language, problem in behavior, problem in IQ, this is called as what? Autism. No, autism. This is called as autism. Same symptoms like autism with microcephaly, with loss of acquired skills, with breath holding spells, This is called as what? Rett syndrome. This is called as Rett syndrome. This is called as Rett syndrome. Remember, Rett syndrome is especially seen among females. There can be mutation of a gene that is called a MECP2 gene. X-linked MECP2 gene, especially among females. Actually, Rett syndrome is exclusive to females. All other autistic disorders are seen among males, more common among males. Remember here, more common among? Yes, very good. So see, here you can understand, if there will be problem in IQ, problem, language, problem, social interaction, problem, right now? See, it is called as autism. Autistic spectrum disorder like Rett syndrome, all these are autistic spectrum disorder. Symptoms like autism, with microcephaly, with seizure, with breath holding spells, right? Breath holding spells, with loss of acquired skills. It is called as Rett syndrome. Earlier, there was no any drug, but recently, this year only in the March, a new drug got launched. Only one drug is there, that is called which drug? Trofinetide. Okay? Same, please write down here. See, one more is called as Heller's syndrome. Heller's. Where, remember, symptoms like autism, with regression of learned behavior. That's why it is called what? Regressive psychosis. It is also infantile psychosis. Loss of acquired skills and loss of bowel and bladder control. Anywhere child can defecate. This is called Heller's syndrome. Remember, IQ is normal, language is normal, but social interaction is abnormal. This is called as Asperger syndrome. My name is Khan. Here only you are going to see islets of precocity. Good doctor, right? Now, IQ, language, social interaction, everything is normal. But whenever this child is writing any exam, he is getting a fail. It is called as what? Learning disability. What is the most common learning disability? Remember, Dyslexia. Tare zameen par, right? Dyslexia. Okay, dyslexia. In Asperger syndrome, you can see hyperlexia, early ability to read. There was a question in Central Medical Service last time. Inability to write is called as what? Inability to write is called what? Dysgraphia, right now? Dysgraphia. In this manner, we have completed all autistic spectrum disorder. Autistic spectrum disorder, right now? Dysgraphia, very good. Now see this question. When there will be problem in attention, okay? When child will be hyperactive, when there will be what? Impulsivity. Inattention, roaming in the class, disturbing other children. When teacher is asking for a question, he is not able to wait for his turn. It is a case of what? ADHD, attention deficit hyperactivity disorder. Remember here, this is a disorder of emergency. If you are not going to treat ADHD on time, no. See, this kind of child will always be punished. Right now, will always be punished. This kind of child will always be standing outside the classroom. Right now, so if you are not going to treat on time, child is at the risk of what? Development of in future antisocial personality, alcoholism, and depression. So that's why we have to treat the patient as soon as possible. We can use two drugs, CNS stimulant or non-stimulant also. Stimulant and non-stimulant also. Which one should be the drug of choice, stimulant or non-stimulant? Why he is having lack of attention? Why is having lack of attention? Because his CNS is not at all stimulated. Not at all stimulated. When you smoke, when you have tea, coffee, when your CNS gets stimulated, after that you get hyper, no? After that you are having good attention, good concentration, no? So this child is having what? Non-stimulated CNS. Basically, his CNS is not at all stimulated. That's why we have to give what? We have to give what? CNS stimulant as the drug of choice. CNS stimulant. CNS stimulant, right? What is the drug of choice? Methylphenidate. Remember, methylphenidate. Methylphenidate. Okay? Question is that, do you think in all conditions we can use stimulant? In two conditions we should avoid stimulant. When child is having ADHD with a seizure, and since CNS stimulant is having what? Severe addiction, severe dependency. So if there is what? A family history of drug dependency, we should use non-stimulant like atomoxetine. Atomoxetine is most preferred because there is no dependency. ADHD can persist in adults also. So even if ADHD with adults will be there, no, atomoxetine is more preferred. Atomoxetine is more preferred. Okay, now substance abuse disorder. See here, what is this? Overall, some one-liner question. What is the most common substance abuse right now in India? See, every year, almost every 2-3 years, it will keep on changing. What is the most common substance abuse right now in India? Nicotine. Or you can say tobacco. Tobacco, actually, tobacco. Now it is tobacco. Now it is tobacco. Most common substance abuse. Most common illegal substance to be illegal. Illicit. Illegal. Cannabis. Okay. Most common substance use. Coffee. Most common substance abuse for which treatment is sought. Patient will come to the hospital. Alcohol. Alcohol. Most common drug abuse after doctor's prescription. After doctor's prescription. Benzodiazepine. Benzodiazepine. These can be your one-liner question. Okay, now one-liner questions. Now, see here the methods of abusing. I'm not going to teach you how to abuse, okay, for the question, for the patients. This is called a what? This is called a what? Electronic, no? Electronic. So this is what? Vaping. This is the news among youths that this is not dangerous. Please remember, this is equally dangerous, same like cigarette. So this is vaping. This is what? Smoking. This is what? Snorting. Snorting. Or like see in the snuff box, if a person is going to, this is what? Sniffing. Snorting and sniffing. Sniffing. Okay. Now what about this? Some drugs, especially heroin, right now? So over the aluminum foil, the powder will be there, and from the lower part, a person is going to heat. When a smoke will be coming like this, smoke will be coming. So then after a person is going to chase this term, a person is going to chase the smoke like this. This is called as what? Chasing the dragon. Chasing the dragon. Chasing the dragon. Method of abusing a substance, right? Chasing the dragon, right? Very good. Chasing the dragon, especially for heroin and then cocaine. Okay, fine. See here, some, like solvents, some liquid kind of, substance abuse. So when you are using a bag and then, so this is called as what? Bagging. Bagging. And in the slum areas, young boys will do what? Like they will soak, petrol, diesel, glues, thinners, Fevicol and all in a cloth. This is called a what? Huffing. Huffing, right? Some people can, inject their drugs. So first of all, they're going to inject in the peripheral blood vessels. After 4 to 5 shots, these are going to get punctured. Then they're going to shift to the main blood vessels here. This is called as main lining. This is called a what? Main lining. Sometimes they can become senior anesthetist also. They can choose this blood vessels also. Here also they can inject the drug, right? Jugular vein also, right? Sometimes they can do what? Skin injection. Under the skin, you can see a small skin popping like this. Skin, like this. This is called as skin popping. Skin popping, main lining. These are the methods of drug abuse, right? Okay. See this question, alcohol is most important. See the alcohol which is being used is called as what? Ethanol. It is called as ethanol. Remember, methanol is poisonous. So कहते हैं कि वो कच्ची शराब है ना, कच्ची शराब है या फिर वो कहते हैं स्पिरिट वगैरह का भी ऐसा ना. So like basically raw methanol is actually poisonous. Okay, so when some patients are getting admitted in hospital because of methanol poisoning, what should be the antidote now for methanol? उसको बोलो अब अच्छा शराब पियो, अच्छा पियो. Ethanol is the antidote. Remember like that, okay? Ethanol, and what is the name of a drug? Fomepizole. Fomepizole. Ethanol, and you remember please, fomepizole. Antidote for methanol poisoning. Remember here, benzodiazepine has addiction, no? Benzodiazepine has addiction. Even there can be overdoses of benzodiazepine also, right? No? What is the antidote for benzodiazepine poisoning? Last time MCI question. Antidote for benzodiazepine poisoning. Flumazenil. Flumazenil. Okay, fine. Now solve this question. Three days before patient came, right? So this is a case of what? Delirium tremens. Delirium tremens, right? Okay, fine. Now see, this table is extremely important. First of all, as per legal limit in India, how much is the legal driving limit? 30 milligram. 30 milligram means up to 30 milligram. If you drink and drive, no fine. Okay, right? Up to 30. See, increasing dose of a substance is giving you kick. It is called as what? Tolerance. It is called a tolerance. Decreasing dose of a substance is giving you kick. It is called as what? Reverse tolerance. Now, suppose if a person is severe alcoholic person. Very good. Now, he has stopped alcohol because of what? Religious issues, because of family issues or professional issues. So first symptom of withdrawal will happen after 6 to 8. So what is the first symptom? First symptom is what? Tremors. After that, there can be GIT symptoms like nausea, vomiting, right? There can be autonomic nervous system symptoms also. There can be severe headache, sweating and all, right? Okay. More than 12 hours, there will be what? More than 12 hours. Hallucinosis. It is called alcoholic hallucinosis. Mostly there will be what? Auditory hallucination. A person will be able to hear the noises of a small insect. Noises of a small insect. Noises of a small insect. Here patient knows that he is hearing these small insects noise because of what? Alcohol. So inside is present? No. So it is called as what? Pseudo hallucination. More than 24 hours, there will be what? Seizure. Which type of seizure? It is called as cluster seizure. GTCS type. After taking rum, a person is having fits. It is called as what? Rum fits. Okay. More than 48 to 72 hours. Now what will happen? More than 48 to 72 hours, what will happen now? Now patient will be suddenly what? Patient will disoriented to time, place and person. Patient will be very aggressive. Patient can have seizure. Patient can have the resting tremors or any kind of the tremors, right? Now there will be what? Severe condition that is called as what? Delirium tremens. This you are not going to forget. Delirium tremens, favorite topic for MCI. Along with this severe hallucination will be there. Maximum there will be visual hallucination. After that there can be auditory or tactile hallucination. Auditory or tactile hallucination, right? Auditory or tactile hallucination. Easy to understand? Right? Auditory or tactile hallucination. Very easy to understand, no? Remember here, delirium tremens is emergency. You have to treat the patient as soon as possible. If you are not going to treat the patient as soon as possible, patient can die. 20% mortality rate. How to treat the patient? Give the injection of benzodiazepine and vitamin B1. Give the injection of what? Benzodiazepine with vitamin B1. With vitamin B1. Benzodiazepine like lorazepam. And vitamin B1, thiamine, because in alcoholism there will be what? Deficiency of thiamine. Why we are giving this drug? Why to give vitamin B1? Because deficiency of vitamin B1 can lead to what? Wernicke's encephalopathy and Korsakoff psychosis. Very easy to understand. Now, how to treat? How to treat? Very, very important. Okay, chalo, fine. Now we are going to treat the patient. We are going to treat the patient. First of all, whenever you are getting a patient of alcoholism, first of all, you have to what? Detoxify. You have to what? Detoxify. Detoxification is needed. How you are going to detoxify the patient? Injection of benzodiazepine with vitamin B1. Vitamin B1 for 7 to 14 days. Okay, fine. Detoxification. Question is that, what is the benzodiazepine of choice? What is the benzodiazepine of choice? Chlordiazepoxide. Chlordiazepoxide. Chlordiazepoxide or diazepam. But these two drugs can be used only when the liver is healthy. Liver of patient is healthy. Remember here, very, very important, you should know, if liver function test is normal, then you can use chlordiazepoxide or diazepam. Why? Because these are long-acting drugs. For a chlordiazepoxide, half-life is 12 to 24 hours. For diazepam, half-life is 10 to 12 hours. So these are actually what? Long-acting drugs, no? So when liver is healthy, then only you can use. Otherwise, if liver function test is not healthy, then go with short-acting drugs. Lorazepam or oxazepam. These are short-acting drugs. Half-life is only 3 to 4 hours. 3 to 4 hours. Very, very important. Now, what is the most sensitive marker for alcoholism? Severe alcoholism. Can you answer me? If you have alcoholic patient, you are going to do what? Liver function test. You are going to check for AST, ALT, alkaline phosphate, right? GGT, mean corpuscular volume. Everything will be elevated. What is the most sensitive marker? CDT. Remember here, CDT. Carbohydrate deficit transferrin. Carbohydrate deficit transferrin. This is the most sensitive and most specific marker. Okay. One more formula we can use. If we know how much alcohol patient has consumed, we can calculate exact blood alcohol content. Widmark formula, right? Okay. There is a questionnaire system which we are using in psychiatry cage, because see, most of the alcoholic patient, if you ask him, hey, do you drink, how he will react? Hey, doctor, no, obviously no. After that he say, hey, I'm not your father, tell me the truth. After that he will say, hey, I'm doctor, tell me the truth, then all I can give you the complete treatment. Doctor, 8. So what does it mean? Most of the patients will lie. That's why we have to ask some question. Cage questionnaire. Cage. I'm asking, have you ever felt that you have to cut down on your drinking habit? Did people annoy you by objecting your drinking habit? Have you ever felt guilty about your drinking habit? Guilt, G for guilty. E. Have you ever taken the alcohol in the morning as an eye opener? It's an eye opener. If answer is yes, for more than 2 questions, 100% he is a severe case of alcoholic, okay, severe case of alcoholism, and he needs proper treatment. Cage questionnaire. Please remember some other questionnaire system, SCOF. Where do we use a SCOF questionnaire? Eating disorder. Where do we use MCHAT questionnaire? MCHAT questionnaire. Autism. Okay, very good, right? Now, deficiency of vitamin B1 can lead to Wernicke's and Korsakoff. Keep in mind, Wernicke's and Korsakoff, very important topic, very important. Remember here, when I talk about Wernicke's encephalopathy and Korsakoff syndrome, Wernicke's is always acute. Korsakoff is long-term, chronic. So in Wernicke's encephalopathy, what is happening is symptoms will be what? GOA. Global confusion means maximum level of confusion. Patient cannot recall his name also. O for ophthalmoplegia. A for ataxia. A for ataxia. Okay, A for ataxia. Now remember here, go for, see here, G for what? Global confusion means what? Maximum level of confusion. Ophthalmoplegia, there will be involvement of 6th cranial nerve. After that, second is third. Okay. So there can be involvement of what? 6th cranial nerve, abducens nerve. Patient can have what? Horizontal nystagmus, ataxia. How to treat? You have to give injection of vitamin B1, injection of thiamine, 250 milligram. Question is that, if you are giving injection, what is the earliest to recover? Ophthalmoplegia. Okay. Even after complete treatment of Wernicke's encephalopathy, ophthalmoplegia and ataxia will be there. Residual. And what about the Korsakoff syndrome? Korsakoff syndrome, long standing, right now? Long standing. Korsakoff. There will be what? Confabulation. What is the meaning of confabulation? Making false stories to fill the memory gap. So basically, Korsakoff or Wernicke's, yes, these are what? Memory problem, amnestic problem, right? A neurological problem. Remember, Wernicke's and Korsakoff, very important. One more disorder is there, that is called a what? Marcia-Fava-Bignami disorder. Now, heroin, opioid. Here we are going to talk about what? Morphine, codeine, right? Now, morphine and codeine, these are what? Natural, right? These are natural. Now we are going to learn what? Heroin, synthetic. Heroin is what? DM, diacetyl morphine. Diacetyl morphine, heroin. Okay. See here, very important. Suppose if a person Heroin is what? Actually what? Opioid. Opioid. From which plant it will be harvested? Poppy plant. What are the street names of heroin? Smack or brown sugar? Smack or brown sugar? Brown sugar. Okay, fine. Now, what are the symptoms of opioid poisoning? What are the symptoms of opioid poisoning? Remember CPR. If patient is in coma or immobile. Okay, no? After P for pinpoint pupil. Pinpoint pupil. Or you can say meiosis and respiratory depression. Respiratory depression. 100% this is a case of what? Opioid poisoning. Opioid poisoning. How to treat? What is the antidote of opioid poisoning? Antidote is what? Naloxone. IV injection. Short term, right now, short half-life, only 30 minutes. For relapse prevention, we have to give what? Naltrexone. Naltrexone for relapse prevention. Half-life is 96 hours. For withdrawal symptoms, we can give what? Methadone. Methadone as a substitute, right? Methadone. Easy to understand? All these are one-liner questions you can solve. Now, when a person was abusing opioid for longer duration, if he is going to stop, what will be the withdrawal symptoms? Remember, only flu-like symptoms. Very, very important. Flu-like symptoms like running nose, running eyes, rhinorrhea, lacrimation, sweating. Patient can have diarrhea also, yawning and low erection. I have taught you in heroin overdose, there will be meiosis, pinpoint pupil. But heroin withdrawal, there will be mydriasis. There will be what? Mydriasis. Very easy to understand. Related to heroin, you have to learn all these points. What about this one? Answer, please. Yes, this is a case of what? Flashback phenomena. This is a case of what? This is a case of flashback phenomena. Remember, a flashback in PTSD is what? That is horrible. Flashback in PTSD is what? Horrible. Nightmare and a flashback. Here, what is happening here? Whenever I talk about, LSD and cannabis. LSD and cannabis. Remember here, see here, what is the active ingredient of cannabis? THC, tetrahydrocannabinol, which is having very high fat solubility. So see here, whenever you are abusing cannabis, whenever you are abusing cannabis, remember here, whenever you are using cannabis, there will be deposition of tetrahydrocannabinol in fat. After 2 days, even if you are not abusing, there will be slow release of THC in your blood. And even in the absence of using it, you will start enjoying it, right? Now, this is called as what? Flashback phenomena. In PTSD, flashback phenomena is horrible. In cannabis abuse, it is pleasurable flashback phenomena, right? Flashback phenomena, right? Very easy to understand. Because of cannabis, yes, psychotic symptoms can occur. Plant of cannabis is hemp plant. So, psychotic symptom because of hemp is called as what? Hemp insanity. Flashback phenomena. Running amok means what? A person who was abusing cannabis means what? Actually, bhang, ganja, hashish, charas, hash oil, right? So see, remember here, running amok means what? If a person was abusing bhang for last many years, one day he will start having this kind, maybe even if he has stopped it. Someday what will happen here? He can develop a disease of mind where he will become very aggressive. He will be having a rage. He will start running on the road. He can hurt anyone. He can murder also. It is called as what? Running amok. Running amok. For this, will there be punishment or not? Can you answer me? No punishment as per IPC number 84. Why? Because this is considered as a disease of mind. He does not understand the consequences. He does not understand what he is doing, right? So running amok is not a punishable offense. Keep in mind. Keep in mind, right? Okay, fine. Easy to understand? Now, what will be the symptoms after abusing the cannabis? How will you understand that a person has consumed bhang or cannabis? How will you understand that? What will be the symptoms? What will be the symptoms? First of all, remember red eyes, increased appetite. Suppose if a person is having red conjunctiva, red eyes, and when he is entering the house and alone he can eat, 4-5 plate biryani, right? Apart from that, symptoms like, symptoms like floating in the sky, right? Floating in the sky, right? Symptoms like depersonalization, derealization. Patient will say what? I can hear light, I can watch music, synesthesia, reflex hallucination. All this basically a dream-like state in cannabis, bhang, right? Bhang. Sometimes there can be bad trip also. Bad trip. Bad trip means what? Suddenly patient will be having what? See, suddenly patient will be having what? See, when he will be enjoying, no, suddenly he will have this kind of, like feeling of fear, feeling of severe fear. He will be what? He will be so much scared. This is called a bad trip. Bad trip. So almost all the symptoms of cannabis will be same in LSD also. All hallucinogens like LSD, like, psilocybin, MDMA, phencyclidine, ketamine, right? Okay, fine. Motivational syndrome means what? Patient or person does not want to do anything. How to treat? In the beginning, benzodiazepine, after that, psychotherapy. Cocaine. Cocaine, remember here, cocaine is very, very important. First of all, cocaine will cause what? Severe vasoconstriction. Severe vasoconstriction. Cocaine is used as what? And cocaine is used what? As local anesthesia also, vasoconstriction. Okay. So remember, cocaine can cause, when a person is going to sniff, so do you think there can be nasal septal perforation? Nasal septal perforation? Yes, nasal septal perforation, right? Or nasal septal perforation. When a person is going to take it orally, so do you think there can be severe vasoconstriction? Because of vasoconstriction, there will be ischemia, lack of blood supply. After that, there can be necrosis, gangrene also. Na? So black. Do you think there can be black color of tongue also? Yes, jet black pigmentation of tongue. Okay, fine. Very, very easy to understand. So basically vasoconstriction is there, no peripheral arteries, even central arteries are also involved. So there is a risk of heart attack, myocardial infarction. There is a risk of CES, so lack of blood supply to the brain, also hypoxia and all, ischemia. So see here, patient can have, patient will be having what? Patient can have seizure also. For seizure, cocaine can cause seizure, amphetamine can cause seizure, okay? Remember here, cocaine and amphetamine. These are a stimulant drug. These are a stimulant. Okay. Amphetamine drug is used to increase the performance. Okay. Cocaine is a drug where patient can have suicidal tendency also. Right now, suicidal tendency also. And obviously what? See here, remember here. So here patient can have what? See, remember. Yes, see here. So because of a stimulation of dopamine, norepinephrine, a patient can have what? Now see, understand psychotic symptoms. So a patient can have what? Feeling like some insects under the skin. That is called what? Tactile hallucination. See, remember here, I have taught you tactile hallucination, very, very important. Also called as formication magnans phenomenon. All these points are important. Now last is what? Tobacco here. So tobacco means what? Nicotine. It is going to stimulate dopamine and acetylcholine. If a person is going to stop after smoking, you have good attention, good concentration, good judgment power, right? After stopping, lack of attention, lack of concentration, lack of judgment power, dullness. How to help the patient? Nicotine replacement therapy. You can give gums, patches, inhalers, spray. Two medicine you have to keep in mind, bupropion and varenicline. See, this is actually alpha 4 beta 2 agonist. Out of bupropion and varenicline is better. Two anti-smoking drug always you have to keep in mind. Always you have to keep in mind. Varenicline and bupropion. Bupropion is what? NDRI. Dopamine is getting here. Now dopamine is there. So patient will get dopamine. He will feel happy. Now last topic here, very small topic. The learning theory. We learn something with the help of classical conditioning and operant conditioning. Whenever we are going to pair up something, we can increase or decrease the behavior, like dog and bell experiment, right? Classical conditioning. Operant conditioning. So classical conditioning, we should know about aversion therapy. Aversion therapy. Aversion therapy. Okay, aversion therapy. Okay, aversion therapy. Classical conditioning. Aversion therapy, this is especially for alcoholism and paraphilia. Paraphilia. Here, alcoholism, how? See, in alcoholism, first of all, we have detoxified the patient. We have what? We have done what? Detoxification of the patient. But after that, maintenance of abstinence is also important. No. So see, this topic I forgot there. So here we can cover. Remember here, maintenance of abstinence, we can give what? Deterrent drug. We can give what? Deterrent drug like disulfiram. Disulfiram drug. Disulfiram. I hope you remember the metabolism of alcohol. Alcohol will be converted to acetaldehyde. Further, it will be converted into acetate. And finally, it will be converted into carbon dioxide and water. Do you think some enzymes are playing the role here? Here, alcohol dehydrogenase. Here, aldehyde dehydrogenase. Remember, I have taught you a drug, fomepizole, no? Fomepizole. This blocks alcohol dehydrogenase. And disulfiram, remember, disulfiram, very, very important. This blocks what? This blocks acetaldehyde or aldehyde dehydrogenase. Okay, fine. Remember, when I already have completed detoxification, I have told my patient, don't drink anymore. Okay, fine, he is motivated. What happened after 1 month? His old friend came. And now he went for alcohol. Okay. So now he is already on disulfiram. Remember here, disulfiram drug, this is going to block this enzyme completely. Irreversible, no? Completely. Now there will be what? Whenever he is going to drink the alcohol, no, now there will be no conversion of acetaldehyde to acetate to carbon dioxide and water. There will be accumulation of acetaldehyde. Acetaldehyde is an itching agent which works on histaminic and serotonin. This is going to increase all these. So remember here, even after this, when patient is going to take alcohol, acetaldehyde accumulation can cause what? See here, whenever he wants to have pleasure, he is already on disulfiram. Disulfiram will give him punishment. Pairing up, classical conditioning, aversion therapy. Now when he is going to drink, though, there will be accumulation of acetaldehyde. Patient will have a red rashes on his body, nausea, vomiting, low BP. Okay, low BP, patient can go into shock. Patient can have seizure also, and patient can die also. This is called a disulfiram ethanol reaction. So basically, with the punishment, when pleasure will be given, and now patient will hate the alcohol. This is called a deterrent, right? No, deterrent. You should also know about anti-craving drugs like acamprosate, naltrexone, and all, right? Okay, fine. Now, operant conditioning means what? As per the result, we'll learn some behaviors. Like, if there will be, suppose if you ask a child that I will give you 1 chocolate if you study for 1 hour. Child will say what? I will study for 2 hours. Give me 2 chocolates. You can increase the behavior. This is called you can increase the behavior by giving a reward. This is called as what? See, this is called as what? Positive reinforcement. That's why in medical colleges, in all the colleges, rewards are being given, medal, Okay, World Cup trophy, certificates, right now. So see here, medal, reward, and all these are what positive reinforcement, so that other students should also work very, very hard. Positive reinforcement, negative reinforcement, because of the fear of your father if you are studying more, right now. So that is called a negative reinforcement. In these two, behavior will be increasing, frequency will be increasing. Positive reinforcement for the reward, negative reinforcement for the fear of something. Punishment, if a child is using foul language, slap him. After the child will not be using foul language. Punishment will decrease the behavior. Extinction, lack of motivation. A hard-working intern, no one has appreciated her. She has stopped working. That is called as extinction. Okay? In this manner, we have completed almost entire psychiatry. I think I have taken so much time, actually 6.5 hours I have taken, right? We started by 7:15. Now it is 1:35. Okay, it's okay. But see, chalo, theek hai, fine. Theek hai. So thank you so much. But you know how much I have taught you, most of the questions you will be able to solve. I expect approximately 10 questions in psychiatry. You can solve all the questions. All right. Chalo then, thank you so much. I hope. Right, very easy to understand. Right. Chalo, theek hai. I'm glad to see you people. Doctor, spirituality, yes, more than enough to pass FMG. Yes. See here, PDF of this file is available on the Telegram group. Annotated PDF will also be given. Okay. So then I wish you all the best. Thank you so much wherever you are. Stay happy, stay healthy, and God bless you all. Thank you so much. Bye-bye. Good night.